One, we're so happy to see all of you, and we thank you for giving us a little point of privilege as we've gone forward in time. Oh, but I think you all look well to say we lost an hour of sleep. I'm happy that we're here today on day 3 of our symposium. I would like you to know that please stay connected with us, meaning after this week, when you receive emails from us, please open them because you will receive additional links to complete your survey. The survey link that you received today is ideal for those of you that have been with us each day. But if you haven't, but I think everybody in the room has been here with us each day, we will send out an additional link for you to fill out the day that you attended. That's one. And then the second, and that's for the speaker. And then the second link that you will also receive will be what we call our gap analysis, which you will tell us before that presentation, I knew this much. After the presentation, I now know this much. And yes, I will or will not use this in my practice. That one is a little bit more in depth than the speaker evaluation. And now this is very important. You get to tell us what you would like to hear about in the future, so that as we're planning additional CPE programs throughout the 21-22 cycle and the rest of this cycle, we'll know exactly what you want to hear about, right? So please look out for those and please complete them. Without further ado, you will hear from the moderator for the day, Dr. Southers, and she'll come forward and introduce our speaker of the hour. Thank you.
Okay, good morning, everyone. I'm so glad that everybody changed their clocks. I did mine last night because I did not want to see that this morning. Well, I'm very, very, very happy to introduce Dr. Jamie Young, a native of Savannah, Georgia. And she's a 2017 graduate of the FAMU College of Pharmacy. After graduating, she completed a postgraduate year 1 pharmacy practice residency at St. Vincent's Medical Center in Jacksonville, Florida. She went on to be the first and only family medicine ambulatory care pharmacy fellow in the St. Vincent's Family Medicine Residency Program, a physician residency training program. Dr. Young currently works as an ambulatory care pharmacist in the pharmacy specialist in an outpatient internal medicine setting at St. Vincent's Comprehensive Care Clinic. She's also a consultant pharmacist for the Sheriff's Office and Department of Juvenile Justice in 3 counties in Northeast Florida. Since graduating, she has become a board-certified pharmacotherapy specialist, recognized as an Academy of HIV pharmacist, and currently working on becoming a certified diabetes educator. I don't know where you find all that time, Dr. Young, but not only does she find the time, but she is here to give a fantastic presentation. So welcome, Dr. Young.
All right, thank you for that wonderful introduction. I was listening and I was like, I don't know if that's me or not. But good morning, everyone. How are you doing this morning? Oh, y'all sound like y'all lost the hour last night. Good morning. All right, so we are going to jump in and get started. We're going to talk about the dangers of vaping today. But before we get started, I just want to say that I have nothing to disclose concerning this presentation. Throughout the course of the presentation, I will use brand names, but that's only for learning purposes. I do not have any affiliations with the companies that I will be using those brand names for. By the end of the presentation, our pharmacy technicians should be able to recognize vaping devices and identify differences in devices, recognize common ingredients in vaping liquids, summarize the most recent health updates concerning vaping, identify the role of the pharmacy technician in smoking cessation, and our pharmacists should be able to recognize and name various vaping devices, list some common ingredients found in vaping liquid, describe the most current vaping concerns affecting the community, discuss CDC guidelines concerning EVALI, and identify the pharmacist's role in smoking cessation. So we're going to jump right in and get started. So what exactly is vaping? Vaping is a blanket term that we use to refer to any type of battery-operated device that's used to deliver nicotine or cannabinoids. And we use the term vaping because of the quote-unquote vapor that is produced from using these products. So as we all have seen, some of the users, it will form this big cloud, and that was one of the big claim to fames with vaping when it first came out, was like, oh, it's just vapor, it's just water. But as we do more research, we come to find that it is actually not just vapor, that it is a aerosol. And it's important to make that distinction between it, as we will find out a little bit later that the aerosol component of it is what actually makes this dangerous for both the users and for those who are around them. And so throughout the presentation, I will be interchanging between vaping, e-cigarette use, vapes, because these devices come under several different names. But it's important for us as pharmacists and as pharmacy technicians to know the various names of the devices, because sometimes you will ask the patient, do you use an e-cigarette? And they will say no. Do you vape? Oh, yes, I do vape. So sometimes when we are asking these questions, we have to be a little bit more specific to make sure that the patients do know what we are talking about. And some of the common names that we will see are e-hookahs, e-cigs, which are short for the e-cigarettes, vapes, pods, mods, tanks, and vape pens. And I have a few pictures up there, but as we go throughout the presentation, I have quite a few pictures because there are hundreds and thousands of these devices and everyone looks a little bit different. So we want to make sure that we are able to identify them as much as possible. And when we talk to some adults, some of the common reasons that they will say that they vape is for smoking cessation, but this is actually not FDA approved for smoking cessation, but that is one of the things that they use it for. Perceived safety, so they'll say, oh, well, I'm switching because it's safer than a cigarette. And we'll talk a little bit about that later as well. Is vaping actually safer than cigarettes? And most patients who will do it or switch over for safety, they end up doing both. They may smoke fewer cigarettes, but they are also increasing their use of vaping. It's relatively inexpensive. So last night I stopped on Lake Bradford to get me a tropical Sprite, and I found at that particular location, they had one of the vape products for 99 cents. And so I asked the cashier, I was like, hey, so is that the device that's 99 cents or is it the pod that's 99 cents? She was like, I'm not sure. So she handed it to me and I looked at it and it was actual device that was for 99 cents, which we know is a lot cheaper than a pack of cigarettes, because when I was looking at the cost of the pack of cigarettes here, it ranged between about $5.50 to $7. So being able to get a device for 99 cents is definitely a whole lot cheaper. There's tons of varieties. You have some French toast, cherry, watermelon, so patients or users really enjoy that. You don't get the same scent of a combustible cigarette, and they're concealables. They come in very small devices that they can hide in their pocket and no one knows that they're using these devices. So lately we've heard a lot about e-cigarettes in the news, but they actually have been around for about 14 years in the United States. And the idea came about a whole lot longer ago. In 1930, you had a gentleman by the name of Mr. Robinson who came up with the idea of the e-cigarette. He had a patent for it, but there's no evidence that the actual e-cigarette was manufactured. In 1965, though, we had another gentleman by the name of Herbert A. Gilbert, and so he is actually coined to be the father of the modern-day e-cigarette. There were definitely some prototypes that he came up with, but it was a little bit before his time because smoking was still popular, so you didn't really have a need for a e-cigarette. But in 2003, we had a gentleman in Hong Kong by the name of Han Lick who actually made the e-cigarettes that we know today and that are available on the market. Can anybody guess what his profession was? He was a pharmacist. His father actually had passed away from lung cancer. He himself was a smoker, and he came up with this device. I think what also helped to make it mainstream was that he worked for a pharmaceutical company. And so they helped get that off of the ground. E-cigarettes arrived in Europe after Asia, and by 2006, we start to see documentation of e-cigarettes coming into the U.S., and by 2007, it was available on the market to consumers. In the shorter period of time, it has definitely evolved a whole lot. You can see in 2007, it looked similar to a cigarette, and that kind of was the idea. But as we have progressed closer to 2020, they look very different. 2015 looks like a flash drive. And so that was the popularity of it, and that is probably one of the most popular devices to this day, and that is a device that our adolescents definitely love to use. It is called a Juul, and we'll talk about the Juuls a little bit more as we go about it. But even though those e-cigarettes look very different, they all have four main components. And the first component is going to be the atomizer, and the atomizer is the heating component of the e-cigarette. It usually contains a coil, and it's what heats the e-juice or the vape juice to form the vapor, or vapor as they call it, but it's actually the aerosol. The battery component, so that's what makes it electric. So it definitely has to have a battery, but you want to make sure that you warn the users to be careful with the battery because it can be explosive. There are some reports of users getting hurt because they try to vape and charge the battery at the same time, and it just does not work out very well. The cartridges, those are what contain the vape juice. And the cartridges can also sometimes contain the atomizer, the heating component for it. And then you have the mouthpiece. And the mouthpiece may be called something different in each device, but of course it does the same thing in each one. It allows the users to be able to inhale the substance. And so we're going to talk a little bit about the various generations, and so provide a few more pictures for you guys to be able to see exactly what these devices look like. This was the first device that came to the market in 2007. They're called Cigalites, and that is because they look like a cigarette. And that was the whole idea of those who were cigarette smokers. They wanted to use the e-cigarettes, and they wanted the e-cigarettes to look just like the cigarette. So a part of it at the end, the gray tip, whenever they use the device, red to mimic the burning of a cigarette. They're disposable. They're pretty inexpensive. You can buy them, use them for about to 300 puffs, throw them away, and you get new ones. But after that, it got a little bit more advanced about 2 years later, and it came out with the rechargeable batteries so that users can use it over and over again. Also, refillable cartridges came about, so you didn't have to throw it away, the cartridges away either, and they can start to use whatever substance and mix the substances that they wanted. The reason that it says non-modifiable up there is because the wattage that the battery pins come in, that is what you have to use. The coil that comes with it, you cannot modify those. The pin is as is. The only thing that is modifiable is what you can put inside of the cartridges. And the battery-operated pens are actually very popular among those who use marijuana or vape marijuana. So the third generations are our mods and our tanks, and these are popular among those users who vape as a hobby. So they are able to take the e-cigarette apart. They can change the wattage for it. They can change the coils, and based on how they manipulate these devices, they have a very customized experience. If they want a bigger cloud, they're able to make a bigger cloud. For those, if they want a stronger hit, they're able to do that as well. And these are popular. However, they're a little bit more bulky. So for those who want to conceal them, this is usually not the device for them. These are for those particular ones who know exactly what they're looking for in their vaping device or how to make what they are looking for. So the fourth generation and the last generation, the newest of all of our e-cigarettes are the pods. And the pods come in two different systems. You have your pods, and then you have your pod mods, which also allow you to modify the pods. And very similar, it comes pre-filled or refillable. These are the ones where the Juul was the first to come out in 2015. And the Juul still continues, as I mentioned before, to be one of the most popular, especially amongst our adolescents, because it looks like a flash drive. I was watching a video where a teacher said that she wished she had known a little bit more about these devices because a student left one in her class. And when the student left it in her class, of course, the student rushes back to the class to get their e-cigarette. The teacher finds it and happily gives it back to the student. Why? Because she didn't know what the device was. So she thought it was a flash drive that the student just left their flash drive, and why not give it back to the student? So that's one of the things that as healthcare professionals, as parents, as educators, we want to make sure that we are aware of what these devices look like, so that hopefully we can decrease the use in our young teens and adolescents. And this device also became popular because it changes the way or the amount of nicotine that is able to be inhaled. The previous devices, they give off or you can inhale nicotine from them, but nowhere near the amount you can get from the pods, which is why they are very popular. There are thousands and thousands of devices by different names. You can order them offline, but I just listed a few of these. These are on the top 100 best vapes to use list. So Juul, of course, is number one. The other ones are not in order, but it was just some of the common ones I wanted you to be aware of. Blue, Enjoy, Fix, Fuse, V2 Cigs, Smoke 51, Red Dragon, Mig Cigs, Vin Cigs, and then V4L is Vapes for Life. So, yes, they come in various names. And so for our first assessment question, just to make sure everybody's still awake, which of the following vape devices can be modified for customized vaping? A, mods, B, pods, C, tanks, or D, all of the above? Anybody have any idea? Is B? Okay, so I've heard a variety of them. So it's actually D. So mods and tanks are kind of synonymous. They are very similar, same device. And then pods, remember I was saying it comes in two forms. It's either pods or pod mods. So the pod mods are the ones that are able to be modified. What is the name of this vaping device? A, a Cigulite, B, vape pen, C, a mod, or D, a pod? A, very good. It is a Cigulite, and it looks like a cigarette. All right, so what is in the cloud? So this has been a big controversy, as I alluded to before. People say it's just water. But as we are doing more research, we're finding out that it is a little bit more than water. But one of the reasons that e-cigs are considered to be safer than cigarettes, not necessarily that it has been proven, but from those users who are like, I think it's better, is because when they look at the ingredients, really they only see 4 ingredients unless they are using it for marijuana. Then there's 2. You'll have your CBD and your THC component. But for those who are using the nicotine, there's only 4. You have your nicotine, you have propylene glycol, you have glycerol, and so for those, they come in various ratios, and then you have the flavoring. And so diacetyl is actually one of the most common flavoring agents that you'll see that is associated with the e-liquids. And so the vape cloud has a little bit more than what the ingredients say that it has. So actually, even though we only see 4 ingredients listed on the package, there are some chemicals that are in there. Early on, the FDA did not require that companies to report what was inside of the vape ingredients, but in 2016 now they have to actually report. So it's being a little bit more regulated. However, you just have to report it. So no one is actually making sure that the what's inside of it is actually what they say is inside of it. So a lot of those chemicals, of course, they are not going to report. So there are a lot of carcinogens that are located within the vape cloud. You have some heavy metals that are in there in addition to the 4 ingredients that we talked about. But also the issue with the vape cloud, why there are some chemicals that are found in them that are not found in the ingredients, is because once you actually heat the chemicals, a chemical reaction happens and it starts to produce other harmful chemicals. So no, formaldehyde is not one of the ingredients that's found in the e-liquid, but once you heat these ingredients, formaldehyde is one of them that are produced. So that is an issue, especially when they start to modify and to heat these liquids at high intended degrees. And so that to hacking and dripping. And that is one of the things. So hacking refers to any type of post-market modifications. And hacking is in any device that is not a modifiable device. So they're not meant to be refilled, and a lot of times the users, they are actually refilling them, and the substance that they are refilling them with, they tend to buy offline, or they're making their own substance, and that poses issues because we're not really aware of how these chemicals will act when they are heated. So dripping is when you hack a modifiable device, and actually you are causing the substance to drip directly onto the heating device. And when you do that, it actually causes more exposure to the toxins and as well as the substance. And so the higher the chemicals are heated, the more harmful they are for the user. And so we have our good friend nicotine that we learned a lot about through cigarettes. And so nicotine, of course, is the same addictive chemical, and it is in 99% of e-liquids. Even for those that say that they are nicotine free, when the CDC did a study, every single, or not every single one, I'm sorry, but 99% of the e-juices that they tested had nicotine in them. And so nicotine, it mimics acetylcholine in our body, and it actually causes a decrease in the acetylcholine production, which is an issue because now we need increased amounts of nicotine to be able to function normally. Nicotine also activates the reward system in our brain, and it causes the release of dopamine. So the other areas besides in our brain where nicotine works is that it blunts the release of insulin from our pancreas. It quickly distributes to the brain and the placenta, and so that is why we want to make sure that we are telling the users who are pregnant, please do not vape. It is not a safer option to smoking cigarettes in pregnancy. The nicotine can still get to the placenta as well as it goes to body fluids to include breast milk. So if they are breastfeeding, they should not be vaping. Nicotine has about a 2-hour half-life. And in most patients, we will not know this, but in case if we do have the information for those who are 2A6 slow metabolizers, they have a better chance at stopping smoking and not being dependent on nicotine, as opposed to those who are 2A6 fast metabolizers who there's an increased likelihood that they will be lifelong users. And so for the 4th generation, those for our pods and our pod mods, remember I said that those have a lot more nicotine than our earlier devices. And the reason being is they came out with nicotine salts for these devices. And they're more acidic than the free-base nicotine that is found within combustible cigarettes and in generations 1 through 3. And it allows more nicotine to be inhaled, and the user does not get that sharp throat irritation that they generally get. So the 4th generations contain at least twice as much as a pack of cigarettes. Yeah. It depends on how often that they vape. Most pods are about 200 puffs. So a pack of cigarettes contains 20 cigarettes. And unfortunately, I don't know, or I guess fortunately, I don't know how long it takes to go through a pack of cigarettes, but it does go through the person. So I would say, if you look at 200 cigarettes and 20 cigarettes and 200 puffs, then you kind of look at them to be equivalent. And these pods have a lot more. And further, as we go further, I will actually show between like the 4 most popular ones and how much nicotine that they have in them. Right. Exactly. And then that's part of the concealable part of it as well, because let's say that you're in an office. If you light a cigarette, you're able to smell it. But for these devices, you can kind of turn to the side, take a puff. And some of them you will get a sweet smell. So I'm not going to say that there is absolutely no smell to it. But, if you walk past somebody's office and it smells like cherries, like, oh, maybe they lit a candle. Maybe they sprayed something, so you can get away with it a lot more than you can, with the cigarette. And actually, I was watching, don't hold it against me. I was watching a Grey's Anatomy episode, and that was one of the things where the father did not know that his son was vaping, because he said every morning he smelled French toast. And he didn't know where the smell was coming from. But it's morning time, you don't really know, and you're not paying attention. So it is a lot easier to puff and to do it in the presence of others without them knowing that you're actually inhaling nicotine. And so to talk about the bases a little bit, these bases are safe. But they are safe for their intended use. And inhalation is actually not their intended use. And so that is why they cause issues. So propylene glycol is used in several products that we see all the time, such as our foods, medications, cosmetics. The FDA says that as long as you use it in those things, that it is a safe product. But propylene glycol is also used in smoke and fog machines. So when we go to concerts and, the smoke machine is going off everywhere, but they can be an irritant. So if you've ever been to a concert and you've sat like front row and the smoke machine is blowing in your face and your eyes begin to water a little bit, that is actually from this particular product. And so it can cause those same effects, both in users and for those who are around users. And it has been linked to childhood asthma. For our glycerol, or our vegetable glycerin, it too is found in foods and in some of our cosmetic products, and it is safe for ingestion, safe for topical, but not safe for inhalation. And actually, that is one of the ingredients that when it's heated, it produces a chemical that becomes harmful to our lungs. And I think that that's where users become a little confused, because they're like, vaping is safe because all of these ingredients are FDA indicated. But yes, they're FDA indicated for its intended use and not for it to be vaped. Has anyone ever heard of popcorn lungs? No. So one person. So what it is, bronchiolitis obliterans, it's the inflammation of the bronchioles, and so it causes such scarring that it blocks the airways, and it is a condition that is not curable. So all we can really do is just treat the side effects of it. And it's called popcorn lungs because when it first came about, they were not sure where it was coming from. This condition, you will see it in those who have autoimmune diseases, but you had healthy individuals who are working in a factory, no autoimmune diseases, and all of a sudden they have this extensive scarring in their lungs. So what actually was discovered is that diacetyl, one of the popular flavorings that's found inside of vapes, was causing this issue. And that is one of the other things of why even though these chemicals are considered to be safe, that when we inhale them, they cause very, very different side effects. So when we are talking to our patients and we're counseling them, this is pretty much a simple breakdown to explain why vaping can be harmful. And so one of the main reasons, as we discussed, highly addictive, because we know that nicotine is addictive. Some of the things that we'll discuss a little bit later is it's harmful in brain development for adolescents. We talked about it's toxic to pregnant women, so we definitely don't want to use it. We know that it causes the lung effects. So that's going to be one of the major things, lung injury. Unknown chemicals, so we are not sure what is inside of the vape juices, as well as we know that they cause many chemicals based on to the degree in which they are heated, as well as I mentioned earlier, that these can be explosive, and so they can burn our patients and cause some very bad skin conditions depending on how it explodes and in what area it affects. So we've kind of just reviewed about the user, but it also, just like smoking, there's secondhand smoke. And we want to make sure that we are telling those who are using that please don't use them around other people, because these same harmful chemicals that are released in the vape cloud, those who are around them will be able to inhale some of those chemicals and cause some of the lung injury that are associated with the users. Vaping in 19 states has been added for smoke-free environments. In Florida, that includes users should not vape in restaurants, in bars, and non-hospitality workplaces. And then the other one that I think we often don't really talk about, or it doesn't get as much attention as it should, is the third-hand smoke. So have we ever went to someone's house, and even though they haven't been home for a week, it smells like cigarette smoke? That is the same thing, but as I said, you don't get the same smell when you're vaping. So if you don't smell anything, or you think it's just an air freshener, then I think that poses probably a bigger harm than for those that when you walk in their house, you know that they're a cigarette smoker. Because these chemicals, they get trapped inside of the rugs, get trapped inside of furniture, and we touch these particular things and it can actually be absorbed through the skin. It's harmful for children because children touch things and then they put their hands in their mouth. Or they will go licking things that they shouldn't, as well as the same thing for pets. So to our next assessment question, which of the following is not an identified ingredient in e-liquid? A, THC, B, nicotine, C, diacetyl, or D, tar? D. Very good, very good. So the CDC has now determined that vaping is a public health epidemic. And the main reason is that youth are more likely than adults to use e-cigarettes. And that is a huge problem and something that we need to all strive to try to turn around. In 2018, there were 3.6 million middle school and high school students who reported that they had vaped in the past 30 days. When in a year's time, that number increased to over 5 million. So that is a lot of students that are actually using these products. And as I had said before, that 99% of these products have nicotine in them. So although they think they may be vaping just flavoring, they are 9 times out of 10, they're getting some nicotine. And this chart just kind of gives us a visual depiction. The one at the top, the bluish looking one, is our high schoolers. And as you can see, it's kind of making a steady increase, and it doesn't quite look like it's slowing down anytime soon. Here we're looking at the comparison of 2018 to 2019. If we look just at our high school or our 12th graders, 37.3% of high school students said that they vaped something in the past year. And so I thought that number was pretty high, but then when you look at 2019, that number increased to 40.6%. So we are definitely rapidly approaching almost half of our teens are at least trying vaping. And in a few slides, I'll talk about why our teens are, or why they have identified that they are vaping. And so we are not just vaping nicotine, we are vaping THC as well. And so this just shows us a comparison. Before we looked at what vaping was like over the year, or those students who reported vaping in the past year. This one looks at the students who reported vaping daily and then vaping in the past month. If we look again just at our 12th graders, 11.7% of them said that they vape daily. And when we look at the past month, that number increases to 25%. When we look at THC, it is not quite as high, but it's something that we still want to make sure that we are educating our young people not to do. For our 12th graders, that number is 3.5%, and for daily use, and when you go to the past month, that number is 14%. And of course, as you can see, the number increases as they go up in their grades. 8th grade is not high on either one of them. However, usually when you're in the 8th grade, you're like 12 or 13. So that is pretty young for them to be using either nicotine or THC containing products. So we want to make sure that we get to our young people as soon and as early as possible. And so just for comparison, is our nicotine use through vaping versus cigarette use. Depending on how you want to look at it, the cigarette use is declining. So that is a good thing. In 2018, 3.6% of 12th graders reported that they use cigarettes daily, and that number dropped to 2.4%. But as we saw, the number of teens who are vaping is significantly increased. Even when we look at the of 2.4% are smoking cigarettes daily, but 11.7% are vaping daily. So these adolescents are still getting nicotine, and that's something that we want to try to avoid. But there has been significant decrease from 2009 to 2019. For the 12th graders, almost 20% of 12th graders reported in the past month that they used cigarettes or that they smoked cigarettes, and that number has dropped all the way down to 5.7%. So that is a significant decrease and moving in the right direction for our cigarettes. Now we just have to reverse our vaping. And so the teens reported their reason for using vapes the most common is to experiment. With 41.7%, it was because it tastes good. And so that was one of the issues, that these companies were marketing the various flavors, and that is what a lot of the teens enjoyed. And that's what poses an issue, because flavored cigarettes are banned in the U.S., but we have all of these flavors that are available when it comes to vaping. And I thought it was pretty interesting that the lowest out of the reasons were that regular cigarette use was not permitted, and then to help quit with cigarettes. So the first couple more so has to do with association with the teen years, experimenting. Their friends are doing it, and because they think that it's something cool to do. So nicotine use in our adolescence. So of course, adolescent years are very important in brain development. And the reason that we don't want to use nicotine in our adolescence is because it changes the way that the synapses in the brain are formed. And that pretty much is harmful to the attention and the learning controls that are found within the brain. And of course, those are our important learning years. So we definitely want to make sure that our teens and our adolescents are not using it as well. Also, with nicotine use, it increases the risk of mood disorders and permanently lowers the impulse controls. And when teens, usually, especially when they're around like 13 to 17, they already don't make the best decisions. So we want to make sure that we are telling them, encouraging them not to use nicotine. And so this is the slide that I was referring to as far as the comparison of the pods versus the cigarettes. And it kind of puts it into perspective of why the 4th generation pods can be so dangerous. So on the far end, we have the 1 pack of cigarettes, but the Juul, the one that is the most popular, has twice as much nicotine as a pack of cigarettes. Fix has 75 or approximately 75 cigarettes contained in it. And over here, we have approximately 90 cigarettes, and that's just in one pod. And each pod contains 200 puffs. And so we say that 200 puffs is about equivalent to 1 pack of cigarettes. So if they are going through these pods the same way that, someone would go through a pack of cigarettes, or sometimes they're using more because, as Dr. Sampson was saying, it's more convenient, it's easier. You don't get that same smell. So we want to if we find any images like this, or you can use mine to share with our adolescents of why they should not be using nicotine, but why these products can be very, very harmful, because while they think they're safer than cigarettes, we are still getting even more nicotine than they would if they smoked cigarettes. And part of the other public health crisis is that it's an old problem that has taken on a new face. So when we see these are some of the old, or our cigarette companies, so some of the old ones from commercials that you would see when they were marketing cigarettes. Now it's not as popular, but you have all of these vapes that are being made by the same companies. So we want to make sure that we also emphasize that even though cigarette smoking is not popular anymore, and you really don't hear too much about the cigarette companies anymore, you hear a little bit, but not too much, the cigarette companies are still very relevant today. They have just kind of changed what they are marketing and what they are pushing. And so marijuana use in our adolescents, Dr. Hill did a great job yesterday making sure that we knew some of the things, the risks that were associated in addition to the benefits. And so marijuana is the second most commonly used drug amongst adolescents, the first being alcohol. And 9.2 million in 2017 reported that they had used marijuana within the previous 30 days, with 12 being the youngest age. And so marijuana can have some of the similar effects on the brain with affecting attention and learning. So we want to make sure that these patients or these users are not using them, especially from the street, because we aren't sure the source of where this marijuana is coming from, what all it contains in it. And it can increase the risk for increased psychiatric effects. So it can increase schizophrenia, and we definitely don't want to do that. In our teens who are between 12 and 17, frequent marijuana use can also increase the likelihood that they go on to use and abuse opioids. And so what this slide really represents is that although we have these devices, we see them. I've talked a lot about nicotine use in these devices. It's hard to decipher which device that adolescents is using for nicotine and which one they are using for marijuana, because they all look the same. Here, we have 3 different companies. The first 2 companies represent what the devices look like if you're vaping nicotine, and the third is what the device looks like if you are vaping marijuana. And they all look the same. They all look the same, so it is very hard to be able to decipher. Juul and Prax actually used to be the same company, and they split. Prax Air went on to just do marijuana, and Juul stayed in the nicotine industry. And I think this is one of the ones why it's important to kind of get a feel on some of the names of these devices, because they look the same. So if you see that it's a Juul, for the most part, 9 times out of 10, then they're vaping nicotine, not unless they hack the device, versus if you see the name Prax, then you know that they are vaping marijuana. And so this is just to reiterate some of the appeal of vaping devices to teens and to the youth, is because family and friends are doing it. They get to see them do it. They want to do it. They want to the flavors. Like I said, there are thousands of flavors on the internet. There are thousands of flavors available in the stores. Social media. So there was at one point a big social media campaign for vaping, where they were pushing the use of vaping as being cool, and all of the teens are doing it. And then again, design is very discreet. So if you have a parent who is not up on the latest things, they will have no idea of what the device is. But we as healthcare professionals, we definitely need to help combat the use of vaping and nicotine and marijuana products. And so one of the first things is support state and local policy. So in some areas, you can buy these devices at 18, but a lot of areas are pushing the age up to 21 years of age to be able to purchase. Screen for use, depending on the setting that you are in, especially if you're in community and you get a lot of access to some of the young teens. They may just be coming to buy, something different, but you see them. Just ask a few quick questions and then counsel them really quickly. If you are in the family medicine setting or ambulatory care setting, one of the things, and you have a lot of access with adolescents, we want to make sure that we are asking the right questions and not just asking, are they smoking or using nicotine products, but actually calling it by name. Because some of them will not say that they're vaping. They'll say that they're juuling, because Juul has become so popular until that's the only thing that they know and what they call it. Like, no, I don't vape. No, I don't use e-cigarettes. I Juul. Education. So making sure that we educate them of the harms, as well as that we are educating ourselves to stay on top of all of the new latest and greatest products that are becoming available. Be an example. So one of that, or I guess an example of that would be, even though as adults we can make our own decisions if we want to smoke cigarettes, if we want to vape ourselves, that is definitely our choice. But it's hard for us to tell our young people not to do it if they see us doing it. So I know one of the things that my mom used to always say is, do as I say and not as I do. And so sometimes that is definitely hard for the younger people to comprehend. So if we could just try not to do it in front of them, so that it encourages them to not do it. And then social media, just combat some of the things on social media where we will see videos of people vaping, making sure that we are going on social media and also sharing the harms of vaping. And so Juul, they came out with a few preventative measures to kind of decrease youth use by limiting access. So they have retail access control standards. So for all of the retail carriers of their product, they have certain things that they must adhere to in order to continue to carry those products, making sure that there is an online age verification, that if the user is not 21 years of age, a lot of times you cannot even access these websites anymore. Track and trace, making sure that they know where their products go. Tobacco 21 is the same thing, trying to encourage that you have to be 21 years of age to purchase these products, and having secret shoppers to come in to make sure that their rules are being enforced. Also, making sure that they are limiting the amount of flavors that are available. They left social media, as well as they suspended all advertising for their products. However, even in these efforts, some of the stores are still advertising them as well. I am located in Jacksonville, and at the neighborhood store, when I went the other day, the price of the Juul had dropped down to $9, and they had a huge poster that was still outside. So of course, that is still appealing to some of the young people, even though it's not particularly targeting them. So our next assessment question: after the implementation of strategies to decrease e-cigarette use in adolescents, studies have shown a steady decline in the use of e-cigarettes amongst high school students from 2017 to 2019. A, true, or B, false? False. Very good. Yes, it is steadily increasing. So, Ivali, so this is the newest condition that has been associated with vaping. Actually stands for e-cigarette or vaping product use associated lung injury. It came out in 2019, in late August going into September. The CDC coined this because they didn't have a name for the conditions that were happening that was associated with vaping, had no idea what it was, but they knew that there were lots of hospitalizations that were occurring, and we had a few deaths as well. And so a total of 2,758 cases have been reported to the CDC since February the 4th, with 64 confirmed deaths. Here in Florida, we have had between 100 to 149 cases. I got to kind of follow a case from a distance in Jacksonville because I do not work at the pediatric hospital, but I have several friends who were rotating there. They're family medicine residents, physicians. Had a 16-year-old young man who came in. He was actually jeweling, got it from his sister, and came in with signs of EVALI. Didn't really know what to do with him. They didn't really know what it was, but there is some CDC guidance from it, so they treated them according to the CDC. Luckily, he was one of the ones who got better, but there are stories out there where we've had deaths. We've had some people who are now on oxygen long term. So one of the things is that as we continue to do more research, hopefully we will find more about this particular disease, and hopefully we can help prevent cases in the future. Right now, the only thing that we know, because we don't have a clear understanding of exactly where this condition is coming from, but the major link has been to THC-containing products that came from informal sources, and those informal sources mainly are buying offline. It's either buying offline or buying off the street in the black market, where people are manipulating their products and creating their own products. Of the 2,000 hospitalizations, 82% of those who had EVALI, they reported using THC-containing products, and 57% reported using nicotine-containing products. In those, most of those patients were using both. There was a very, very small number of those who only used nicotine. That number was about 13%. Vitamin E has been that major link to EVALI. However, there has to be more than just the vitamin E substance, because for those who, that 13% that only use nicotine, vitamin E is usually not found in those particular products. But unfortunately, right now, we're not sure what the other substances are, but vitamin E is the one that is showing a strong link. And so vitamin E is a substance or a supplement. We take it all the time. It's safe, but kind of as I alluded to some of the other ingredients in the beginning, it's safe until we inhale it, because that is not its intended purpose. We should not be inhaling vitamin E. And so vitamin E is a sticky oil, and it is definitely something that interferes with the normal function of the lungs, because it adheres to the surfactant on the lungs and stops proper oxygen exchange. And the CDC has warned all users to not use products that contain vitamin E. And the reason being that most of the THC-containing products, or that the link with EVALI has been associated with most of the THC-containing products, is because sometimes they use vitamin E as a preservative to maintain the color. Because of course, you know, if you're buying from someone and the color doesn't look right, you don't want to buy it. So people want to push their product. They want to encourage their users to continue using it, and they will do anything to make sure that it remains marketable. So some of the symptoms of EVALI are shortness of breath, cough, chest pain, fever and chills, diarrhea, nausea and vomiting, tachycardia, and tachypnea. Very non-specific. Like, there are multiple conditions where a patient can present with these. So it makes it a little bit harder. One of the things that is usually when a patient comes in, if they report that they have been vaping and they have diarrhea, nausea, and vomiting, then we start to lean a little bit to this diagnosis. But it's really a diagnosis of exclusion. If you have no other reason for a patient to come in, you look at their chest x-ray, they have opacities, and they have no viral infections, no bacterial infections, and that they have been vaping, that's really how we make the diagnosis for it. And so the CDC came out with some guidance. It's actually very broad and vague, but it does give us an idea of the direction to go in order to manage this condition. First being asking about use, making a clinical assessment to determine if the patient needs to be treated inpatient or outpatient, and then go ahead and make sure that we treat these patients to the best of our abilities. And asking is just that, you know, asking the patient, hey, do you vape? Do you jewel? Do you dab? Do you drip? If they do one of those and they've done it within the last 90 days, then that is EVALI is something that we definitely want to consider. But more importantly, we want to ask these follow-up questions about what are they dripping, dabbing, juuling, vaping? Where did it come from? Brand names, how long have they used it, when was the last time, and what method did they use it. And the reason that it's important to make sure that we ask these follow-up questions is because we really don't have a lot of information on vaping and what is causing this EVALI condition. So this helps the CDC be able to narrow down where are these products coming from. Is it associated with a specific product that may be something that they are buying off of the internet, where we're seeing maybe 56% of these patients who use product X. But right now, we really just don't have much information. We can't narrow it down to a particular product or, as I said, one particular substance. When the patient comes in and they have some of those symptoms, we want to make sure that we get a pulse ox, get a history, and try to evaluate the patient for other causes for their symptoms. And if the patient comes in, their pulse ox is pretty good. Above 95 is actually what they recommend. Above 95, they have no respiratory distress. The only thing that they really have is just these abnormal symptoms that have occurred. Then they are eligible for outpatient management. We want to try to prevent as many people from going to the hospital as possible. I think reliable access to care, that is the recommendation to the CDC. Sometimes that can be hard to determine, but for the most part, those patients, we want to make sure that we take care of them in the outpatient setting and that we encourage them to follow up as quickly as possible. And so for the outpatient management, one of the things that we want to make sure that we are not doing is recommending corticosteroids. Steroids can actually make the condition worse in the outpatient setting. And the reason that it can make it worse is because we are not quite sure if the patient truly has EVALI. We're kind of making an assumption, as I said, it is a diagnosis of exclusion. And if that is not what they truly have, then it can exacerbate some conditions. So, and being that these patients are going home and not being monitored, we do not want to recommend corticosteroids. We want to manage other infections if possible. So if we think maybe the patient could potentially have CAP, or if the patient may potentially have some type of viral illness, that we are treating those in the outpatient setting, making sure that we emphasize that they stop vaping or dabbing or dripping. Though that is probably one of the number one things in order for the patient for their symptoms to resolve. They have to stop the use of their whatever product that they are using, and making sure that we are encouraging vaccinations amongst these patients. Our inpatient management is very similar as the outpatient management. The only thing is that you can use corticosteroids, and it has shown some improvement in these patients. These are the patients that are a little bit less stable. Their pulse ox is less than 95%, or they have some other underlying condition that can worsen, and they need more, or they need to be monitored a little bit more closely. Antibiotics and antivirals, the same thing as in the outpatient setting. And also, if we can, encourage that they get vaccinated before they leave the hospital. But these patients too need to follow up with their PCPs after discharge, usually within 1 to 2 weeks. And so as pharmacists, what is our role in the management of EVALI? In the community setting, so we're asking about use. Are these patients using these particular products, especially if they present to the pharmacy, say, I have a few chills, can you make a recommendation? We definitely want to add this to our list of questions to ask, refer them to the appropriate place. So do they need to follow up at their PCP versus do they need to go to the emergency room and seek inpatient management? Immunize them in the pharmacy if we can, and then making sure that we encourage smoking cessation. Our hospital pharmacists, same thing, asking the appropriate questions, medication utilization, antibiotic stewardship. So even though we are not 100% sure how this condition works, Vanco, Zosyn, and Flagyl would probably be overkill. And so for these patients, so far, we are treating them as if it was like a cap. So making sure that everything is not being thrown at them if they don't need it. And then immunization, education, encouraging the same thing as I just said, encouraging that they get immunized before they leave the hospital. Okay, so our wake-up questions. Which of the following is a main concern of people using e-cigarettes or vaping products that has recently been discovered? A, EVALI, B, teeth loss, C, black lung, or D, all of the above? A, very good. Which of the following recommendations from the CDC guidelines on treating EVALI is questionable for community pharmacists to recommend? A, influenza vaccine, B, cessation strategies, C, corticosteroid use, or D, asking patients about vaping if they present with symptoms of EVALI? C, very good. We do not want to use corticosteroid outpatient setting. All right, so smoking cessation. 70% of U.S. smokers, they actually do have a desire to quit, but only about half of that number will actually make an effort to quit. And only about 10% of those who make an effort to quit will actually be successful in quitting. E-cigarettes, as if you remember at the very beginning where I said some of the reasons that people use e-cigarettes is for smoking cessation, it has not been FDA approved and it should not be recommended. If you hear users or patients say that, oh, I vape now because I don't want to smoke, make sure that we encourage for them to not do that and that we use one of the FDA recommended quitting aids. So nicotine replacement is going to be one of those FDA recommended quitting aids, as well as we have a few medications that I will go over as well. And patients who vape and smoking cessation should not go back. Even though we encourage them to not vape for smoking cessation, we don't want them to go back to smoking cigarettes. And so one of the big questions that people ask when they hear about vaping is vaping safer than smoking? Yes, in short. However, vaping is not safe and it should not be recommended. It does have less chemicals. However, there are unknown chemicals that are also seen in vaping. So we want to make sure that we do relay that information to the patients. Although it may be safer, it is not safe and we do not recommend it at all, especially being that it is not well studied and we don't know the long-term effects. As well as youth and adults who have never used tobacco should not vape. Even if they are just vaping flavoring, make sure that you remind them 99% of all vaping products contain nicotine, and they should not do it. For those who are interested, or just for anybody who's vaping or either smoking cigarettes, we want to make sure that we use the 5 A's to help them with smoking cessation. So the first question is asking, do they use these products? And once we figure out that, yes, they are vaping or they are smoking, we want to advise them. So not in a judgmental way, but just let them know the harmful effects of smoking and the harmful effects of vaping, and making sure, especially for vaping, since a lot of the users are under the notion that it is safe, we want to make sure that we advise them that it is not safe and that quitting would be the best option for them. Assess their willingness to quit. If they're like, I'll think about it, then they may not be quite ready yet. They may know the effects, but they're not quite ready. But each time we see them, we want to make sure that we advise them to quit smoking. For those who are ready to transition, assist them. We help them make a quit plan, come up with some strategies for them to be able to quit. Are they going to use medications versus are they going to use nicotine replacement therapy? Are they going to use both? And make those recommendations for them, and then arrange for follow-up. So to make sure that we are ensuring that they are on the correct path. And so for our quit plan, we want to make sure that the patient set a specific date, and that is very important because a lot of times if patients don't have a specific date, they're going to say that they're going to quit, and that date never comes. So we definitely have to give them a date. Encourage them to tell their family and friends. So in that way, by telling their family and friends, it's a twofold. So it kind of lets their family and friends know, for those who are vaping or for those who are smoking, like, I'm not doing this anymore. But then also for their family and friends to be encouragement to them, and to remind them, like, hey, on today, you said that you were going to quit. So we make sure that we stay on that path. Anticipate challenges. And I think that this is a very important one, especially for those who have been smoking or vaping for a long time. A lot of times when they try, they don't necessarily anticipate the struggles or the challenges that they are going to face. And whenever something happens, stress comes, they go back to smoking and they're like, oh, well, I've already failed, so I'm just going to go back to it. So make sure they have a plan for what happens if they start to have symptoms of nicotine withdrawal, or if there are some slip-ups. And then remove products from the house. Remove it. So try to, have that out of mind, out of sight, out of mind attitude. And there is no true algorithm for patients in smoking cessation. So there's no step 1, step 2. It just kind of depends on the clinician, as well as it depends on what is best for the patient. And so one of our medications is bupropion, which blocks dopamine and norepinephrine reuptake. And the recommended dose is 150 milligrams BID for 3 months. You can go all the way up to a maintenance dose of 6 months, but after that, you want to discontinue the product. But one of the things with bupropion that we want to remember is that it can lower the seizure threshold. So we don't want to use it in those patients who have a history of seizures, for those who have eating disorders, as well as for those who've had some type of abrupt discontinuation of alcohol or benzos. Then we have Chantix. Yep. Got it? You sure? Okay. And I guess I should have asked a little bit earlier, but can everybody see? Are the slides pretty clear? Okay. And then Chantix, which binds to the acetylcholine receptors. Chantix is a little bit more effective than your bupropion, but the biggest thing with Chantix is we are often concerned about the psychiatric effects that are associated with Chantix, and so it is not used as often as it could be. And one of the things with Chantix is if you use it in combination with the nicotine replacement patch, it increases to 65.1% of a 6-month maintenance rate, which is actually pretty good. But as I said, the psychiatric effects a lot of times deters its use. And we have the nicotine patch, which is available over the counter. It comes in lots of different generics. One of the important things to remember more so with this is dosing for the patients, to making sure that they are using the correct dose. So if they smoke 1 pack of cigarettes, which if they are vaping, we kind of have to do the math. So if they're using 1 joule, and 1 joule a day, and 1 joule is equivalent to 41 cigarettes, they are pretty much smoking 2 packs of cigarettes, and that's the way to look at it. But for those who are 1 pack a day or more, you want to start with the 21 milligram patch, and they use that for 6 weeks. Then they'll go down to 14 milligrams for 2 weeks, and then 7 milligrams for 2 weeks. For those who are using about 10 cigarettes a day, you can start at the 14 milligram patch. And again, we just do the math for those who are vaping. This is an off-label use, but for those who are smoking more than 2 packs a day, 2 21 milligram patches can be used. And one of the biggest things that you will see is usually local irritation that is associated with the patches use. And insomnia, as well as vivid dreams, is something that is very common due to the nicotine. If patients start to experience those side effects, just have them to take the patch off at bedtime and replace it when they wake up in the morning. But if they are waking up in the morning and they have cravings and they can deal with the sleep side effects, then they can wear it for a 24-hour period. Another option would be the nicotine gum. And for the nicotine gum, it's a little less effective than the patch, but not much. One of the biggest side effects that are associated with the gum, though, is mouth and jaw soreness, because they have to chew it for a little bit until they get a peppery taste, and then they park it. So they put it in between their cheeks and their gums and let it stay there for about 1 to 2 minutes, and then you do it again. As the flavor starts to decrease, that's when you know it's time to chew again. And 24 pieces is the max that these patients want to use in one day. For those who are smoking more than 24 cigarettes, you want to use the 4 milligrams. For those who are smoking less than 2 milligrams would be the gum that you want to use. For our lozenge, one of the side effect, or the biggest side effect, is going to be throat irritation and nausea. Those are the two main ones that patients complain of. For those who are smoking, that is actually, it is opposite. For those who are smoking more than for those who wake up greater than 30 minutes and they require a cigarette, then they can use the 2 milligrams. For those who require a cigarette less than 30 minutes after they wake, they can use the 4 milligram lozenge. And what they do is just sit it in your mouth, let it dissolve, make sure you don't chew anything, no food or no drinks while you are using the lozenge. And it is so important not to chew it. You have to let it sit in the mouth and just let the lozenge dissolve. So the nicotine inhalers are actually available only through prescription, and cough and throat irritation are the biggest ones, biggest side effects that are associated with that. There's 4 milligrams of nicotine in each cartridge, and you can use up to 16 cartridges a day, which is kind of a lot, but you keep puffing until pretty much the craving is gone. And every 20 minutes or so would be ideal for the patient to use it. And each cartridge contains about 20 minutes of active puffing. You also have a nicotine nasal spray, and this is available just through prescription as well. Each spray is equal to 0.5 milligram, or 2 sprays equals 1 milligram, but you only want to do 1 spray in each nostril. Patients can give themselves up to 40 doses per day, which is also, quite a bit. But 94% of patients who use this experience side effects. It's not something that is used very commonly, but it is available. And so for our pharmacists, all of those things are strategies in which we can get involved, and recommendations that we can make. But we want to also make sure that we are involving our pharmacy techs. A lot of times the pharmacy techs are the first face that some of our patients get to see, so they can help us to identify some of our patients who may benefit from smoking cessation, for those who are vaping and for those who are using cigarettes. And for the pharmacy techs, just ask, if the patient is using any of these nicotine-containing products, offer information to them. So if there's any pamphlets, their phone numbers available. So 1-800-QUIT-NOW. You have the Florida Quit line. So there are various resources if they are not available directly in your setting, and then refer to the pharmacist if the patient has any particular questions, especially if they say, well, maybe I want to try the nicotine patch, just to be able to counsel the patients and give them some guidance on how to use these particular products. And so for our assessment question, which of the following are steps that both the pharmacist and pharmacy technician can take to assist patients with smoking cessation? A, ask about e-cigarette and vaping product use. B, provide patients written material on smoking cessation. C, nothing, because vaping is safer than smoking. Or D, both A and B. D, both A and B, because although vaping technically is safer than smoking, it is not safe, and we want to make sure that our patients are not doing it. So as we walk away from today's presentation, some of the things that I want you to remember is that vaping is just a blanket term that refers to any use of a battery-operated device to deliver nicotine or cannabinoids. The use of e-cigarettes and vaping products are steadily increasing amongst our adolescents. Fourth generation vapes, such as the Juul Pod, contains nicotine salts that are designed to allow high nicotine levels to be inhaled and contain, at the very least, twice the amount of a pack of cigarettes. That recent lung injury and deaths are associated with vaping, THC-containing products that come from sources, and recommend smoking cessation to both teens and adult users. And I want to thank you all for coming and listening to me speak this morning. I know we lost the hour, so it was like extra early. But I will take any questions. No? Thank you.
If everybody would start returning to their seats, we'll go ahead and continue. All right. I'm very pleased to introduce our next speaker, Dr. Mallory Alexis. She's from Miramar, Florida, and is currently a post-grad year one resident at the FAMU Appalachia Center, where she participates with the treatment team at the hospital. She's also a teaching resident here at COPS. And she graduated in 2019. She currently has an interest in emergency room medicine, academia, and oncology. After completing her postgraduate first-year residency, she plans on completing a second one in either ER medicine or oncology, or going into academia. She hopes to strengthen her clinical knowledge during her residency and become a better version of herself. So I'm very, very pleased to bring up Dr. Alexis.
Good morning, everyone. Again, my name is Mallory Alexis, and today I will be presenting a presentation. And my presentation today is Trying to Catch Some Z's, Management of Insomnia in the Elderly Population. And of course, to begin my presentation, I have to disclose that I do not have a vested interest in or affiliation with any corporate organization offering financial support or grant money for this continuing education program, or any affiliation with an organization whose philosophy could potentially bias my presentation. So by the end of this presentation, the pharmacist should be able to define insomnia disorder based on DSM-5 criteria, explain pharmacological and non-pharmacological treatment for insomnia in elderly patients, recall adverse effects, important drug interactions, and patient counseling pearls for medications used in treating insomnia, and explain the role of the pharmacist in treating insomnia in elderly patients. If we have any technicians, by the end of this presentation, they should be able to define insomnia disorder based on DSM-5 criteria, discuss the epidemiology and pathophysiology of insomnia in elderly population, and recognize the pharmacological and non-pharmacological treatment for insomnia in the elderly. And before I actually go into the actual presentation, I thought it would be nice to give a little bit overview just to show you what we'll be discussing. So first, I will go over the normal sleep cycle. Then I'll go into discussing the different sleep-wake disorders based on the DSM-5 criteria. Then I'll go into defining insomnia disorder, and then insomnia specifically in the elderly population, the epidemiology, diagnosis, risk factors, treatment, and then the role of the pharmacist. So I decided to bring a friend along with us during our presentation. His name is JT. JT has a couple of questions that he may have for us to help him, recommend him so he could get some better sleep. So JT, he is a 69-year-old man who is referred to a sleep disorders clinic for evaluation of insomnia and daytime somnolence. JT reports that he has had insomnia for many years and that it has gotten worse in the past 10 years. He has trouble with sleep initiation, and it often takes him more than an hour to get to sleep. Once he is asleep, he wakes up multiple times and then struggles to get back to sleep. He tosses and turns in bed until morning and gets up feeling exhausted. JT has also been recently diagnosed with depression. So that's a little bit brief overview on JT. We'll see him throughout the presentation, but again, I'll bring him back up because I'm pretty sure everyone's not going to remember everything about JT. And so, of course, before we actually talk about the actual insomnia disorder, we always have to talk about what does it normally look like? What does sleep look like on a day-to-day basis? And so, as we may all know, sleep is actually divided into two phases. We have our NREM, or non-rapid eye movement. Then we have REM sleep, which is, if you ask anybody about sleep, they'll tell you, oh, I know what REM sleep is, right? REM, rapid eye movement. And what's really interesting with REM sleep, this is the part of sleep, this is the deepest part of sleep, and this is when your brain activity is actually the highest, and your eyes are actually rapidly moving, hence the name rapid eye movement. So the two phases usually occur about 4 to 6 times during a sleep cycle, and during a sleep whenever you're sleeping, and each can last between 70 to 120 minutes. So pretty much, if you're getting sufficient enough of sleep, you should be going in and out both of those and experiencing dreams if possible. I do want to take note about several hormone changes that does occur and why sleeping is so important. Growth hormone is released during sleep cycle, but I want to stress the cortisol and the melatonin that's released. In the next slide, I'm going to go a little bit deeper into something really cool that we have in our body, but cortisol usually peaks right before awakening, and so as we all may know, cortisol actually keeps you alert, and have a lot of attention. Melatonin actually secretes right before you're about to go to sleep. So some resources say 7 p.m., some may say 9 p.m. But again, their whole role is to increase or induce sleep. And so what's really cool about us as humans, we have something in our body called circadian rhythm, or our natural alarm clock, right? And so how our body functions is by the light and the darkness that we see. So once light is present, our body is alert to know, okay, maybe it's time to wake up, maybe it's time to function. This is when we're the most alert. When the sun sets, our body is seeing that it is dark at night, then melatonin will start secreting, therefore inducing sleeping, giving you that relaxation. You'll have a drop in body temperature and just a whole metabolic change. And so let's actually go into the actual sleep-wake disorders. There's a few of them. I'm not going to discuss every single one since it's not really pertinent for this presentation, but I will, of course, emphasize insomnia disorder based on the DSM-5 criteria. And so when we talk about sleep-wake disorders, that is changes in sleeping patterns or habits that can negatively affect the health. So the Diagnostic and Statistical Manual of Mental Disorder, 5th edition, or your DSM-5, classifies sleep-wake disorders in 10 categories. Of course, insomnia disorder being the most common, as we always hear about it. We also have something called hypersomnolence disorder, narcolepsy, breathing-related disorders, circadian rhythm sleep-wake disorders, non-REM sleep arousal disorders, nightmare disorders, REM sleep behavior disorders, restless leg syndrome, and substance/medication-induced sleep disorders. So based on the DSM-5, insomnia disorder is actually broadly defined. You have two types of characteristics of how you would actually go into defining insomnia disorder. So the first one would be a predominant complaint of dissatisfaction with sleep quality or quantity associated with one or more of the following: whether you have difficulty initiating sleep, difficulty maintaining sleep, early morning awakenings with inability to return to sleep, and the next portion is sleep disturbances that causes clinically significant distress or impairment in important areas of functioning. So it could occur at least 3 nights per week, or it could be present for at least 3 months. It can occur despite adequate opportunity for sleep, and it's not better explained or does not occur exclusively while other sleep-wake disorders are present. It is not attributable to the physiological effects of a substance, and no coexisting mental disorders and medical conditions do not adequately explain the insomnia. So to go better and deeper into the classifying insomnia disorder, you must specify the type of insomnia the patient is experiencing. So again, we want to emphasize that sleep disorder is not associated to any other mental comorbidities, whether that be depression or anxiety, as well as substance use disorders. No medical comorbidity issues, whether that be any pulmonary issues like COPD, asthma, or maybe diabetes, hyperthyroidism, things of that nature. And with other sleep disorder, as we just mentioned, the other 9. Another big thing is specifying whether it's episodic, persistent, or reoccurring. When we say insomnia disorder is episodic, that means symptoms last at least 1 month, but less than 3 months. For persistent, that means the symptoms are 3 months or longer. And reoccurrent means the patient has experienced 2 or more episodes within a 1-year period. So the fun stuff, the pathophysiology, we may wonder and ask ourselves, well, why are people experiencing insomnia disorder? What is causing this? And so insomnia disorder is actually an induced state of hyperarousal during sleep or wakefulness. When we talk about hyperarousal, that just means increased stimulation, right? And it's usually manifested as an elevated whole body metabolic rate during sleep and wakefulness. And again, emphasizing elevated cortisol, elevated adrenocorticotropic hormones, again, plays in the adrenal glands, things that keep you alert and stimulated, and also reduced parasympathetic tone and heart rate. And as we know, we have our parasympathetic and our sympathetic system. The importance with our parasympathetic system is rest and digest. So if I do not have the actual presence of my parasympathetic system functioning the way it needs to be, I'm not technically resting the way I would like to, right? Next, we do have some abnormalities that are actually seen with patients with insomnia disorders, some levels in our interactions of these following substances in the brain actually may lead to insomnia. And if you actually pay attention to some of the certain hormones and chemicals that actually play a role in insomnia, are certain ways of how they are actually treating the insomnia disorder that many patients may experience. So when we talk about molecules that promote wakefulness and suppress sleep, usually we have our catecholamines, orexin, and histamine. So usually those levels should be elevated to promote you to be more alert. What may be decreased in patients with insomnia disorder, which are chemicals and hormones that play a role in actually promoting sleep and suppressing wakefulness, is GABA, serotonin, and melatonin. So JT's back. I'm not going to read everything, but I will emphasize that he did state that he had insomnia for many years and has gotten worse. He has trouble sleeping, initiating sleep, and it often takes him more than an hour to get to sleep. And once he is asleep, he does wake up multiple times and then struggles to get back to sleep. He tosses and turns in bed until morning and gets up feeling exhausted. So our first assessment question is, which of the following molecules promotes sleep and suppresses wakefulness? Is it melatonin, A, melatonin, B, cortisol, C, serotonin, or D, A and C, or E, all of the above? Yes, thank you. I don't think mine shows all the answers. I didn't do that fancy stuff, so yes, you guys are correct though. The next question is, based on JT's symptoms and the DSM-5 criteria, which of the following describes JT's insomnia? Is it A, difficulty initiating sleep, B, early morning awakenings with inability to return to sleep, C, difficulty maintaining sleep, or D, A and C, or E, all of the above? E, right, all of the above, yes. So JT has problems going to sleep. He wakes up, tosses and turns, and he also has a problem just staying asleep the whole night. And so going into the more fun stuff, we're talking about insomnia in the elderly. And I think the importance with insomnia in the elderly is the actual projection of the elderly population by 2050. What we have seen is a drastic increase in this population, especially due to our baby boomers. A lot of them are living a little bit longer, which is a good thing, but that means we have to have a little bit more focus in knowing how to better treat them, since they will become a big part of the population. So by 2050, there should be at least 22% of the population that will be 65 years of age and older. So just some little facts and statistics. There's approximately more than 50% of the geriatric population that actually complains about difficulty initiating or maintaining sleep. Elderly patients or older patients are actually more likely to complain about insomnia compared to younger individuals. Sleep maintenance is the main symptom that many patients do complain about. And elderly patients with depressive symptoms are 2 to 3 times more likely to report complaints of insomnia. And elderly patients with respiratory symptoms are 40% more likely to report complaints of insomnia. So when we talk about the aging process, we understand that there are some things that should naturally occur, and then there are some things that just don't make any sense. And so, again, with the elderly population, insomnia does remain one of the most common sleep disorders encountered in the geriatric population. And usually when these patients are complaining about suffering with insomnia, they usually complain about difficulty falling asleep or maintaining sleep, as well as sleeping maybe 8-7 hours, but waking up feeling like they did not have a well-rested sleep, and then some mood disturbances as well. When we talk about age-related changes, these are things we expect to occur as individuals change with sleeping, and one of the biggest things is the total average sleep time. So usually individuals sleep about 7 hours, but as you age, 5 hours a night is the amount of sleep that an individual would get. Also decreased sleep efficiency and a tendency to fall asleep a little bit earlier in the evenings. So the big thing about sleeping is, I don't know how many of you guys may experience it, but insomnia does happen. I know I've experienced insomnia, so we know sleeping or going nights without sleeping is pretty common, but the problem is, are you not being able to sleep every night? At that point, that's when it becomes a problem. So the biggest thing we want to emphasize are, what are the following symptoms that are not a part of the aging process? So if a patient is having trouble falling asleep, even though he or she feels tired, that is a red flag. Having trouble getting back to sleep when awakened, another red flag. Not feeling refreshed after a night's sleep, red flag. Feeling irritable or sleeping during the day, another red flag. And relying on sleeping pills or alcohol to fall asleep, it's not a go. We want to make sure that individuals are naturally going to sleep and don't have to depend on anything to fall asleep, right? We don't want someone to think they have to take medication for the rest of their life just to be able to sleep on a day-to-day basis. And so they did a little bit of research back in January 1st, 1995. They kind of wanted to compare the prevalence of insomnia in the general population compared to the elderly population. And so they used a psychiatric examination, and they received information from the different populations. So they got information from individuals in a community, so 874 of those people. And then they got information from people who actually live in the institutional residencies, 59 of those residencies. What they did see was that a lot of the patients that did experience insomnia, it was really closely related to other comorbid conditions, whether it be pain, depression, and poor physical health. Out of that survey and out of the research, they saw that 16% was in the community and 12% in the institutional residency, the patients actually experience insomnia. So the whole basis of the research basically showed that persistent insomnia in the elderly is strongly associated with depressed mood as well as physical disease. So oftentimes, a lot of patients may not actually have the actual insomnia disorder, but there may be something contributing to the actual insomnia, and if we could identify and treat that underlying issue, then we could better assess the insomnia altogether. So our next assessment question: more than how many percent of the geriatric population complains about difficulty initiating or maintaining sleep? A, 20%, B, 30%, C, 40%, D, 50%, or E, 60%? Yes, 50%. I don't know if I heard B, maybe not. But yes, no, maybe so. But yes, it was 50%. I don't know if I emphasized that enough. But yes, 50% of our geriatric population actually complains about difficulty initiating or maintaining sleep. So going into the risk factors in diagnosis, we're going to focus on the patients that are at more risk of actually complaining about insomnia and how providers are actually going into the diagnosing patients with insomnia disorder. And so big two factors that contribute to insomnia is psychiatric conditions and medical conditions. When we talk about psychiatric, we're more so talking about depression, anxiety, substance use disorder, or PTSD. When we talk about medical conditions, we're talking about pulmonary, like COPD and asthma. Maybe some of you may have COPD or asthma, I'm not sure, but I know I have cold and allergies sometimes, and I know during that period of time I can't sleep because I can't breathe, and that is just not a good feeling. So I can only imagine people who are actually suffering from comorbid diseases like COPD and asthma, how that could affect somebody from sleeping on a day-to-day basis. Another big thing is pain. A lot of people are experiencing pain, and their pain is not being managed at the way that it needs to be, whether it be treated suboptimally. So like arthritis, fibromyalgia, or chronic pain. Another big one is CHF. As we understand, patients with heart failure, sometimes they develop fluid overload, and that causes them to have shortness of breath. So another thing that deals with difficulty with breathing. Another big thing is like diabetes and hyperthyroidism, as that affects the whole metabolic change of an individual. So again, anything that is disrupting homeostasis can increase the risk of insomnia. Another big thing is like gastrointestinal issues like GERD or PUD and IBS. The biggest thing with that is interrupting sleep at night. If you have any flares or if you're experiencing that burningness when you're having acid reflux, that's just not a good feeling. Again, that would cause somebody to not be able to sleep as best as they would like. Another big thing is cancer. When we talk about cancer, the big thing about cancer is the pain that the patients are experiencing. And because of the pain, they're not able to sleep as well either. So all of these all together increase insomnia. And I decided to put this little funny picture I saw online. It says Insomnia Jeopardy. And it kind of has like different tabs on what would possibly cause their insomnia. So category 1 says which ways in which people have wronged me, strange noises, diseases I probably have, money troubles, why did I say or do that, and ideas for a screenplay. So I thought it was really cute and funny, and just playing on words on why a lot of people do have insomnia. It's not because they truly have an insomnia disorder, but there's something underlyingly causing the insomnia altogether. So another big thing is medications and substance-induced insomnia. So as pharmacists, we should be aware of certain medications or certain substances that increase the risk of patients not being able to sleep at night. So a big thing is CNS depressants like BZDs and opioids. You might say, what, BZDs, aren't those actually used to treat insomnia? But just like if you were to overuse NSAIDs for, say, migraines and you're going to experience rebound headaches, that's the same thing that would happen if you were going to keep using BZDs or opioids to treat insomnia or pain or what have you. It actually results in rebound insomnia. Another thing is CNS stimulants. As we know, anything that stimulates the central nervous system and causes you to be alert, of course, you're going to be at a higher risk of staying up and not being able to sleep, so increasing alertness and functioning. Another thing is antidepressants. When we talk about antidepressants, they're more so affecting the actual sleep cycle and REM. Again, this is not as common, but it does and can occur. Another class are diuretics. When we talk about diuretics, we're not necessarily talking about affecting the whole sleep cycle or individual to actually go to sleep, but we're focusing on timing. A big thing, again, when we're counseling patients who are on water pills, like we will say to them, taking it at nighttime is not the smartest idea at all. Again, the purpose of the medication is to release the amount of fluid in your body. To do that, you have to use the restroom. And in turn, you don't want to be taking the medication at nighttime and have to wake up during the night to have to use the restroom. So again, emphasizing correct dosing time and frequency. Another thing is glucocorticoids. Again, same thing, timing, emphasizing that it is important to take this medication during the morning time, because again, this medication does increase and have activity on the adrenal glands, i.e. increasing the release of cortisol as well. Again, a big emphasis on playing a role on alertness and functioning during the day. Another big one is caffeine and nicotine, and of course we know those are stimulating agents, so again, very similar to your CNS stimulants. And lastly, we have alcohol. Alcohol actually affects the actual circadian rhythm, but besides actually affecting the circadian rhythm, I don't know how many of us may actually drink, or back in the day when you probably used to drink a lot, but when you drink a lot, they used to say the term "don't break the seal," or I don't know if that's a new term for us millennials, but basically stating when you drink a lot of alcohol, you have to use the bathroom a lot. So again, drinking a lot of alcohol causes you to use the restroom a lot, but also another thing is some patients experience like heartburn and acid reflux when they drink, so that's another thing that would disrupt anybody from being able to have quality sleep. So we may ask, well, why do we care about insomnia so much? Who cares if someone can go a couple of days without sleeping? The big issue is insomnia disorder altogether has some morbidity that's actually associated with it. Certain studies actually show that individuals with insomnia actually have a 23% increased risk of developing depressive symptoms. And as we understand, depressive symptoms actually increase risk of suicidal tendencies. So again, you see the negative effects and impacts of not being able to sleep. Another big thing is sleep loss. And insomnia actually is associated with heart disease and other cardiovascular risk factors like hypertension, myocardial infarction, and stroke. And again, I want to emphasize, when we talk about sleep, the importance of sleep is we need to rejuvenate our body. Our body needs to sleep to be able to function again the next day. So when we're not being able to rest and regenerate, we're affecting our whole body. And so there are different changes that can be affected long term when not being handled accordingly. Another thing is individuals with insomnia are just at a greater risk for metabolic syndrome, like I mentioned earlier with the whole circadian rhythm and sleep cycle. And so again, for healthcare providers, the biggest thing is asking questions. Sometimes providers may ask a couple of questions and they think they may know the answer, but really getting into the deep core problem. And by identifying these problems and asking these actual questions, you can actually treat the patient accordingly. So are you under a lot of stress? Are you depressed? Do you feel emotional? Do you struggle with chronic anxiety or worry? Have you recently gone through a traumatic experience? Do you have any health problems? Are you taking any medications? And so specifically when we're talking about health problems and taking any medications, it's important to ask, well, if it is yes, you need to ask more specific questions so you can further understand the issue altogether. And again, want to emphasize identifying the underlying problems. As the research showed earlier when I discussed in January 1st in 1995, a lot of patients who experience insomnia, it's not because they have insomnia disorder, but it's because they have other comorbid issues that you could actually go in and better assess and treat, and overall helping them all together. So JT's back. JT's wife loves him so much, so she decided to tell us a little bit information about him. So she told us that he snores and that he has had occasional times when he actually has stopped breathing while he sleeps. He has type 2 diabetes, hypertension, depression, and GERD. So, of course, next is an assessment question. And so, which of the following risk factors for insomnia disorder does JT have? A, GERD, B, cancer, C, type 2 diabetes mellitus, D, ANC, or E, all of the above? Yes. JT has GERD and type 2 diabetes. Now, if JT had cancer, that would be an option too, but thankfully, JT does not have cancer. Yes, sir. Yes, and you're going ahead of yourself because I have a question that relates to that. But I love the critical thinking skills and jumping ahead of me. But yes, exactly. That's the main focus on JT. He does have depression, and we'll go into that. And so going into the treatment options, again, when we're talking about treating patients, the whole purpose of treating someone is to have a goal. Not only in just treating patients, but in life you have goals. So of course, whenever you have a patient, you want to make sure that you're giving them the best treatment possible. So we want to identify and assess potential causes or sleep issues. Again, correcting the underlying sleep complaints. I can't stress it enough, and I don't want to be redundant, but again, a lot of times these patients are not experiencing actual insomnia disorder, but it's because of other comorbid conditions. We want to enhance sleep. Everybody loves to sleep, so not being able to sleep is just not a good issue to have or want to experience, right? We want to improve daytime functioning and reduce daytime sleepiness. We want to avoid adverse effects from selected therapies. Adverse effects is a really, really big thing when we talk about our elderly population, and we'll go a little bit deeper into that while I go further into the presentation. But again, as we get older, our body changes, so we're at more risk of actually experiencing adverse effects. So taking the time to understand these effects on this specific population is really, really important. A big thing also is using the lowest dose possible for the shortest duration possible. Again, if people have insomnia, we're not trying to treat insomnia for the rest of their life. This should be a short-term course and using the lowest dose possible. Again, we're not trying to have people become addicted to a lifestyle that is not necessarily needed. So when we talk about managing insomnia, the management altogether should be divided in two. So again, we should always have a non-pharm therapy and a pharmacological therapy. When we talk about non-pharm, there are different ways like sleep hygiene, psychological and behavioral therapies, and another thing called cognitive behavioral therapy for insomnia, or CBT. We also have our pharmacotherapy, which we'll go into a little bit deeper, the different types of medications that are actually available to help. Again, it's a stepwise approach. We go and we try different things, making sure that we're assessing all problems before actually going to pharmacotherapy. Again, don't want to stress it enough, but this is the elderly population. If we do not need to use any pharmacological therapy that is unnecessary, we want to always go with non-pharm. Non-pharm is the number one option. On top of non-pharm, if we are going to implement pharmacotherapy, we always want to combine it with non-pharmacological therapy. And usually you'll see it with CBT, or cognitive behavioral therapy. So when we talk about the stepwise approach, again, we want to collect thorough history. We want to know what is causing you not to be able to go to sleep at night. We want to evaluate present challenges, whether it be you have stress, whether it be you work night shifts, whatever it may be. We want to make sure we're assessing all those challenges that may be in front of us. We want to evaluate the nature. So what exactly is causing the insomnia? How frequent is it? And when did it start? How did it look like? And the duration of the symptoms. Some cool things that providers actually use to help diagnose insomnia. I don't know how often they use it, but there's something called a wrist actigraphy, and it's basically a watch that patients can wear on their wrist, and it actually displays their brain waves. And through that, they're able to see what disruptions these patients actually may be experiencing during their sleep that can actually be contributing to their insomnia. So that's a cool way to kind of see what is happening. Another big thing is rating scales. Again, anything that helps with scoring something helps you better assess a patient's disease state. And then lastly, we'll encourage patients to probably contain or have a journal, a sleep journal that kind of jots down how they've been sleeping and things that have been affecting their sleep altogether. So going into the non-pharm and pharmacological therapy, which will be the majority half of the presentation, we're always going to start with non-pharm again. Want to stress, yes, we are pharmacists, but we always want to tell patients other things that they can do to alleviate whatever issue they may be having, because pharmacological therapy oftentimes alone is not as effective as combining non-pharm. So we always want to combine the two together to get that optimal response. So sleep hygiene education. When we think about the word hygiene, we think about cleanliness, right? So things that we could do to make something clean. So we talk about what can I do to make my sleep clean or better. So we want to promote stable sleep practices. So some things we will tell patients to do is decreasing environmental disruption. I don't know about you guys, but I'm one of those people who actually has to sleep with sound or something like a TV. I'm the type of person, I find that if I don't have any distraction, I might find myself worrying a lot and thinking about things I don't want to think about, right? But again, we have to understand those type of things disrupt your relaxation, because when you're sleeping, you want to be at the most relaxed state possible. So again, encouraging patients, maybe we'll do white noise instead of maybe a TV or something more soothing. Turning off all electronic devices at least 30 minutes before bedtime. This is a really big thing now since, we have those really cool things called smartphones, and they're able to do a lot of things. So people in general are using their phones a lot right before going to sleep. And again, as I mentioned earlier, our body is so awesome and so cool. We actually have our own natural alarm clock, and that actually activates and works by the rise of the sun and the setting of the sun. So if I'm seeing light, my body is thinking maybe it's night, maybe it's morning time. So you're going to be more alert. So again, not having that light in front of your face before going to sleep is really, really important. Having a comfortable bed in a cool, quiet, dark room. Again, I don't know about you guys, but I don't like sleeping in a hot room. It's just not the best situation to be in. You always want to be comfortable. You want to be at the most relaxed state possible. And for people who actually clock watch, there are people who look at the clock and get nervous and like, oh my God, it's 11 o'clock or 10 o'clock and I'm still not asleep. So people who tend to be anxious and worry about things like that, we tell patients like that, it might be better for you to actually remove the clock. Maybe you don't need a clock in your room, or maybe putting a shirt over the clock so you're not actually looking at it constantly. Another thing is limiting the use of alcohol, nicotine, or caffeine before bed. Want to really emphasize the alcohol because, as we may know, sometimes alcohol does cause us to be drowsy and makes us go to sleep. But again, it's not the smartest decision to have patients depend on a substance to be able to go to sleep at night. So emphasizing the use of alcohol to go to sleep is not the best option. Another thing is try not to exercise too close to bedtime. Again, anything that causes you to be more alert, it does not make sense to do it right before the time to go to bed. And another thing is avoiding naps. Again, I don't know about you guys, but I love taking naps. That is a part of my daily schedule. I have to take a nap because I feel like I will not be able to function. But when we talk about naps, the purpose is to kind of rejuvenate you for the rest of the day. So when your nap is becoming longer than 1 hour, it's no longer considered a nap. So emphasizing that a nap should be no longer than 1 hour if you truly, truly, truly need a nap. The next portion is behavioral. So this more so focuses on the thought process of patients who are experiencing insomnia. So again, when we talk about cognitive behavioral therapy, we're more so thinking about how somebody thinks about sleep, how their behaviors actually affect the ability to sleep or sleep well. So more so this place with just getting into the patient's mind and assessing what is going through their mind. Another thing is stimulus control, reassociating the bed with sleep. Again, I don't know how many of us may do this, but people actually do their work in bed. They do a lot of things in bed. And the whole purpose of your bed is really for you to sleep. And so when you become too accustomed to your bed, your body becomes very comfortable to it, and it's not really associating sleeping with that bed. So when we talk about stimulus control, we want to avoid patients sleeping or spending too much time in their bed. And then sleep restriction is very similar to stimulus control. The difference is we're actually talking about patients who may be sleeping too much. Again, we want people to get quality sleep. We don't want them to get too less of sleep, but we don't want them to get too much sleep either. So again, restricting the amount of time they're sleeping in their bed. And then we have relaxation therapies. Anything to put you in a relaxing state will always, always, always induce sleepiness. So maybe it be Tai Chi or yoga or whatever it is that you may do to put you in a relaxed state. Maybe drink some hot cocoa or, hot milk or whatever it may be, but doing something to make you more relaxed is really, really important to emphasize to patients too. And so going to actual pharmacological therapy, where we can actually counsel patients and give them a little bit more information on. Yes, sir. Yes. That question. And I didn't see any studies because even when I had to create studies for this actual presentation itself, I'll repeat the question. So he was stating that people of African descent tend to have less sleep deprivation. So is there any studies that show ways to better address that certain population? That was your question, right? Oh, they are more, yeah, African Americans are more risk of actually experiencing sleep deprivation. So he was saying, is there any study specifically identifying that specific population? And I did not see any. I also did not make an effort to look into that too. I will say that. But even looking for studies dealing with insomnia specifically for the elderly was even hard. So what we do notice with a lot of research, they tend to not have as much in the elderly population, which is why it's important to stress more research to be done in that population, since they are going to start growing to be a big portion of it. But yeah, unfortunately, I didn't see any research. But if I do find anything, I can definitely contact you and let you know. And so for our pharmacological therapy, there's a couple of agents, or more than a couple, there's a few that are actually used. So we have our over-the-counter medications like antihistamines and melatonin. We have our antidepressants like mirtazapine, trazodone, and doxepin. Then we have our benzodiazepines like temazepam, triazolam, clozapam, istazolam, and flurazepam. Our other agents are our non-benzodiazepine receptor agonists. We have esopicolone, xalapone, zolpidem, and its other formulations. And then our two newer class of agents are our orexin receptor antagonists, which is suvorexant or Belsomra. And then we have melatonin receptor agonists, Remilton or Rosera. So before we actually go really deep into the pharmacological therapy, we want to also emphasize the special considerations again with our elderly population. When we think about 65 years and older, the first thing that should come to our head is Beer's criteria, or i.e. Beer's list, right? And we know that is a list of medications that are technically considered inappropriate to use in the elderly population. So the reason for that is elderly people are more prone to experiencing adverse effects, especially when we're talking about medications that are used to actually induce sleep or sedatives. So they're more sensitive to all sedative, hypnotic, and sleep aid medications. These medications also increase the risk of confusion and memory problems. So that's a big thing we don't want to add to this population, especially patients that may actually have dementia or Alzheimer's. And because of this confusion and memory problems, these patients are actually at a double risk of actually experiencing falls and fractures, and also car accidents, as anybody would be at increased risk of car accidents if they're taking a sedative medication. Another big thing is our over-the-counter antihistamines or sleep aids or herbal or natural products. Even though they do actually work, we want to stay away from patients using them chronically to treat their own issue. Again, we want to emphasize to patients that they are not healthcare providers and they may not know the long-term effects of these medications, especially because there's not enough research that is actually due to that. So due to that lack of efficacy and safety, we want to stay away from actually treating any chronic insomnia with these over-the-counter medications. Another big thing is using cough and cold and pain combinations. You often hear maybe sometimes your colleagues will tell you, yeah, I couldn't go to sleep last night. I decided to take some NyQuil. And honestly, it doesn't make sense to take NyQuil for insomnia if you're only experiencing insomnia, but then it has medications in there that are used for cough or cold or pain, whatever, what have you. And so again, you're adding effects and side effects to yourself when you don't necessarily need that. So again, emphasizing if it is a cough and cold combination or a pain combination medication, to use it accordingly if you have a cough or cold, if you are experiencing pain. And again, the attractiveness for those medications is because they do contain diphenhydramine or Benadryl. So another big thing with our elderly population is polypharmacy. When we say polypharmacy, we're more so talking about patients that are on specifically 5 or more medications. We want to emphasize that it's 5 or more, not necessarily 2, 3, even though that is a lot of medications, i.e., quote unquote, but polypharmacy specifies and emphasizes 5 or more. And of course, it's a concern in the geriatric population because they tend to have more disease conditions. And so since they have more disease conditions, they need more therapy. So there's studies that actually show that approximately 20% of Medicare beneficiaries actually have 5 or more chronic conditions, and then 50% of those people actually are on 5 or more medications. So again, when addressing any issue, we want to identify any other underlying issues first, address that before we add any other extra medication that we don't need. Another thing is elderlies are at a greater risk for adverse drug events. So that, again, is due to the aging process, and due to the aging process, there are changes metabolically, and that affects the ability for individuals to actually metabolize or clear the drug as effectively as, say, their younger counterparts. And again, polypharmacy just increases drug-drug interactions. And again, pharmacists, our role is to make sure we're mitigating that and lowering the chances of any drug-drug interactions. So going into our first class, our antihistamines, big one, Benadryl, and it has different brand names that are over-the-counter: Sominex, Simply Sleep, and Nytol. Majority of these medications are like 25 to 50 milligrams when we talk about our antihistamines. They're usually taken 30 minutes before bedtime, which makes sense, right? And usually these medications do cause dry mouth and somnolence. Those are the more so common complaints. And as we understand, these medications do tend to have anticholinergic effects, so i.e. the dry mouth makes sense. So a big thing we could counsel patients on if they tell us that they're taking it for this purpose: drink some more water than you usually would do so that you don't experience that dry mouth, and making sure that you are taking this only at nighttime. Again, since it does cause sedative effects, avoid any activities that require mental alertness or coordination. Another big thing is, since these patients don't need to necessarily have a prescription to get these over-the-counter medications, they could easily go through the aisles, pick it up, and check out without contacting us. So if possible, and we're able to actually catch this, we could emphasize to patients that chronic use actually leads to tolerance. So it's recommended not to use these over-the-counter medications for more than 10 days. After that, you become tolerant to it, and it no longer serves the purpose that you are looking for. So now you're at a point where you're just taking medication for fun, and we don't want to do that. Again, risk of confusion. These drugs have anticholinergic properties, so we don't want to worsen any confusion or add any confusion. And again, emphasizing that it does have anticholinergic effects. Melatonin. Melatonin is a really, really big one. If anybody ever tells you they have sleep problems, many people will say, hey, yeah, go over the counter, get some melatonin. And as melatonin is really, really good, again, any of these over-counter medications, we don't want to use these long-term. That is not the purpose. What's really cool, or what's really good about melatonin, is that it has different formulations. So sometimes our elderly population may not be able to swallow capsules. So there is a chewable form and there's an ODT formulation. Again, the side effects are similar to many of the other ones, which are somnolence and fatigue. But what's really interesting with melatonin is hypothermia. And I'm going to go a little bit into that in the next slide, because there's a research that was actually done in the treatment of melatonin, specifically in the elderly population. They wanted to see if there was a relationship between actual elderly people and melatonin levels. So in theory, they were thinking possibly the reason why patients in this population was actually experiencing insomnia was probably because they had lower melatonin levels. So they kind of wanted to do the study to relate to see if this was a correlation. So it was a double-blind, placebo-controlled trial, and the patients were receiving no medication on the odd weeks. So week 1, 3, and 5, they were receiving no medication or placebo. And on the even weeks, 2, 4, and 6, they were receiving either dose 0.1, 0.3, or 3 milligrams. And the results basically showed at 0.3 milligrams, melatonin was actually able to restore melatonin levels to normal and actually improve sleep altogether. 0.1 and 3 milligrams was able to do that as well. But what they really saw was that with 3 milligrams, patients were actually experiencing higher levels of melatonin the next day and actual increased hypothermia. And again, going back to the beginning of the presentation, I talked about the circadian rhythm. And again, when we want to get into that relaxed state, our body's temperature drops when it's time to go to sleep. And so if I'm increasing melatonin levels, I'm increasing my body's mind believing that it is time to induce sleep. So again, increased risk of that hypothermia or low body temperature. So that is what they saw with 3 milligrams. And basically the study showed that at 0.3 milligrams, that is sufficient. Nothing more, nothing less is needed to actually improve sleep and give the result that they're looking for. So using the lowest dose possible is the emphasis on this research and trial. So now onto our miscellaneous, our antidepressants. Our first one is mirtazapine, or Remeron brand name. Usually you'll see patients start on 15 milligrams. The max is 45 milligrams, so we don't want to give anything more than 45 milligrams. The biggest thing with mirtazapine is increased appetite, a raise in serum triglycerides, weight gain, and dry mouth. Again, with all our antidepressants, I won't say it again, but we want to avoid co-administration with or within 2 weeks of a MAOI. And so with mirtazapine or Remeron, what's really cool is we're using the side effects to our benefits. So for patients that may be experiencing depression and insomnia or may actually need to gain weight or increase their appetite, this is a medication that's very, very attractive for this population. I know right now at the Appalachia Center, we have a lot of patients that come in that experience depression. Some of the side effects of depression is probably not eating. So we would advise and we would recommend that medication for that patient. But then we have patients that are overweight. They tend to eat a lot when they're depressed. So we would avoid that medication in those type of populations. So again, using your side effects to your benefits. Triglyceride levels, that should be monitored. Again, anybody who has high triglyceride levels, anything above 250, again, we would not want to start this therapy in them because that just isn't the best recommendation possible for them. And again, with majority of these medications, we don't want to just abruptly discontinue. We want to gradually discontinue any medication someone may be taking on a day-to-day basis to treat any chronic issues. So some symptoms may be dizziness, nausea, headache, irritability, and anxiety. So our next assessment question for the man in the back, which of the following is considered first-line therapy in the treatment of insomnia in the geriatric population? Was it A, mirtazapine, B, cognitive behavioral therapy, C, temazepam, D, doxepin, or E, trazodone? Yes, B. Again, emphasizing with our elderly and geriatric population, always start with non-pharm. We don't want to give any pharmacological therapy when we do not need it. So we're going to always start with non-pharm, whether it be cognitive behavioral therapy, sleep hygiene education, stimulus control, yes, or sleep restriction. I actually did not. Have you heard about? Yeah, I haven't seen anything either. I know with the research, they more so focused on the hypothermia. But yeah, I didn't see anything about the cardiac issues associated with specifically melatonin. I know when we talk about cardiac issues, they more so emphasize doxepin, which we'll go on, which we'll discuss next. But yeah, I have never heard. Okay, it's good to know. Yeah, I did not see any research on that, so I was not well versed on that. But that's really good to know. Next, we have trazodone. With trazodone, usually 50 to 100 milligrams, again, starting at the lowest dose. So 50 milligrams is what we'll start with, and if 50 is not enough, again, we'll move up to 100. Some side effects are dry mouth, QT prolongation, priapism, and orthostasis. The biggest thing with trazodone is it does increase serotonin levels. So anything that increases serotonin levels, we want to be mindful for serotonin syndrome. Again, theoretically, it is not as common. We don't see this on a day-to-day basis, but again, we must emphasize and discuss the possibilities of that actually occurring. And just some counseling points with trazodone. It's important to emphasize to our male patients, if they are experiencing an erection that is longer than 4 hours, not to just hang around, but definitely it's an emergency situation and they need to seek medical attention as soon as possible. Again, with trazodone, the reason why it is beneficial and attractive is because it can help patients who have depression and actually experience insomnia. Another thing is, since it does cause orthostasis, that does cause an increased risk of falls and fractures. So again, we want to avoid that in patients who have increased risk of fall or fractures. Again, avoid sudden discontinuation. We always want to warn patients about possible side effects that could happen if for whatever reason they're on multiple medications that may increase serotonin levels. So looking out for serotonin syndrome like confusion, rapid heart rate, high blood pressure, and increased sweating. Next, we have our last antidepressant, which is a tricyclic antidepressant, doxepin or Silanor. With this one, again, we want to start with the lowest dose possible. But I do want to emphasize doxepin, just like our benzodiazepines and non-benzodiazepines, this is not the most attractive medication to recommend to our elderly population. We would actually consider this to be probably the last possible choice after your benzodiazepines and your non-benzodiazepines, and that's just due to the highly, highly anticholinergic effects of doxepin. So it can cause QT prolongation, cognitive impairment, orthostasis, dry mouth, blurred vision, and urinary retention. And so I do want, on this slide specifically, I listed that it was on Beer's criteria, and again, that's due to that anticholinergic and sedating effect, And so also that risk of orthostatic hypertension. Another thing is that doxepin or your TCAs altogether have a very, very, very narrow therapeutic window. So again, at increased doses are increased risk of QT prolongation. So again, emphasizing that maybe this isn't the best option to give to a patient that may be experiencing depression and insomnia. This is more so worst case scenario, nothing in this world probably can help this patient. And again, we want to avoid in older adults who have a history of falls or fractures. And a possible side effect is like SIADH that could possibly happen, and hyponatremia, so to monitor sodium levels. JT's back. His physician actually decided to start him on some mirtazapine. His six-pack started to go away, and he did not like that, so he wanted to see if there was another medication he could get. And so they decided to discontinue his medication, and they wanted to ask us for a recommendation. So what would be the next best pharmacological treatment option to initiate in JT? Is it doxepin, PO-HS, PRN? Is it trazodone, PO at bedtime daily? Is it fluoxetine, PO at bedtime daily? Is it Zoloft, PO every morning daily? Or is it Parnate, PO at bedtime as needed? Yes, B. Again, if I were to just choose another medication like not trazodone and put, let's say, Cymbalta or something, doxepin also is not an attractive option because it says PRN. So again, when we're treating patients with insomnia and depression, the purpose is to have them take it on a day-to-day basis, not on a PRN basis, as you would see with your other medications. The next question is, which of the following is our appropriate counseling points a pharmacist should relay to a patient picking up a new prescription for trazodone? Is it A, look out for signs and symptoms of serotonin syndrome like rapid heart rate, high blood pressure? Or is it B, look out for triglyceride levels and they should be monitored? Or is it C, report to the emergency department immediately if you experience an erection longer than 4 hours? Or D, A and C, or E, all of the above? Yeah, D, A and C. So next we have our benzodiazepines. The biggest thing with our benzodiazepines is the fact that it is a scheduled medication, it's controlled, but not only is it controlled and it has a risk of addiction, misuse, and abuse, but it also has a black box warning. The black box warning is associated with the concomitant use of benzodiazepines and opioids. Again, anything that depresses your CNS system, we don't want to combine those two medications together. So you'll see, and specifically in elderly patients, they'll probably experience more profound sedation, respiratory depression, coma, or even death. What's, I guess, really cool about the benzodiazepines, or important to take note of, is that there aren't any renal or hepatic dose adjustments specifically for the agents that are FDA approved to treat insomnia. Some side effects, again, since they are used to induce sleep, drowsiness and sedation as the side effects, but some patients actually complain about hyperactive or aggressive behavior. So that's also a side effect that has been seen when patients are taking benzodiazepines. So this is a list and a chart of our benzodiazepines and the different doses. I'm not going to really stress the doses too much, but understanding we want to use the lowest dose possible for the shortest period of time when we're dealing with benzodiazepines. Again, lowest dose, shortest time possible. So we have temazepam, trazolam, quazepam, astazolam, and flurazepam. And just some clinical pearls and some counseling pearls. Benzodiazepines are on Beer's criteria, and that's due to the increased risk of impaired cognition, delirium, falls, and fractures. Again, our older patients actually have an increase or a change in the GABA neurotransmitter system, so they have increased sensitivity to the actual side effects that are seen with GABA. Another big thing is, since these are more prone to side effects in our older patients, a long-acting agent is just not the best option. Our long-acting agents that are available are flurazepam and quazepam that are FDA approved. So again, we would not want to use that in our older population. Another thing is avoiding in patients who actually have a history of substance or alcohol abuse. Again, we don't want to give someone who has a history of an addiction to build another addiction. If only if you truly need to start a benzodiazepine in an elderly population, again, lowest dose, shortest period of time possible. It is recommended 4 to 5 weeks max if for whatever reason you really want to use a benzodiazepine in an elderly patient. And another big thing is using your short-acting benzodiazepines. One of them is temazepam, so that is a recommendation that could be made for patients who may possibly need a benzodiazepine for insomnia. And another big thing is gradually tapering patients on GABA. Again, they may experience withdrawal symptoms if you automatically discontinue the benzodiazepine and not gradually taper after long-term use. Next, we have our non-benzodiazepine receptor agonists. We have esopicolone or Lunesta, Xalapone or Sonata, Zolpidem or Ambien. We also have Ambien controlled release, Intermezzo, Edler, and Zolprimis. And these are all taken before bedtime. There's one that's different, and I'll go into that when we talk about the counseling pearls. But the non-benzos also have a black box warning, but their black box warning is for complex sleep behaviors. So there are actually patients that complain about sleepwalking, sleep driving, or just doing weird things while not fully awake. This is also a controlled substance like your benzodiazepines. These are Schedule 4. And with these, there aren't any renal adjustments that need to be done with any of them that are FDA approved, but there are some hepatic dose adjustments that are recommended for the different agents. Some side effects, very similar to your benzodiazepine, but of course, less adverse effects and less side effects compared to the benzodiazepine. But again, you'll still see that drowsiness and sedation. So just some clinical pearls or counseling pearls on your non-benzodiazepines. They are also listed on Beer's criteria, and that's due to increased risk of impaired cognition, delirium, falls, and fractures. And again, just like your benzos, if you truly need to start one, use the lowest effective dose for the shortest period of time, 5 to 4 weeks. There's actually different formulations, so for patients who may not like to swallow a pill, you could use a sublingual formulation or an oral spray, and if they're taking the sublingual form, do not use it with water. Ambient controlled release, as for many controlled release formulations, do not crush and chew, except the ones that don't fall in that category. We have Zolpidem. It should be taken immediately following a meal. So it's just been seen that you have better absorption and better effects when you're taking it after a meal. Intermezzo is one of the formulations and one of the different brand names, and it has the word as needed because, of course, all of these are as needed, but Intermezzo has been seen to be beneficial for patients who actually wake up in the middle of the night and are having a hard time actually going to sleep. So specifically for those type of patients who actually had sleep initiation, but they woke up in the middle of the night for whatever reason and can't actually go back to bed. So Intermezzo has been seen to be beneficial for that specific purpose. Esopicolone has the longest half-life, so of course it's not the most attractive to initiate in our elderly patients. And then we have Zolprimis, which is the oral spray, and with many agents that are oral, you should prime them first before actually using them. So with your Zolprimis, it's important to counsel patients to prime before using. So there was another research that I saw that was pretty cool, the trends in prescribing of sedatives. Specifically, the research was done from 1993 to 2010, and they basically want to see the prescribing of your benzodiazepines compared to your non-benzos. And so they examined about 520,000 patients, and they used a survey. And based off that survey, they were able to categorize patients based off the way that they answered them, so non-BZD or BZD. What they saw was that the benzodiazepine and non-benzo, the proportion of prescribing increased, but what decreased was the use and indication of benzodiazepines specifically for insomnia. So yes, there was still an increase of benzodiazepines being prescribed, but when it came to specifically for insomnia, there was a decrease. Again, the decrease was like 1%, but again, they saw that decrease, and it kind of showed how the use or the implication of adding non-benzodiazepines kind of, I guess, decrease the use of benzodiazepines being treated for insomnia. And so, again, the trial consisted of patients from 18 to 70, or 18 and plus, there wasn't a cutoff, and 30.8% of them were actually 65 and older, and they were prescribed sedative hypnotics. But again, the conclusion was that the introduction of your non-benzos did likely result in the decline of benzodiazepines being prescribed specifically for sleep disorders. But again, as I mentioned earlier, many of our people don't just have one issue, they have many other issues. So it's very hard to actually see the real true outcome of the study itself. So next we have an assessment question, which is, what is the best way to avoid tolerance and dependence in a patient? Is it A, use high dose for a long time? Is it B, use high dose for a short time as possible? Is it C, use a low dose for as long as possible? Or is it D, use low dose for a short term? Or is it E, initiate with a low dose and then titrate to a high dose? Yes, D, low dose for the shortest period of time possible. Again, the recommended is 4 to 5 weeks. JT mentioned to his primary care physician that when he was first diagnosed, another physician prescribed him a medication that caused him to sleepwalk. Which of the following medications would cause this adverse effect? Is it temazepam, Silanor, Remeron, Ambien, controlled release, or Deseril? Yes, Ambien. So that was seen more so with our non-benzodiazepines. So we're almost done talking about the last two new agents that came in to try to help alleviate some insomnia. We have our orexin receptor antagonist, or suvorexant, or brand name Belsomra. With this one, the max recommended dose is 30 milligrams, and it's not beneficial for patients who are actually experiencing hepatic impairment, severe hepatic impairment. So this is not an agent to use in that population. Some side effects are drowsiness, abnormal dreams, cough, and CNS depression. And so with the administration, research and studies have shown that when taking it, the onset is quicker if it's not taken with a meal. So telling patients, try to avoid eating prior to taking this meal because it decreases the absorption and the effects that they're looking for. And last, we have our melatonin receptor agonist, which is Remilton or Rosarum. The biggest difference between this medication and melatonin is just the higher affinity for your melatonin receptor agonist. So they have a higher affinity to the melatonin receptors. And so, i.e., that's why they decided to create the medication. This one is this should be administered 8 milligrams within 30 minutes of bedtime, and it's not recommended to use it for more than 3 months. So this isn't the best agent also. With the last two agents, the other thing about them is they're very expensive. When a medication is new, they're expensive and they're just not prescribed as often, so they're not attractive. But also, melatonin receptor agonists, there's really no difference with the effects compared to someone who's taking melatonin over the counter. So again, what is the point of me paying X amount of money for a prescription medication when someone can go over the counter and get melatonin? With your receptor agonists, there are side effects of dizziness, CNS depression, hyperprolactinemia, and decreased testosterone. With this one, it should be administered before bedtime, but to avoid with high-fat meals, because also it has been seen to actually decrease the absorption of the medication. And so to conclude and just to talk about the role of the pharmacist, which is always important, we want to consider certain factors when choosing the most appropriate agent. So symptom patterns, past treatment response, patient preference, treatment cost/availability, comorbid conditions. We also want to closely monitor for impaired cognitive and or motor performance. We want to recommend any dose adjustments whenever recommended. We also want to manage for any polypharmacy. Again, we don't want to add more medications on a patient's list when they do not necessarily need it. We want to minimize any drug withdrawal symptoms. So again, tapering the medication or recommending a taper and not suddenly discontinuing it, and just educating the patient on signs and symptoms of adverse and side effects. It's always important to tell patients what to look out for, so when it does occur, they're not alarmed and confused as to why this is happening. So we have our last question. Dr. Larry Robertson at FAMU Hospital decided to start a 72-year-old woman on Rosarum to treat her insomnia. He wanted to consult with the pharmacist prior to writing the prescription. What are some factors to consider as the pharmacist when choosing an agent? Is it A, past treatment responses, B, cost and availability, C, symptom patterns, D, A and C, or E, all of the above? Yes, E, all of the above. Again, we want to take into consideration all of those factors when prescribing a patient medication. Again, especially with Rosarum, since it's one of the newer agents, it is expensive. It doesn't make sense why we would prescribe that to a patient when there are other attractive agents on the market. So in summary, just to conclude the presentation, insomnia is common in the older generation or the older population, and usually it results from multiple factors. So basically it's been seen that insomnia in the geriatric population usually isn't attributed to actual insomnia disorder, but there's actually something underlyingly contributing to that insomnia that they're experiencing. So whenever counseling a patient, always includes sleep hygiene practices, whether it be to sleep in a cool, dark room, don't sleep with any noise, or whatever works best for them to be in a more relaxed state. Again, when treating patients or whenever making recommendations, always emphasizing non-pharm therapy. Again, it has been seen non-pharm plus pharm gives a better response than pharmacological therapy by itself or non-pharm by itself. If in that case of scenario. Again, benzodiazepines and non-benzos are potentially inappropriate, so they should not be used. And if they are used, to be used with caution. Again, these populations are at an increased risk of actually experiencing side effects and adverse effects, so again, we don't want that to occur. Another big thing, again, minimizing withdrawal symptoms. We don't want to abruptly discontinue any agents when not needed to. And when prescribing a drug for a patient, remembering that every patient is built differently, so what may work for one person may not work for the next person. So again, making sure that each therapy is individualized. If you have any questions, comments, and concerns, this is my email. You can email me and I'll try to respond. I guess this is the end of the presentation. If you guys have any questions for me, I can answer now. Yes. Yes. Mm-hmm. So your question is, just to first answer your sleep apnea, I was told that I only had 1 hour, so my presentation was actually longer, but I had to cut it off because there are certain things I have to emphasize, and for the purpose of this symposium, I only had 1 hour, so I had to emphasize more in my presentation on insomnia. But the second question was, what is another option for patients who actually are diagnosed with insomnia disorder and benzo? I didn't hear the last. Yeah, so in that case scenario, because in reality, the real world, many people do not follow guidelines to the T, because as we understand, it's just a blueprint. So again, with the benzodiazepine, worst case scenario, if they do have to be on it for a long period of time, again, the biggest attraction is to use a short acting. Again, if for whatever reason you may have to use a non-benzodiazepine, not using controlled release. So looking at the better options that are in the drug class specifically. Any other questions? Mm-hmm. Right, correct. I agree. I don't know, did everyone hear him? I don't know if anyone wants me to repeat what he was saying. He just wanted to emphasize the importance of making sure that we're represented in all trials and that we matter. The minorities, how we respond to certain medications is important. Anybody else have any questions, comments, or concerns? Yes, ma'am. So the max recommended is 3. Okay, so they do give 6 milligrams, 9 milligrams, even 10 milligrams, right? Again, it's recommended to just stop at 3 milligram, and that's just based off of research. But again, we do see higher doses being prescribed. So again, it's very hard to control that. But yes, it's not recommended to go past 3 milligrams. But again, you do see sometimes 6 milligrams, 9 milligrams, or 10 milligrams, or sometimes there's formulations of 5 milligrams. So again, just depends on the prescriber and how much you may know about melatonin, so you can make a clear recommendation as a pharmacist. But again, the studies just show that lower dose is more effective, that you don't have to go as high as 3 milligrams or even 6 milligrams sometimes. But the pharmacist consultant article said 3 to 6, yes. I do not know the treatments that actually correct circadian rhythm, and that's only because I did not go into deep. Are you talking about specific circadian rhythm like sleep disorder, like DSM-5? Yes, I do not know the exact treatment option for that. But usually I know with circadian rhythm, whenever it is interrupted, usually they tell patients to either switch any patterns that they may be doing, so whether it be that they work nighttime shifts, things like that, anything that they're doing on a day-to-day basis. But I don't know any specific agents, unfortunately, I'm sorry, but I could get back to you on that. Any other questions? That's all. Thank you guys, and I hope you guys enjoy the rest of your day.
Hi, everyone. I'm Dr. Thompson, or Sam. I'm the chair of Symposium. I can't tell you enough how I appreciate you guys coming out, and I hope you guys enjoyed this weekend. Before we go to a short break, I know the best part of Symposium are those such fun surveys that we have to give you guys. I know that's your favorite part. We're doing something a little different this year. We're going to do something that takes 2 minutes right now, and it's just called a gap analysis. So I just want to know if, in general, you guys walked away with more than what you came in with. Oh, yeah? Okay. How did we feel about the hottest topic right now, which is alternative medicine and medical marijuana? That was great. It's fabulous. What I need to know is how many of you all think you are going to take that into your practice, or you are going to further investigate that. This is with MMRI right now. That's the biggest research we're doing on FAMU campus, which is medical marijuana under Dr. Green-Powell. And so it's a huge topic. So I wanted to know if you guys are interested in learning more about it. You are? Okay. Is anyone interested in learning more about dispensaries being open and the pharmacist interaction there? Because there is a lot of money in there. Yes. You guys heard money, you're like, yes. Okay. What other topics do you want and need to know about? Anything you've heard in the pipeline? Because that's what we'll incorporate next time. Anything at all? Or anything that you heard about that you'd like us to elaborate just a little bit more on? Yes, sir. So are you asking when is like that presentation that Dr. Hill did, when is that coming to Jacksonville? Whenever you want. Okay. You and I can talk offline because I do have something interesting to add to that. August. Okay. So we can add that too. Are you talking about with the consultant? Now I see what you're saying. Yeah, we can do that. We can definitely do that. That's really smart. Yes, Miss Hattie. I was. Yes, I was on the panel. So that's why you did? Oh, friend. Miss Hattie's so delightful. Yes, and then we're doing it again in Gainesville. So I can't emphasize enough, this medical marijuana is blowing up. It's like exploding right now. So we'll probably repeat and elaborate more on this. And Dr. Hill just did a fantastic job. So I hope that she continues to travel with this knowledge. So what other topics have you heard? What other topics do you think in your practice you could use, because we'll add that in. Toot sweet. Oh, don't be shy. We're all friends here. Yes, ma'am. Infusion practice and specialty. Okay. Yes, ma'am. Infusion too? Can you elaborate? Okay. 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 So we said infusion, injectables. Yes. GI and gut disorders. Excellent. And yes, right behind her. Uh-huh. Okay. I would love to hear about that as well. We will find out. And then you and I can talk about any recommendations as speaker-wise, who that could be. Anything else? Yes. I'm sorry? Okay, like evidence-based medicine. Okay. It's always a good idea. Yes, ma'am. Cute, yep. Okay. And transgender health? Yes, that's actually my specialty. Maybe I'll come and bless y'all with that knowledge. Maybe so. Okay. So even just a more unpopular opinion, what are we tired of hearing about? What do we not want to hear about anymore? Like we're tired of it, outside of the mandatory. Okay, you don't want to really hear about any diabetes anymore. Okay. Okay. Anything that doesn't necessarily apply to your practice or in general. Because I just don't want you to sit here bored. Yes. Absolutely. Mm-hmm. Yes. Yes. It's difficult because we are one of the people. Me and Dr. Journay and Dr. Alexis, we are recent grads, and the reason why we do stay so close to FAMU is because we are fostered with great mentors here, as well as we are employees and we're residents here. But outside of that, it is extremely difficult. I'm president of IndyPAC in Jacksonville. It's even hard to get my colleagues to come to meetings. And I don't know if it's just a microwave society of we get most of our CEs on the internet. So that's a part of it. I just don't think, there's no, I don't want to say it's impossible. I don't think it's impossible at all. We've tried different marketing strategies, like making this like a homecoming event for pharmacists, for, different classes, and that worked a little bit last year. I don't want you to feel like the younger generation is not involved in the career of pharmacy and represents FAMU. But a lot of them would rather catch it locally and online than come to Tallahassee. The hardest part is just getting them to Tallahassee. If we get them here, then they'll fall in love with it all over again. but it's not impossible, but it is very difficult, and I know you've noticed that. But we have our marketing. That's the biggest thing that we're working on in the Office of Continuing Education, is just marketing and getting the younger generation, the younger pharmacists, to be a lot more involved. Yes. I agree with that too. We spend money on what we want now. We sure do. And I'm not here to give excuses because I am a younger generation person. But at the same time, it's we spend money on what we want, and we're trying to basically train our minds into letting them know this matters. Like Symposium matters. This is where we reconnect. Because I'll tell you, our generation, we're quick to say, oh, there's not a lot of jobs out there. There could be if you come to Symposium and network and connect and give back to your school. And donate. But child, you can't tell grown people nothing no more, so it's fine. Also, something that we've started is this is all recorded, so we're packaging this as well. Like when you get on freece.com, this is a package as well. So we're working on making sure that that's packaged properly. But I have those same concerns, sir. That's a huge concern of mine. Even my classmates that live here. It's like, why can't you, if I give you the save the date a year ahead of time, come, but then, it's a multifactorial issue that we can handle. We can definitely strategize. And if any of you guys have any suggestions, please email me. Yes. Okay. Would you guys be okay with that? Because one of the things I had issues with, not issues, I'm flexible, but I work around you guys, and Symposium has been in February for a million years. And it was a big deal when we changed it to March last year. So if y'all are okay with that, y'all let me know. But if you're not, we're not going to change it. Yeah. Uh-huh. We sure do. We sure do. Yes. Yes. It really does. They did great. We do have a person amazing hire, Mr. DeBose. He's been walking around with the camera. That was an amazing hire from Dr. Early. He is our marketing strategist. I'm excited to see what we got planned from him in the next couple of years. Yes. I'm sorry? You're going to have to ask some of my clinical faculty colleagues. Yeah, she's here. Yeah, oh yeah, I don't want to make it seem like they're not here. They're here and they're very dedicated. But I can't speak for them because I'm not them. So, yes. Yes, sir. Mm-hmm. It did. Yeah. I did. And we did have that showcased on Friday from mhm. Basic sciences. Is that what you're referring to as well? Industry. Okay. Okay. That is actually an amazing idea. We could possibly incorporate that, which would take time, like now. We could get that ready for next year. Mhm. Correct. I agree with you. And then we can definitely look into that. But as far as like what we can do now, I think overwhelming. What I'm hearing, an overwhelming response is getting more people involved. Is what I'm hearing. Is that correct? We would like to see that. But otherwise, this conference, as far as knowledge, you guys feel like it was competent. Oh, wonderful. That's so great. If you guys have any other questions or comments, that's what I'm here for. I would love talk my ear off before I drive back to Jacksonville. Okay. Yes, Dr. Davis. You would like that. Okay. Okay. Do you think, in your opinion, there would be a lot of the younger generations too, like 2000s and up, in general? Yeah. Also, in general. Oh, wow. Okay. So we can talk about that. Absolutely. We can talk about just incorporating that down. Oh, wow. It's a different population. Yeah. Wow. Okay. And maybe we can incorporate that with you and we can talk because then I'd like to go down there. Okay, well, we're going to go ahead and move it. You can, I'm going to find you. Yep. We're going to go ahead and move to Dr. Brianna Jornay, who is HIV extraordinaire. I know you guys are really pumped. She's going to talk about PrEP and PEP and post-exposure. So I hope you guys are ready. I'd like to have Dr. Southard introduce Dr. Jornay. It's okay to clap, because we clap.
Oh, yes, you can clap twice. Okay, Dr. Brianna Jornay. She was a graduate of the FAMU College of Pharmacy in 2016. She also got an MBA in 2017. Matter of fact, she was the first student to complete that dual pharmacy MBA degree, which was introduced back in 2010. She completed her 2-year postdoc with the FAMU Leon County Health Department, serving as the AIDS Drug Assistant Program Pharmacist, dispensing meds, medication therapy management to patients, facilitating lectures for pharmacy students on topics such as HIV. Matter of fact, she is credentialed with the American Academy of HIV Medicine. She's currently an assistant professor here at COPS IPH. Her research interests, HIV/AIDS, health disparities, health outcomes, pharmacy management and leadership, and she's an outstanding community advocate interested in community outreach. So we will now hear from Dr. Journay.
All right, so I am what is standing in between you guys and lunch. So I'm going to try to make this quick. And I kind of want to make it a little bit informal. I don't want to lecture you guys. So if you have questions like in the middle, please feel free to, raise your hand and I'll kind of come to you and I can kind of address it. Or you can wait till the end. It's up to you guys. So I am going to talk about pre-exposure prophylaxis and post-exposure prophylaxis, and I'm not sure if the recording needs me to stand here, if I can walk around. But, of course, I don't have anything to disclose, and you guys can look in the brochure to read the objectives. But just a general overview of what HIV is. So we know that HIV is a retrovirus that attacks our CD4 cells, which is the cells that help fight off infection, okay? So when the CD4 cell is infected with HIV, once HIV replicates, it kills off that cell. So it's not like the cell is like recovering. It kills off that cell, and now you have less cells fighting for your immune system. So that is why when HIV goes untreated, those individuals cannot fight off things that, we can't, like the flu. So eventually it can lead to AIDS, and just so that you guys know, an AIDS diagnosis is a CD4 count less than 200 or a CD4 percentage less than 13%. Or an AIDS-defining illness. And an AIDS-defining illness can be PCP, toxoplasmosis, anything like that. All right? So this is just a picture of the life cycle of HIV, okay? So I know I'm going really fast, so bear with me. But as you can see, it's numbered. So that little ball at the top, does this work? Yes. Okay, so right here is the HIV virus, and it is going to enter the CD4 cell at these receptors. This is the CD4 cell, this orange thing, okay? It's then going to insert its genetic material into the CD4 cell, okay? So it's RNA. It's then going to transcribe its RNA into DNA, and then it's going to then integrate the viral DNA is integrating into the CD4 cell DNA, so that when the CD4 cell is doing its normal cell cycle of replicating its DNA, it's actually replicating the HIV DNA, all right? It then assembles and kind of goes out and matures to go infect another CD4 cell. So that's what's happening. You see that there are numbers. What's important to know is that at each of these numbers, excluding 5 and 6, these are where the medication classes are working for in HIV, okay? So if you don't know, an HIV regimen is usually composed of 2 drugs, an NRTI, or nucleoside reverse transcriptase inhibitor backbone, and so that's stopping at this point, and then usually it's in a third additional agent, and that third additional agent usually comes from here, the integrase inhibitors, or here, protease inhibitors, okay? So that's when you have a complete HIV regimen for an HIV patient. So in pre-exposure prophylaxis, and post-exposure prophylaxis, but pre-exposure prophylaxis, which is you are preventing yourself from contracting the virus before you're exposed to it, the drugs that they're using is working right here at number 3. So they're reverse transcriptase inhibitor, nucleoside reverse transcriptase inhibitor, and they're working right here. So it's stopping the viral RNA from transcribing into DNA, okay? So, HIV transmission, I hope we all know, it's transmitted through bodily fluids. So that can be blood, that can be semen, breast milk as well. Obviously, when a baby is born vaginally, that vaginal fluid is also a way that it's transmitted. So here's an assessment question. What specific cells does the HIV virus infect? C. I heard C. The consensus sounds like C. So yes, CD4 cells is what it's infecting. So it's important to know that you cannot get HIV from tears, saliva, sweat, or urine. Okay, so yes, they are bodily fluids. However, you cannot contract the virus from someone crying or sweating near you. Okay, and so I think that's very important because when we are talking about HIV prevention, stigma is a big part of it. Okay, so we have to make sure as healthcare providers that we are not kind of giving into that stigma And so I have patients who have cried on my shoulder. I have patients who, have come in, and I'm not going to treat them any differently. If they need a hug and they're crying on my shoulder, that is fine. I'm not going to contract the virus that way. So diagnostic testing. So there are 3 types of diagnostic testing that we do for HIV. It's antibody tests, combination tests, which are antibody and antigen, and then we do the nucleic acid test, which is kind of the confirmatory test. You guys may have heard of it as Western blot. So in the field, I guess you can say, what we're using is the antibody test. When we do the rapid test and they take a little prick of your blood, they're doing the antibody test, okay? So the antibody test, it can take up to 3 months for those antibodies to show up with those tests. So it's important to stress the fact that patients, when they come to get tested, that they're coming and repeating the test, at least every 3 months, just to make sure that they haven't seroconverted. Combination tests, they're a little more sensitive, so they can detect a little bit sooner than the antibody test. They're more expensive, so we don't really see them out in the field as much. And then the confirmatory test, we do that when we get a positive antibody test. So when we get a positive antibody test, we still tell them that, you have a positive antibody test, but we still have to do a confirmatory test. Now, the testing that we have, the 4th generation tests, are very accurate. So the chances of getting a false negative are really low. So it's important to not give patients a false sense of hope. So yes, we are going to do a confirmatory test after they've done the antibody test, but we don't want to give them a false sense of hope. Like, oh, we still have to do the confirmatory test. You may be okay. Because honestly, I have not gotten a false positive in the last 3 years. Personally, I haven't. I mean, of course, I haven't tested everyone in Leon County, but I have not gotten a false positive. The antibody test, yes. So that's what we're doing in the field, the rapid test, where we don't even use the OraSure anymore, really. We do the rapid test. You get the results in less than 15 minutes. So in the assessment question, HIV cannot be transmitted through sweat. Yes. So it can be transmitted all the other ways. All right, so prevalence. So the CDC estimates that about 1.2 million people in the United States are living with HIV, and almost half of those people are African American, okay? So as you can tell, it's already something that's an issue that's disproportionate. We're only supposed to make up 13% of the population, yet we're making up over half of the diagnosis. And then 1 in 7 people don't even know they're infected. So that's why it's important to continue to get testing. A lot of times it's important to stress, even if you're married, people come into the clinic, they've been married, but then it's like, I have HIV. So you don't think about those things, but you do have to discuss that with your patients, no matter what their situation is. They can be in a monogamous situation, but we still want to stress the importance of getting those tests done. I know even for women, when we go in for pap smears, some of the testing, if they don't see anything abnormal with your pap cells, they won't necessarily do the additional things, especially if they know that you're married. But it's important to just have them kind of send that off as well. I mean, you're already there anyway, so what is it going to really hurt to get that extra test? So of all African Americans living with HIV, 85% received a diagnosis. Great. 60 received HIV medical care. 46 were retaining care, and only 46 were virally suppressed. Okay, so obviously that's another issue. So that is another example of us being disproportionately affected by this disease. Okay, or this virus. I'm sorry. So we have to make sure that we are stressing the fact that once you get a diagnosis, you are getting into care so that you can be treated, because treatment is also a form of prevention. So even if a person is diagnosed with HIV, them being treated is a form of prevention, because the goal is to get them undetectable so that they cannot transmit the virus to someone else. Okay, so a lot of times when we think of treatment, we think of prevention, we're thinking about prior to or before they get it. But prevention involves those who are affected with HIV at the moment as well. We want them on treatment. So prevalence in women. Since it's Women's Month, March, I thought I would put some of these statistics specifically pertaining to women. But we account for 1 in 5 diagnoses, and African American women make up 62% of those. So again, African American women are disproportionately affected by this. Lifetime risk of contracting HIV in African American, it's 1 in 48. Okay, and then in our Hispanic counterparts, 1 in 256, and in our Caucasian counterparts, 1 in 880. Yes. And so I'm going to kind of talk about it a little bit, but one of the reasons is because we're not receiving the same amount of care. So when HIV became a thing in the 80s, and, everyone was kind of scrambling around, it was found majority in white gay men, okay? And so they were getting into care, getting treatment. And so now you have a population that knows nothing about it. And so they're not getting the same treatment. And so there was a study done that showed Black men and Hispanic men were less likely to be recommended PrEP, which is what I'm going to talk about, but they're less likely to be recommended PrEP by their primary care provider. So Black men and Black women, we're going to the doctor. If we're not a healthcare provider, if we don't know that this is even available or this is even a thing, how are we supposed to get it? So if our primary care provider isn't offering it to us or telling us about it, we can't even be educated on it to even know. So I think lack of education in our community is one of the biggest things. We're not being offered certain things. We're not, they're not telling us about certain things, so we're unable to kind of help ourselves. And then there's also, historical, we don't go to the doctor. You can go as far back as, to Tuskegee trials, and the distrust in, healthcare. But there are a lot of reasons. But one of the reasons is because we're not kind of sometimes being offered those same resources. So lifetime risk, and so I stopped that, I'm sorry. Caucasian counterparts are 1 in 880. And then in the state of Florida, 6 babies were born with HIV in 2014, which sounds good. 6 isn't a lot, but with the medication that we have today, that number really should be 0, okay? So you can be HIV positive and give birth and give vaginal birth. That's another thing. It does not have to be a C-section. You can give vaginal birth to a baby, and that baby can come out without HIV, okay? So even though that number 6 does not sound like a lot, it should definitely be 0 with what we have. So lifetime risk for African Americans overall, it's 1 in 120 for men, 1 in 148 for women. Caucasian, 1 in 132 for men, 1 in 880 for women, like I stated. And then in men who have sex with men, and this just doesn't matter the race, it's 1 in 6. Clearly, they are at a little higher risk. And then Black men who have sex with men, 1 in 2. Latino, 1 in 4. And then white is 1 in 11. And then injection drug users, 1 in 23 for women and 1 in 36 for men. And so going to injection drug use, I just want to kind of talk about it because a lot of times we automatically assume it's illicit drug use. But there is a population of people who are injection drug users, but it's not illegal. So think about communities with senior citizens who may not have a lot of resources. They don't have, or they're underinsured. They don't have supplies for diabetic materials. So there have actually been reports that those communities have been sharing diabetes supplies. So we don't even think about that. A lot of times we just think of heroin, methamphetamine, different things that people inject illicitly, but it's also involving that community of people who may share diabetic supplies or needles. So, of course, the most affected subpopulation. So this is just a graph kind of already describing what I said. So Black men who have sex with men are the most affected or most at risk, followed by Hispanic men who have sex with men, followed by white men who have sex with men, followed by Black heterosexual women, okay? And then it goes on and goes down from there. And then this is also just kind of showing you a graph of how many cases are made up of men who have sex with men versus heterosexual contact. And then it divides it up by race. So again, men who have sex with men, we know is the most affected, and then African Americans are the most affected race, followed by Latino and then white. And then those little triangles in there are like Asian, I think like Native American and Pacific Islander. So by state, this is showing by state. So if you can see Florida, we are ranked number 3. In the country, and this is by 100,000 people in the population, per 100,000 people, okay? So Florida specifically, so 1 in 150 adults in Florida are living with HIV, and then the statistics break it up by race, so 1 in 292 whites, 1 in 49 blacks, 1 in 49 blacks, and then 1 in 156 Hispanics and Latinos, okay? There were almost 5,000 cases in the state. This is all from 2018. They haven't released the 2019 data yet. And then I have the counties that kind of are affected the most. Leon is not one of the counties that is affected the most, but because we're in Leon County, I decided to include it on there. But there were 81 cases in Leon County in 2018, which was an increase from 2017 because there were only 65 cases. And so, as you can see, we're trying to make strides to help this issue, but it's still an issue. Numbers are going down nationally. However, there are still numbers that are increasing in certain areas. So, and this just explains the same thing of what I'm saying. Look, the blue line, the blue bar of the graph is showing the population of the United States, and then the orange line is showing the AIDS diagnosis, and the yellow line is showing HIV. Okay, so as you can see, the black population, it says 15% on here, and this is from the state of Florida. I don't know, that number could be a little off, but it might be right. So 15%. But we're making 49% of AIDS cases, and usually that's because we're not getting into care. So we're not being diagnosed. So we're not getting tested, we're not being diagnosed, and by the time we do go to the hospital, it's already progressed to AIDS. Okay, and then we also are leading with HIV diagnosis as well. So which of the following populations are most at risk for HIV contraction? You have African American heterosexual women, African American men who have sex with men, Hispanic men who have sex with men, or white men who have sex with men. B, yes. Followed by C, and then D, and then A, yes. All right, so let's get into it. Pre-exposure prophylaxis. Again, before your exposure, and then prophylaxis is the prevention, right? So PrEP is HIV prevention for those who are HIV negative, and it's really important that they are negative because, of course, if they're positive, we then want to get them into care, and we want to get them on a full regimen. But they may be at increased risk for contracting the virus, okay? So, and I'm going to go into it in the next slide. I'll save it. But the combination of two drugs that blocks the HIV infection from spreading in the body. So it's one pill, but there are two drugs in it. It's a combination product, okay? It must be taken every day to ensure that enough medication is in the bloodstream to fight a potential infection. So the goals of therapy are to decrease the risk of HIV negative patients from contracting it, as well as decreasing the prevalence and death rates, okay? So think about PrEP as birth control. Okay, you don't want to have an unwanted pregnancy, so you take this pill every day to prevent that, all right? And then PEP I'll get into, but think about that as plan B. You've already had exposure, or you already had the sexual intercourse, and now you're trying to stop it from progressing. So evidence of need. So PrEP approval, the drug that we use for PrEP is Truvada. It was approved prior for treatment in HIV patients. So it's not a new drug, but in 2012, it was approved for specific use for pre-exposure prophylaxis. Okay, and so according to the CDC, approximately 50,000 people were being affected with HIV each year. So this is kind of showing us, okay, there is a need for it. People are still being diagnosed with HIV in high numbers, so what can we do about it? And so between 2008 and 2012, the incidence kind of remained stable amongst heterosexuals, injection drug users, and most races, but it still was increased with men who have sex with men, of course, affecting African American men the most, and then also adolescent and young adult, that rate also increased. Okay, so among the 25% of persons newly infected through heterosexual activity, 66% were African American men and women. This data indicated a need for additional methods of HIV prevention to further reduce new HIV. So I'm not going to go deep into the trials, but they did look at 3 different population types: MSM population, heterosexual population, and then injection drug user population. And so these are the trials that pretty much got this drug approved. And then IPREX, which I circled, is kind of what I'm going to talk about and where we're getting the numbers from as far as reduction rates. All right, so it was about 2,500 people or negative men, and half of them received placebo, half of them received the drug. And during the follow-up, 100 of them became infected. All right, and that was 36 in the those received the drug that became infected, and 64 became infected in those that were receiving the placebo. Okay, so there was 44% reduction in the incidence of HIV, which does not sound like a lot. But it's important to note that what they did was they went back to those patients that were on the drug, and they did serum levels. So they checked to see who actually had a therapeutic amount of the drug in their body, because when you're doing clinical trials, we don't know if the patients are adherent, are they taking it how they're supposed to. So then they went back and they did serum levels. And so they found that of the people who became infected, so it said 36 people became infected that were supposed to be taking the drug, right? But actually, after they did the serum levels of everyone, only 3 of those people became infected had the correct serum level. So that's where they're going to get the real reduction rate. So yes, 36 people became infected. However, they weren't taking it correctly. So out of those taking it correctly with the actual right amount in their system, only 3 became infected. Okay? So this is just talking about the safety of it, adverse effects. And we kind of know this already from the clinical trials when it became approved for HIV treatment. So usually patients are going to experience nausea, headache, fatigue, and a lot of times those subside within like the first 2 to 4 weeks. So it's important to kind of talk to patients and let them know, continue to take the medication, see if they subside. And then if not, of course, we'll discuss a different therapy, but a lot of times the side effects will subside with patients. So in conclusion, the Truvada provided protection against the acquisition of HIV infection. And what's in Truvada is emtricitabine and tenofovir disoproxil fumarate, or TDF. So I'll get into that in a couple slides as well. But detectable blood levels strongly correlated with the prophylactic effect. So that means that when they did the blood test in the patients who were supposed to be taking the medication, they found a strong correlation that they were protected, pretty much. So the reduction rate increased from, I know we saw 44% initially, but when they took those patients who actually had the drug in their blood, it was 92%. So that's why we say it's going to decrease your chances of contracting the virus by over 90% when you take it as prescribed. Yes. Yes. So I want to say the biggest one was right here with nausea, actually. But it's usually nausea, headache, and fatigue that's usually experienced. And they usually subside within 2 to 4 weeks. Yes. So updated prevalence. So remember before I said that 50,000 people were being diagnosed with HIV prior to PrEP approval. So the updated prevalence in 2018, 37,832 Americans were diagnosed with HIV. So since the approval of PrEP, there's been a 25% decrease. So that shows that proper prevention works, right? This drug is working when people take it as it's prescribed. So eligible patients. The short answer of who can take PrEP is everyone. I can take it. You guys can take it. Pretty much everyone who's sexually active, okay? But when we are talking to patients, we do, target certain patients, especially those who are having or showing risky behaviors. So if there's a patient who's coming in for an STD screening and they're coming in often every 3 months, or they're coming in with different bacterial infections, that sort of thing, clearly you're probably, you have a conversation with them and you find out that they're having unprotected sex. So those people would be more at risk. Also men who have sex with men, obviously, heterosexual men and women, patients who are HIV negative but have positive partners. So we call that serodiscordant partnerships. So if a person is married to an HIV positive person, that negative person would probably get on PrEP to make sure that they're protecting themselves, as well as the positive person being in treatment to make sure they're keeping their viral load undetectable. And then, of course, adult drug user who use illicit drugs, but also have maybe shared needles in the past 6 months. So that goes back to that population that we don't really think of as injection drug users, but the older population of people who can't get diabetic supplies and they are sharing needles with their counterparts. So prior to initiating PrEP, laboratory tests have to be done. So baseline tests that should be taken, obviously an HIV test, because you have to be negative. Okay, hepatitis B and C, STD panel, pregnancy, liver function, renal function. We do not want to initiate this if the creatinine clearance is less than 60. As far as pregnancy, it's important to know that You can still be on PrEP if you're pregnant. That is not the issue. The issue more so is we want to make sure that if you are pregnant, if you do contract the virus while you are on PrEP, we get you into treatment. And so we make sure that you're, getting that prenatal care that you need so that even if the mother contracts it, the child won't. And then hepatitis, that's another one. Of course, STDs, we want to make sure we clear up any underlying issues. But with hepatitis, it's really important to get because one of the ingredients in Truvada is used for the treatment of hepatitis. So if a patient is on PrEP and then they decide, I don't want to take this anymore, or I'm not in that relationship with an HIV positive person, we want to make sure that they're given something for that hepatitis because once they get off that drug, that hepatitis is going to flare up. Okay, so that's why we just need the baseline. So these are the two treatments that are approved for PrEP or pre-exposure prophylaxis. So Truvada is what I've been talking about because this is the one that was approved in 2012. The Descovy was just approved December of 2019, so a couple months ago. It's important to know, though, that Descovy is only approved for men. So the reason that is because the pharmaceutical company only included men in their clinical trial. They did not include women or anyone receiving vaginal sex. So therefore, it may be an issue if you're trying to switch someone to Descovy because it's better. Insurance probably is not going to cover that because it is not FDA indicated. However, Descovy is indicated for HIV treatment in women. So it's not that we don't think it'll work in women. It's just more so for this specific purpose or for this specific indication, you guys did not include it in your trial, so we can't give you that indication. Okay. So the biggest differences to note is the tenofovir component. So they're literally the same drug, emtricitabine and tenofovir, but this one is TDF and this one is TAF. Okay, or tenofovir alafenamide, but you'll hear it as TAF a lot. So you may have heard that TDF causes things like long-term issues like bone mineral density loss. I just drew a blank. Bone mineral density loss is a big one, though. Also, renal dysfunction. It can also cause renal dysfunction. So they made this newer tenofovir, which is supposed to be less harsh. It's a smaller dose of the other tenofovir, and it's supposed to help with those side effects. So it showed that it caused less bone mineral density loss than the original tenofovir. So that's really the biggest difference between these two drugs. Other than that, there is no difference. I think also Descovy is a little bit smaller of a tablet, but they're pretty much the same drug. This one is Descovy is just a little more tolerable. But again, it is not indicated for women. So the only thing you can do, is give it to men or switch a man who was on Truvada to Descovy, but it's going to be very difficult to try to get that woman on it. So it's a single tablet. It's taken once a day. It reduces your risk of contracting HIV by over 90%. Precautions, of course, you can't use if you have impaired kidney function, and also you may experience headache, nausea, abdominal pain. So, of course, like I said, those symptoms usually subside. Of course, there is going to be 2% of the population where they're intolerable, they can't take it at all. So, we would have to address that. But for the most part, the side effects are very tolerable. So we do want to make sure that we're stressing the importance of safe sex practices and medication adherence. So if you have patients coming in and they're always getting an STD panel every 3 months and they're having these risky behaviors, just because they're on this drug, that's not it. They need to also continue condom use. They need to be adherent. Adherence is really big because, it's a virus. It can mutate. There are different strands of the virus. So if a patient is taking PrEP on and off, and they're sometimes taking it, sometimes not, and then they contract the virus, they can become resistant to that medication. That whole class of medications it's a possibility that it can be wiped out, making it harder to treat them once they become infected. Okay, so that's why we want to stress the importance of adherence. Yes. Mm-hmm. I want to say they still do it at 60, but I want to say with the actual drug is 30. So treatment monitoring, get baseline labs, of course. We're going to dispense a 90-day supply. So usually the doctor prescribes a 90-day supply. So we will be dispensing a 90-day supply, making sure that we are counseling them about taking the medication at the same time every day. It takes about 21 days for this drug to reach peak efficacy. So it's not like, oh, I'm taking it today and I'm covered for tomorrow. So, that's why we stress the importance of safe sex practices. But it takes 21 days to reach peak efficacy, and that's really in vaginal tissue. It's shown in rectal tissue to actually reach therapeutic levels or peak efficacy in 10 days. I want to say 7 days to 10 days. And then we want to make sure that they're coming back every 3 months. So we're doing another HIV test every 3 months, okay? We're also making sure that we're assessing their side effects. Is there anything else going on in their life that may prevent them from getting the medication? Do they want to stop the medication? Did something change? Maybe they're not in that monogamous relationship with that HIV positive person, so they're no longer thinking that at risk. So who's using it? So this kind of answers your question as far as why are we maybe so much more disproportionately affected? So as you can see, white PrEP users make up 69%. Black PrEP users, only 11%, okay? And we made up over half of the diagnosis, right? So we are most at risk, but only 11% of PrEP users are African American. And that goes back to healthcare providers not giving that information, not telling them that this is an option. You have been coming to my office, you're having unprotected sex often, so let's get you on something that is going to help protect you. So when to discontinue, and again, if HIV is, yes. So the question was I don't know the exact percentage of how many African Americans are open with their position. And so, but I think it is important that we look at African Americans, period, because a lot of times I have had patients in the clinic who don't consider themselves homosexual because they are on the giving end. So they may have sex with men, but they do not consider themselves homosexual. So when you ask them certain questions, they're going to say no, but when you ask it in a different way, you end up finding out that actually they do belong to maybe a certain population. So that is an issue. Yes, that is an issue with people not maybe identifying as that, and then we're not looking at them as a target group or an at-risk group because we think that maybe they're in a monogamous heterosexual relationship when in reality they're not. So I don't know the actual statistic, and I can get back to you about that. But as far as, of course, African-American stigma is a big thing. So, there are probably a lot of people who are not identifying as homosexual, and they're actually in the category of the heterosexual male to female contact, when in reality they're on both sides. They're having contact with both male and female. Yes, when they're not being honest, yes, that could be a reason why they're not being treated like their white counterparts. But however, it doesn't matter if it's not prescribed, it's not indicated for just men who have sex with men. It's indicated for heterosexual men and women who are having unprotected sex. So even if a person comes into my office and they're denying that they're having male-to-male contact, if they're coming into my office and they're getting a shot for gonorrhea or they're getting treatment for syphilis or something, I still would recommend it to that person. And that's why I think education is important. And I think the company is starting to do a better job at marketing. But if you have ever seen a Truvada commercial, it's focused in one specific group, and that is homosexual men. So it gives people the false perception that, oh, this is only for that group. So that's not for me, that's for people who are in that group, when in reality it's for everyone. So I think as healthcare providers, it's our job to kind of change that narrative, and so they don't think, oh, it's only for this particular group. No, it's for you as well. You're having unprotected sex with multiple women. You're coming in here, you're getting shots, you're getting medication prescribed every couple of months. So clearly you are an at-risk population. So I think it's just about education. And reducing that stigma. And I want to say recently that company has started to change their commercials a little bit and kind of target like Black women and, the other at-risk populations, which I think is going to help. Yes. Mm-hmm. Mm-hmm. I agree. I agree. That would be a great idea to have all the HBCUs kind of join forces. I know here in Leon County, there are different federally funded health clinics that FAMU specifically has partnerships with, Neighborhood Medical Center being one, Bond Community Health Center being another, and then Big Ben Cares being another. So they do a lot of partnerships with student health services where they are pushing that. I do know personally students who are on PrEP, but again, you are correct. There should be some type of, mass campaign with the HBCUs kind of being able to push this information out. I think that would definitely help. I definitely think that would help. Yeah. So, and I'm going to kind of talk about that later, about accessibility, but insurance coverage can be an issue, definitely. But, there are ways and resources in which we can get the drug. One being the manufacturer does patient assistance. So, I deal with a lot of underinsured individuals, and so they are still able to get the medication. Also, in the state of Florida, all county health departments in all 67 counties, they have to offer PrEP, so for free. So that is available in all of the county health departments. So if a person does not have insurance, that should not be a reason for them to be initiated on PrEP or recommended PrEP. That definitely shouldn't be a reason. That was going to be the same question. Okay. Right. Mm-hmm. Mm-hmm. Yeah. Right. Mm. Okay. Mm-hmm. And so I do definitely agree with that. I mean, that's an issue not just here. That's also just an issue in the South. Period. Mississippi, definitely an issue in Mississippi. Alabama, Georgia as well. But yes, here it is an issue about people not knowing or people being in certain positions and not wanting to teach about certain things because of their beliefs. So we have to get past that. Like, we really have to get past that, past our personal beliefs to help out those people. I mean, people are going to have sex. Premarital sex, that happens. That's a thing. So we have to kind of get that in our head so that we can then help those individuals who may be the most at risk. Yes. Mm-hmm. Right. I mean, well, those statistics came from the CDC, but think about it like this. So Black men are the most at risk, men who have sex with men, right? And some of those Black men who have sex with men also are having sex with heterosexual Black women, all right? And then you look at white men, they are least at risk, right? And so the statistic isn't just a number based off the population. They're taking it from the men who are the people that they're having sex with. So they're taking it, women, majority of women having sex with white men, and white men are lower on the totem pole where the risk comes in. So that statistic can be questioned, but it did come from the CDC. So how do you question the CDC? You got to. You definitely have to. But you have to kind of think. It does make sense though. If black men who have sex with men are 1 in 2, it's a 1 in 2 lifetime risk that they're going to contract HIV. So that automatically tells me that black women who are having, because there are some black men who have sex with men who also are having sex with black women, we're going to be highest as far as women are concerned. Yes. As far as who was not educating or who was not, I don't think it was based on a specialty. It was just primary care, period. And a lot of times primary care physicians don't necessarily have the information. When I graduated in 2016, we went to Taylor County, which is a more rural area than Leon, and we had to educate the nursing staff and the other physicians that were there to tell them this is an option. You need to be talking about it with your patients. So you're right. There are people who may be in primary care who may not necessarily have the information themselves to even relate to their patients. I agree with that. So Florida is a little bit behind, but in some states it is mandatory. Like for women, for example, when they go in for a PAP, in some states it is mandatory that they do an HIV test, while in Florida it is not. So there are some states that have already kind of implemented certain things like that to help with the HIV epidemic, but Florida is a little bit behind. So it's going to take a little bit more lobbying, a little bit more going to the Capitol, I think, for that to happen. But I think that's a great idea. Did I see someone's hand over here? No? Yes. Okay. Right. And so you skipped the question. So that's good that they asked it, though, because you may not think that you're at risk, but then when someone else reads that, they can say, oh, this person is at risk. So, yes, I think that's a great idea. Blood test. Mm-hmm. Mm-hmm. Ooh, that's another a conversation for another day. But I think because even in Mississippi, there's a thing where if you're married, they don't do certain tests because they're assuming because you're married, that you're married and both of you are being monogamous and faithful. But that's not necessarily the case all the time. So yes, I do agree. I mean, I can't go deep into conspiracy theories and whether or not the government is really trying to do certain things, but I do agree that there are issues that need to be looked at and try to see what laws can be put in place to help prevention for the most part. You know, they have all these goals. If you look at Healthy People 2020 and health, they're basically saying, if you look at, I want to say the Trump administration's, what they have that they want to end the epidemic in 2030, which is in 10 years. So, okay. Oh, well, I don't know about the credit report. No, but it's a little bit invasive. But no, I mean, I think that's something that's important between you and your partner, regardless of if you're married or not. I think that's something that should be talked about anyway. But I tell my students all the time, even whenever you have a new partner, hey, let's go get tested together. Not just for HIV, for everything. Let's go get tested together. And if they have an issue with it, then they probably aren't the one for you. So I just it's important that we are stressing that to everyone. So again, when do this continue? When HIV is contracted, because we want them into care. If it's a personal choice, so maybe you're no longer an injection drug user, you're no longer in that relationship with an HIV positive person. If the side effects are intolerable, obviously we want you to stop that. And then also chronic non-adherence. If this patient is not taking the medication, they're taking it once a week or a couple days a week, it may be better for them to stop taking the medication and just use condoms at that point, because we don't want them to kind of cancel out this drug treatment if they do contract the virus. So, which patient is not eligible to begin PrEP? A 27-year-old pregnant woman, a 50-year-old woman with a creatinine clearance of 45, a 37-year-old man with hepatitis B, or a 16-year-old sexually active male? B, yes. So the answer is B. So I just want to know, I don't have anything about pediatrics in here, but I do want you to know that PrEP is approved for anyone over 35 kilograms, about 70 pounds. So minors can technically take the medication. Of course, when they're a minor, they need parental consent, and then that gets into a whole lot of stuff because parents don't want to hear about their children having sex. But technically, it is approved for individuals who are under 18 as long as they are at least 70 pounds or 35 kilograms. So post-exposure prophylaxis. Post is after exposure that you've been exposed to the virus, and then prophylaxis or prevention, right? All right, so it is for those that are negative, but they've been exposed to it. So just like I gave the analogy with is it a dead spot? Okay, with birth control and PrEP. So PEP is just like Plan B. 72 hours, just like Plan B, okay? But the difference is, unlike Plan B, where you can go into the pharmacy at any time and it's over the counter now, with PEP, you need to still have those baseline labs, you need to still see a doctor, and then you have to be prescribed it, and then you have to get the medication, and then you have to take it. So you have to do all of that within that 72 hours, and that's really important to stress because a lot of activity occurs on the weekend, right? So on the weekend, some of those clinics are not open, and so you're on a time clock. So Friday night, you might have had fun. Saturday, Sunday, now Monday, you're rushing trying to get what you need to get because you've been exposed, okay? So this can be in an occupational setting or non-occupational setting. You may see it as like lowercase o PEP or NPEP. That you may see NPEP a lot more. OPEP, really, we don't really talk about it. Not talk about it, but usually it's handled within your employer. If you are working at a hospital and you expose yourself to bodily fluids of an HIV positive person, they're going to take care of you. Probably with your whatever health plan you have through your employer. But it's going to be taken care of. It's going to be probably easier for you to get the meds. You're right there, so that's not an issue. But MPEP or non-occupational is usually what I'm talking about, and the end is actually missing, okay. But you must be seen by a healthcare provider or an emergency room. So if it's a weekend, the clinics are closed, they may have to go to the emergency room to speed the process up because you are on a ticking time clock. You must initiate treatment within 72 hours of exposure to HIV. The reason being is because they didn't see any added benefit when people started it after that. Okay, so I get this question a lot, so I don't know if y'all are going to ask it. I'm going to just answer it. Can you initiate PEP after 72 hours? So as a clinician, a doctor can really kind of do whatever they want. If they want to prescribe it, they can. But again, there has not been we have not seen any added benefit after those 72 hours. So majority of prescribers are not going to prescribe it after that 72 hours. So that's why it's important that as soon as a person is exposed, they go and start this process the next morning. Okay? So it's a 3-drug regimen, and unlike PrEP, which is taken indefinitely, you only need to take it for about a month or 4 weeks or 28 days. Okay, so evidence of efficacy, obviously they're not clinical trials because it would be very unethical to expose someone to HIV, give one person a placebo and one person the treatment. So they don't have any like clinical trials. They did study it in animals, so that's where they get the 72 hours from. They saw that there was no added benefit after the 72 hours in animals. But they did do a case control study with healthcare workers. And so they were giving them zidovudine, which was the first HIV medication. You guys may know of it as AZT or Retrovir. But they were giving it to healthcare providers after they were exposed, and they saw 81% reduction. So it shows that, okay, if someone's exposed, you can give them some medication, and it can help them from contracting the virus or from the virus continuing to multiply in your body. Okay? And so we do have kind of guidelines for PEP. Unlike PrEP, there is no drug that's indicated for PEP. So PrEP, there is an actual indication. PEP, not so much. So you can kind of use the drugs that are available to you depending on the area you work, but they do have recommended drugs that they kind of are preferred. So again, eligible patients, 2 different settings. Occupational, obviously you're at work, you're exposed to bodily fluids, maybe you were giving someone a shot, you accidentally pricked yourself with the needle somehow, that's one thing. But non-occupational would be those risky behaviors, sexual contact, so it could be consent or non-consent. So if you were sexually assaulted and you don't know you don't know the person who raped you or who assaulted you, you don't know if they have HIV, you don't know their status, so you technically are eligible for PEP. Fighting, I put that on there. A lot of people don't think about it, but the chances are low, but think about if someone has a bloody cut up knuckle, bloody cut up mouth, that sort of thing, blood can transfer. So, and then of course IV drug use. So the same baseline labs must be done. Pregnancy, hepatitis, STD panel, renal function, all of that must be done just like PrEP. Again, you can still do it if you are pregnant. You can still do it if you have hepatitis. They just need to know, okay? And of course, with the renal function, I'm saying the creatinine clearance must be greater than 60 if you're initiating Truvada as a part of that or another drug that has some type of renal dosing. So again, there is no drug approved for PEP. So if a patient has decreased renal function, there are additional options for them, okay? So PEP should be initiated within how many hours of an individual being exposed to HIV? 72. All right. So PEP treatment. So this is the preferred. We do Truvada and another agent. So you may see Icentris or you may see Tivicay or dolutegravir. So both of these drugs are integrase inhibitors. Okay. The reason why I have this underlined is because this is more preferred because it's a once daily dosing. As opposed to this one, you need to dose it twice a day. They also have a newer version called Icentris HD, which is once a day, but it's still 2 big tablets. Okay, so this usually is more preferred just because it's just one additional tablet that they have to take in that 28-day period. Same with the precautions and side effects because it's pretty much the same drug. So the difference between PEP and PrEP, the big difference is that PrEP, you're only getting this agent, this Truvada. PEP, you're getting a full HIV regimen. So this is a regimen that an HIV patient can be on. You're getting that for the full 28 days, okay? So alternatives, of course, you can add an additional agent. It could be this is a protease inhibitor. Again, there is no PEP indicated drug. So if you have to get creative, depending on your patient population or what you have available at the hospital, that's fine. But in practice, usually what we see when they come to the clinic and they're telling us they did XYZ over the weekend and they need help, these are the drugs that we're probably going to be able to get to them quickly. The Truvada and the Tivicay. And usually we can get them through insurance, but also the pharmaceutical companies do patient assistance just like they do for PrEP. PrEP, I mentioned that it is available at all 67 county health departments. Currently, PEP is not available at all 67. So it's important to kind of know that when you're talking to people, and you're educating them, like PrEP is available everywhere, go to the health department, but if they're exposed to it and they're trying to get post-exposure, you need to kind of let them know that it's not going to be, they're going to have to get it another way. It's not going to be at the county health department. So monitoring is pretty much the same. So we want to make sure every 3 months we're getting that HIV test done to make sure that you have not seroconverted or contracted the virus. But you do want to make sure that they come back 4 to 6 weeks. And this is very difficult because a lot of times patients have in their mind, yes, I got this drug, I'm taking it for a month, I'm good. And they don't come back. So we don't even know, did they contract it? Did they finish the full 28 days? So that is what I've seen that's been an issue as far as following up. But we need to make sure that they know they get the initial prescription, they take it for 28 days, they need to make an appointment at least 4 to 6 weeks, within 4 to 6 weeks of that initial appointment, so that we can make sure everything, they took it, make sure there was no issues, kind of respond to questions, and we educate them that they need to come back to get HIV tested again. So transitioning from PrEP to PEP. So this is PEP to PEP. So this is important. So if there's a person coming in your pharmacy and they're getting Plan Bs every night, Eventually, you're going to try to have a conversation with them to say, okay, have you talked to maybe your doctor about switching to birth control so that you're being more preventative instead of reactive, you're being proactive, right? So if a person is continuously coming in and they're saying, oh, I need this post-exposure prophylaxis, I've been exposed, I need this, you need to try to transition them because clearly they have those risky behaviors. You need to transition them over to PrEP, okay? And so you need to have that conversation. Usually if a person comes in twice in the course of a month or two, I would definitely have that conversation to switch them over to PrEP, okay? So of course, this is frequent reoccurring exposures, sequential or near continuous courses of MPEP, they should then be offered PrEP. Once HIV negative status is confirmed, PrEP can then begin immediately. So if they come for PEP, they do that 28-day regimen, they get an HIV negative test again, they can start PrEP that next day. It's no wait period, like, oh, okay, well, you have to wait 3 months until we do that other HIV test. Literally, they do PEP, and then we kind of transition them right over to PrEP immediately. It's no wait time. So PrEP reduces individuals' risk of contracting HIV by over 90%. Yes, when you take it every day as prescribed, as mentioned. So accessibility of the medication. Some insurance companies do cover it. Again, we talked about Truvada and Descovy. Because Descovy is not indicated for women, if there is a woman that wants to be put on Descovy, they probably won't be covered because it's not FDA indicated. If patients are uninsured, usually the pharmaceutical company is really good at doing patient assistance. I know here, they throw the drugs, I feel like, at us. Of course, we know the county health departments provides PrEP, but if they can't get to a county health department, the pharmaceutical company is really good for that. And it's also important to figure out what agents you're going to use and which companies those agents are under. So, for example, if you're going to use the Truvada and the Tivicay, Truvada is with Gilead, Tivicay is with Vive, so you have to call those separate companies. It's not just, I can call one place and get all the medication. Icentris is Merck, and then you have to know kind of how they do it. So Vive, they give you a patient assistance card that you can take to the pharmacy and go get that prescription that same day. Merck, on the other hand, they mail you next day the medication. So they don't give you a card that you could take. So if a person is on a time crunch, they're at hour 60, we don't have time to get that medication from that company and get it next day shipping. We need to make sure that we're choosing options that are going to be readily available for the patient. So the role of healthcare professionals, we want to make sure that we're counseling the patients on safe sex practices. That's very, very important. This drug is not 100%. Nothing is 100%. Safe sex practices is important. People who are HIV positive, they are part of prevention. Them taking their medication is helping stop the spread of HIV when they are undetectable. So we need to make sure that we're communicating that to them as well. Informing patient of medication-related side effects, monitoring parameters, letting them know, maybe symptoms of HIV. So yes, we tell them to come back every 3 months, but if they get really sick before then, come in for a test. We want to, if you're having some flu-like symptoms or something is going on, come in for an HIV test, okay? Because you can't be having an acute infection. Assess adherence at every visit. So we definitely want to make sure that they're taking the medication. Identify the non-adherence barriers. So why are they not taking the medication? Low literacy could be an issue. I don't know how many patients I see that, when I'm asking them how they're taking the medication, and it's nothing that is on that bottle. Like they literally didn't read the bottle at all, because what you're telling me is not, even if you didn't want to get counseled by a pharmacist, but the least you could have done is gone home and read the bottle before you started taking it. So a lot of times they don't. So we have to be able to address that. Their schedules, if they're homeless, that sort of thing. We have to think about that. No one wants to carry around a medication that's used for HIV on their person. So we have to think about those different barriers and how we can help. They have a keychain where you can put it on your keys, put a couple pills in them, and kind of take it to go. So when people go out on the weekend, they may go out of town with their friends. They don't have to have that pill bottle with them. They can have it in their little keychain and make sure that those 2 days that they're out of town on the weekend or 3 days that they have it with them so that they're still being adherent. Of course, like that's what I was talking about as far as providing resources, pill boxes, the keychains, medical referrals. Mental health is really important. We want to make sure that if that person contracts the virus, that they're going to stay in care. So we need to have those conversations with them, have those talks with them, letting them know, if the worst case scenario that you do contract the virus, what then do you do? They should know what they need to do from that point. It shouldn't be a guessing game of, oh man, how do I get the medication? Where am I going to go? We need to educate them on the other end as well. So strategies to improve adherence, of course, we want to make sure that we're collaborating with other healthcare professionals, call their doctors. If they're not on PrEP, they're not picking up, make those phone calls, let them know so that, we can kind of all be in collaboration and communication with each other. Evaluating the patient's baseline knowledge and then filling in the gaps, that's the biggest thing. Encouraging safe sex and needle practices. So the CDC does have a way for you to clean used needles. I personally do not trust for patients to properly do it, so I don't encourage it, but I do encourage buying needles. So in the state of Florida, except in certain counties, it is perfectly legal to buy needles without a prescription. I know a lot of pharmacists don't like to do it. Does any pharmacist in here, I guess, don't have an issue with if someone comes to the pharmacy, they ask for needles, do you have an issue with selling them? No? Okay, that's good. So, again, some people may be using it for injection drug use. Some people really may be picking up needles for their grandmother. Okay, so I like to, use that power as a pharmacist. I can sell needles without you having a prescription. So what you do with those needles once you leave here, you are going to do it anyway. So I would rather try to prevent a spread of a virus by giving you a clean needle, okay, if I can. All right. And so, of course, knowledge of their HIV status as well as the status of their partners. There are too many times where men are, and I'm sorry to point the men out, but I hear it a lot from men. They're like, I don't need to get tested because my girl or my wife, she just went to the doctor, got tested, she's good, so I know I'm good. And that's not the case, okay? So it's very, very important that men and women alike know the status of each other's, health. And so future implications. So this is very, very important. Of course, Florida, we're kind of always behind. California is a little bit more progressive. But last year, California passed a bill that allows pharmacists to dispense a 30 or 60-day supply of PrEP or MPEP without a prescription. So that's like really big because, again, with MPEP, you're on a time frame. And so sometimes that first point of contact is going to be that pharmacist. You're not going to be able to necessarily see. Now, of course, we still need those baseline labs, but if we can start them on the medication and then get the labs and find out, this person maybe shouldn't be taking it, then that may be a little bit better than having them wait or not being able to get the medication. Or, for example, think about a person who's already been prescribed PrEP. So they're already on it. They've already seen a primary care provider, but now they're due for a refill. So it can kind of be important to kind of just make sure that they're continuing on their therapy and to hold them over until their next visit. So I think that this could be something that is going to be good, especially in those counties that have higher risk. So earlier I showed you the counties like Miami-Dade. There were 1,200 cases in 2018. So in certain counties, I think this will be very beneficial.
how can health system pharmacists help mitigate?
Medication safety. Medication safety is medication.
All right, everyone. Thank you for joining us again. As everyone makes their way back into the auditorium, we're going to go ahead and begin the latter part of today's session. Ms. Kyra Gaddis, P1 student, is going to come before us and introduce our speaker of the hour. Ms. Kyra.
Good afternoon. Whenever you hear someone describe a professor with flawless memory, quick wit, and impeccable knowledge, you usually will hear a resounding, "Oh, you're talking about Dr. Robertson." Dr. Gervin Robertson is not only considered one of the most brilliant pharmaceutical minds, but he is also a gifted educator. A graduate of the FAMU College of Pharmacy, Dr. Robertson also has a master's in business administration as well as master's in health administration from the University of Florida. Dr. Robertson has also been an assistant director of clinical pharmacy services at Capital Regional Medical Center in Tallahassee, as well as a consultant pharmacist at Option Care of Northwest Florida. Having been no stranger to a diverse career, Dr. Robertson completed a fellowship in infectious diseases at Amgen Biotech and is specialized in infectious diseases, clinical drug development, and cardiovascular pharmacology. Ladies and gentlemen, please assist me in providing the warmest welcome to the incredible Dr. Robertson as he presents To Err is Human. 20 years later, what have we learned?
All right. Good afternoon. That was a most gracious and more than welcoming introduction. I really appreciate that, and thank you. So we'll get started today, and I know that after we'll get the show on the road, we're a tad bit behind, so I'm going to try to do my best in order to give us a good overview, and we're going to go back and do some reflection and think about why is it that many of our pharmacists in the state of Florida, why do you have to sit every 2-year cycle and get these 2 hours of medication error CE? Well, just to provide a little bit of background, that's what I'd like to do today, and just give us some idea as to where the medication errors concepts come from and why, and after 20 years of discovery, what have we learned? So upon completion of this course today, we would have a few objectives for you. For the pharmacists in the audience, we'd like to define the various types of medication errors, know the role of ISMP, also known as Institute for Safe Medication Practices, and other regulatory state and federal bodies that involve monitoring safe medication environments, describe the impact of medication errors on the healthcare system, understand a safe medication use system, identify the leading types of medication errors that put patients at risk, recognize the leading causes of medication errors, identify strategies to enhance patient safety and reduce medication-related errors, and why we have to implement continuous quality improvement programs and understand the root cause analysis review in helping us to reduce medication errors, and then identify the primary roles of individuals responsible for promoting cultures of patient safety in our pharmacy settings. For our technicians, we also will expound upon those types of medication errors, talk about our regulatory bodies as well, understand the impact of the errors on our health system, understand our safe medication use systems and the role of the technician in the safe medication use delivery system, identify the leading medication errors and patient safety types and risks that technicians can help to reduce, recognize the leading cause of medication errors, and identify strategies that technicians can help to reduce and make our patient population areas safer, and understand the technician's role in promoting a safe environment. To Err is Human. So an excerpt from the To Err is Human statement from the Institute of Medicine, IOM, back in 1999. The major statement was, despite the cost pressures, liability constraints, resistant to change, and other seemingly insurmountable barriers, It is simply not acceptable for patients to be harmed by the same healthcare system that is supposed to offer healing and comfort. Our obligation is, first, do no harm. That's a powerful statement. That was a statement that was developed in 1999 by the Institutes of Medicine. So, as we look at that, just a historical overview, just to kind of bring us up to speed, we find out that in 1999, the Institutes of Medicine and the Institute for Safe Medication Practices, they partnered with the American Hospital Association in a national initiative. This initiative was done to examine hospitals and to come up with surveys and identification techniques so that we can improve medication practices. And so at the conclusion of this data, a white paper was published, and this white paper was presented to President Bill Clinton. President Clinton accepted the white paper during a White House briefing and then began to fund and put into place what we call, is known today as our safe medication practices. So ISMP basically participates in various types of national policy discussions along with other regulatory bodies such as the Institute of Medicine, AHRQ, as well as the Joint Commission. Those are continued to be followed in our other environments, such as our retail outlets, by other quality initiative measures, such as our leapfrog groups, HEDIS, and many others, in which we measure quality and we try to identify ways in which we improve things like medication adherence, medication safety, and error reduction. So the first edition of the Medication Errors to Err is Human was published by Michael Cohen. So in 1999, this pioneering report, To Err is Human, Building a Safer Health System, revealed that as many as 98,000 people at that time, and this was a retrospective study done from the mid-90s, concluding about 1998, that found that at that time, over 20 years ago, 98,000 patients died from preventable medication errors in U.S. hospitals each year. I'll give us a short excerpt of some statements from some of our other experts.
Everyone makes errors all the time. It's sort of a part of the human condition, and even someone who tries their very best will still make some errors. We've moved from focusing on error to focusing more on harm, in part because it's become clear that for many things that we thought were not preventable, we can actually prevent a very large proportion. The classic example is CLABSI, or catheter-related bloodstream infections, where one time we thought that was just a complication of having a central venous catheter in place. But now we know that if you follow a set of procedures or a bundle, you can essentially eliminate those infections, and we've had similar findings for a number of other areas. So I think it makes much more sense to focus primarily on harm. There are many different definitions of harm. The Harvard Medical Practice Study defined harm as harm that resulted in death or disability at discharge or prolonged hospital stay by 2 or more days. I think that's too narrow a definition, and I think it should include anything that causes a substantial issue for a patient. So something like an IV infiltrating might not have been considered harm in the Harvard Medical Practice Study, but I think it should be considered harm, and it should be something that we're trying to strive to prevent.
Okay, so when we look at the impact of I had this rehearsed pretty good, so. All right, I think we're good now. So I do this, try to make it keep what I have to do when I have an after lunch presentation to keep my audience awake. We have to keep you all interjected and engaged. But the impact of our healthcare system, the medication errors, one of the things we have to look at is, so the impact of medication errors on the healthcare system. So what are some of the impacts that occurs when we have medication errors and errors involved in the health system, in the community environment, and as pharmacists? What types of errors can occur? What kind of results can we get? Would we expect to have potential loss of life? Would we expect to have patient harm? Would we expect to have an increased cost of care? So we find that the impact of medication errors and the impact of medication safety causes all of the above. We have an increased potential for a loss of life. We have an increased potential for harm to the patients. We have increased potential for increasing the overall healthcare costs to our patients and to our health system. That's a major impact. So D, all of the above. So we look sometimes at the medication use system. The medication use system begins from a simple perspective. It begins with the appropriate selection and procurement of our medications, beginning with our ordering from either a wholesaler and ensuring that medications come into our system in a safe manner. We realize that now there are a lot of ways that medications enter our environment, enter our retail environment, enter our healthcare setting environment, and we have many types of improvements since 1999 that help to improve our selection and procurement, as well as our storage. What are some ways in which, from our selection and procurement or our getting the medication into our pharmacies, what are some ways now that are improved in our system? Can anybody come up with a couple? What are some ingenuitive ways that medications enter our system that help to reduce errors now? What is it? Barcoding. Barcoding is a big one. It's huge. What else? What is it again? Yes, so that's another good way. So many times in many healthcare systems nowadays, the computer systems that we order our medications from, whether it's Cardinal, McKesson, AmerisourceBergen, when we procure those medications into our facilities nowadays, usually, and I'll use this term, when it comes in the back door, we have a barcode scanner there waiting for it in most instances nowadays. If we don't, then that is the goal that most institutions should be striving for. The goal is when the medication hits the back door and it comes out of the tote or comes out of the crate, and whoever the person is that's securing that medication in the proper form, they're scanning it into practice, right? Or into position. So how does that work? Can someone tell me how that helps to interact and improve patient care when that barcode begins from an initiation process? How does that improve the next flow? So we know that, and we've also used technologies like RDFI technologies, especially on our expensive medications. We get medications that cost $100,000 for a little 2cc vial, and we want to make sure it's in the right location. And if it's not with us, we want to be able to track it with the little chip code notifying where it's located. We also sometimes, if we need to figure out if it should have been refrigerated at a certain temperature on the ride, we want to make sure that if we need to, we can determine what the proper analysis of that medication was, if it was within the proper temperature controls. We can do that with a lot of current technologies. So we find out, we bring the medication through the back door, it comes in, In the most appropriate environment, we would scan that medication into our computer system. But guess what? Not only when we scan it in, but once that NDC number is recognized, that medication is usually ineffective or inoperable to us if what? In the most perfect system, if that NDC barcode doesn't link up to our drug file in our computer system when we're prescribing and ordering the medication from practitioners through CPOE or the pharmacist, when we barcode scan that medication, and then if that drug is not identified in our drug file, we can't even use it to order. And if we're inputting the order on the patient, or a physician's inputting the order, or the pharmacist is prescribed or inputting the order. That's in our most perfect system. That means that the medication that came through that we ordered from our wholesaler comes to the house. We scan that medication into the house. That medication then has to be reconciled into whatever system we use, whether it's Meditech, whether it's Epic, whether it's Cerna, whatever system that is, that medication, that NDC code has to be either alternated in as a drug that is a generic that's compatible, and say, well, we have alternate NDCs and we can use that NDC or a variation of the three, right? So that now when we select, we know that the drug that came in the house cannot even be input on the appropriate patient if it's not in our drug file, okay? So that helps with our selection and procurement. We store it in the most proper places, and then now we cannot order or transcribe that medication unless it's in our drug dictionary. That means if it's in our drug dictionary, then it goes through the appropriate what? It has to go through our appropriate checks for adverse drug reactions, drug dosing recommendations. It goes through to provide, build into our patient's profile, checks the patient's disease states that may be contraindicated. So now that I know that I have the correct drug and I have it in our system, now we also know that through drug data bank situations, it now goes through the appropriate safety measure checks. So we have things that are in place that are now making sure this medication that's in the facility cannot be prescribed on a particular patient unless, first of all, it belongs there, right? Because we can now, it can probably be mispicked, but we got things for that later on, right? But when it comes through the back door, if it can't find a home on the shelf by being scanned in to the system, because our system scanning the medications into the house, it won't accept it into the house unless it's in our drug file. So then somebody has to create a file for it, okay? So these are just new technological aspects of ordering and transcribing the medication. Then as we prepare the medication for dispensing, we have things where, whether it's the computerized physician order entry or computerized prescriber order entry, CPOE, or the order entry that's done by the pharmacist, whatever that occurs, whatever situation that is, now we select that product. It goes through the appropriate check mechanism. We have various computer systems now that, like Epic or Cerna or Centricity or any of the other ones, that are so in tune with every aspect of the patient's care that it even monitors adverse reactions that might occur secondary to potential lab results. So it interfaces lab data, it interfaces potential drug interactions that may occur. It may tell us, oh, I have you getting ready to put a patient on Coumadin, but the current INR is 3.5, so it might give us an alert to then go do that. Now, sometimes we might bypass that alert, but the system gives us an alert that interfaces with the lab that lets us know what our next step and our next clinical decision is. Then we get to administration. Then we also have points of administration to where there are also points and checks that the administration should occur. Patients should usually have, or the person who's doing the administering, nowadays we have the electronic medication administration record, or the EMAR. And with that electronic medication administration record, normally we have a computer system that sits outside the patient's room. If it's in an inpatient situation, the nurse or a person who's going to do the administration would go in that patient's room, barcode scan the patient arm label, come back to the computer right outside the door, and that data should pop up. Now, when they barcode scan the medication label, the NDC on the back of the medication, if John Doe was supposed to get his metformin 500 milligrams at 10 a.m., then if it's 6 p.m. and that's the inappropriate dose, then we should get an alert. That's an inappropriate time to administer that medication. Because, or if it, let's say they pick up the metformin by mistake, let's say they pick up potassium chloride, both big bulky pills that may be difficult for us to swallow, those two big white pills. So KCL 40 milliequivalents or KCL 20 milliequivalents would kind of, at the naked eye to a nurse or somebody administering, kind of look similar. But if they bypass scanning, then the patient might get that medication. We'll talk about that a little bit later. But there's a process that we have, and we'll continue to talk about that, just laying that foundation. These are all medication safe check systems that allow us to then come back and monitor the effect of the medication. So a safe medication use system, a whole system that begins from the time the pharmacist says to the technician, could you put another order of valsartan 80 milligrams on the book so we can order it? There is a system that goes all the way till that patient, Jane Doe, gets her 2 tablets of valsartan 160 milligrams the next day at 10 a.m., okay? So what are the characteristics and management of a medication error? So we say, well, what's a medication error? Well, usually a medication error is preventable. 9.99% of the time, it's unintentional. If we're lucky, it doesn't cause any harm. If we're lucky, all we have to do is just monitor them a little bit. We're supposed to give those, that the dose was supposed to be valsartan 160 milligrams once daily at 10 a.m. The nurse picked up 1 valsartan and only gave 80 milligrams at 10 a.m. So luckily, if we're lucky, all we got to do if somebody picks up on that is monitor for it. And if it's within a nice window, within a reasonable time frame, we can administer that next pill. But most of the time, we don't know that until the night shift nurse comes in and finds out, oh, we still got an extra valsartan in the drawer, right? Because it didn't get administered, still in the patient's specific bin on their med card. So we identify that. It's a little too late then. We document that medication error, and then we'll follow up, and we'll talk later as to how that medication error is documented, followed, tracked, and how we come back to reconcile so that it doesn't happen again. But there are other times when medication errors do cause harm. When we find out that we've unintentionally in the course of an event, let's say in the course of a surgical event, and someone wanted to pick up a dose of epinephrine, and the anesthesiologist by mistake picked up some ephedrine and created an adverse drug reaction. Or maybe an adverse drug effect because they picked up the wrong thing in the med cart because the ephedrine and epinephrine at one point in time were both brown ampules that looked almost alike that usually sat right next to each other in the old days, right? Y'all remember those? All right? Now, we might be dating ourselves for some of the younger pharmacists in the room. But there was a point in time when those things looked like each other, sat by each other, and you just had to be, quote unquote, a good pharmacist not to pick up the wrong one. Okay? So any medication error that does cause death or significant harm to a patient, according to Joint Commission, is called a sentinel event. And a sentinel event will have everybody in the country at your doorstep, knocking on the door. They'll have CMS will be there at one point, which is a Center for Medication Services, Medicare and Medicaid Services. The Joint Commission is going to come by. Your local state Department of Health will be knocking at the door. You're probably going to get the DEA that's going to come to the door at some point, depending on what medication it was. But a sentinel event will cause all kind of heads to roll real fast. All right? So we have to then, sometimes they're educational. The major sentinel event that I remember or recall was in my early years of practice, when a patient received 40 milligrams or 40 milliequivalents of KCL because the dose was written as 40 milligrams of Lasix, 40 milligrams IV push, and the patient received 40 milliequivalents of potassium. It might have been 80 milliequivalents of potassium IV push in the mistake of furosemide 80 milligrams IV push. But needless to say, I think that was about 1998, that was a sentinel event that changed the whole world of keeping potassium on the floor, on the patient units. How many people remember that? You had to change your whole level of practice and practice habits simply because, and we say simply because they were both in what? Brown amber bottles. They both looked almost just alike. In those days, we had what? Floor stock. So our patients had medications on the floor, no automation, open cabinets, and the nurse was to go there and pull her medication, right? And they go and they pull it and they see that brown ampule little vial, about the same size, about 4 milliliters in volume. And the potassium and the Lasix look just alike almost. Both brown ampules, 4 cc's. So the patient, I want to think, got 80 milliequivalents IV push. And if we don't know what 80 milliequivalents of IV push potassium chloride will do to us, that's one of the major components in the lethal injection. Lethal injection has about 120 milliequivalents of potassium chloride. Used to be a nice, big, healthy dose of pentothal and a good little bit of atracurium to relax the lungs and paralyze the lungs. And if you don't have a ventilator in place when the lungs go paralyzed, and if you don't have anything to wake up that pentothal that takes you under, and then you get that 120 milliequivalents of KCl that causes immediate AV node blockade and complete heart block, that's the recipe for lethal injection. So the other aspect of that is if somebody got 80 milliequivalents IV push of potassium chloride, that was deadly. It was fatal. That was a sentinel event. So as we went back and reviewed those things, that changed and began to introduce to us various techniques and ways in which we prevent medication errors. Joint Commission came down and there was an immediate cease and desist of having potassium chloride on patient care units on the floor. And they were swooping through everybody. That was an easy 30-day report, 6-month follow-up, and a 1-year visit again the next year, right? How many people remember those? You didn't want to be the one that called. You didn't want to be the pharmacy director in charge when you got a dean for having potassium on the floors because somebody was too lazy to develop a system so that the nurses could get it. I wouldn't say too lazy. I take that back. That's a little bad. But somebody was too busy. Thank you, Dr. Brown. Somebody was too busy to develop a system that would prevent that error from occurring again. So we do things called root cause analysis that go back and evaluate the systems of use, medication use, and how those are prevented. So we'll talk about that a little bit later too. There are various types of medication errors, and some of them are, simple that we can fix. Prescribing errors. These prescribing errors secondary to maybe a wrong dose, illegible SIGs, wrong frequencies. Through computer systems and automation, we've been able to correct those transcribing verbal orders from physicians nowadays because now they can do what's called the e-scribe. They can go through and check it right off on their computer, on their pad, and it comes directly to the pharmacy as an electronic script. And then you don't have to, not as much, have to decipher all the different types of handwriting and illegibilities. Dispensing errors and dosing calculation errors, especially on critical drips, critical IV infusions. We'll talk about those and other safeguards a little bit later. When individuals have inappropriately calculated the infusion rate and volume of a critically necessary medication, and once it goes in the veins, usually, if it's wrong, we can always add more. We can always increase the rate, but we can't take anything out. So now we're at antagonizing this event that we've caused. So some mistakes result from dispensing, physically preparing medications incorrectly. We talk about medication segregation. So segregating those medications that may have a propensity to be in similar locations in our pharmacies, but have a potential to cause a great deal of harm. Separating our concentrated saline ampules and vials away from our, for example, our normal saline vials that we might use for reconstitution, transcribing SIGs and instructions now because of the electronic prescribing. That's been a lot better. And as I previously stated, administration errors usually involving nurses, an incorrect route of administration. For example, once again, giving a KCL 40 milliequivalent IV push instead of IV piggyback. For example, over 60 minutes, it should be given 40 milliequivalents at a maximum. And they got to be on EKG monitoring tele if we're going to administer anything more than 20 milliequivalents per hour or greater. But those are fatal. All right, either one of those is fatal. 40 milliequivalents over an hour, that can be touchy. We only like to give 20 over an hour maximum. Those all are fatal errors that will result in a sentinel event. So other causes of errors, sometimes it's performance problems. Sometimes we don't follow proper procedure. Sometimes there are deficits in knowledge. And then we got to the idea of what did the pharmacists always say? What was the other thing that would always cause us errors in the workplace? And we tried to reduce those. What's the biggest thing many pharmacists you say, I can't get any work done because telephone's always ringing, right? So that was a major distraction. How many misfills could occur? How many things could occur? You get phone calls, telephone. So now we have a lot of automated phone lines. And now in this current day and age, many people send us messages in our email queue. So we don't have to use the phone, but the phone's ringing, the noise distractions. One pharmacist is working, and then the other pharmacist is talking, and as the other pharmacist is talking to the side of him, the pharmacist that's putting in orders starts entering what the other pharmacist is talking about. Right? So distractions, and they can lead to errors. Or you get a phone call, and someone comes in, and Gilda Brown in the room, or she sneak out somewhere. First, all these things always occur. Gilda Brown would enter a book full of medications, top to bottom. And she was just on the phone helping a nurse, and she realized before she hit send, she just entered them all on the wrong patient. Because she went in the profile to check. The nurse wanted to know if John Doe was supposed to get this, that, or the other. She went in John Doe's profile, talking on the phone, and then she realized she's behind. She comes back on, goes right back in John Doe's profile as opposed to Sammy Smith's profile, and just goes and enters 30 orders. Took her 15, 20 minutes. And then so she's like, oh, Lord, I entered this on the wrong patient, right? So those types of things would occur, and we learn from those. I had the benefit of being able to learn from those, and it only takes you one time. You see that, and you try to use those as experiences. Like, man, I don't want to have to run all those orders again, right? So noise levels at work that will lead to distractions, but we'd have strategies for improvement that also came up in the early 2000s. Joint Commission and ISMP in the early 2000s, they came up with things like do not use abbreviations. In the old days, you'd see an order for, how many people remember that MSO4, 10 milligrams IV? And that's it. That was the only thing down there. They'd be like, MSO4, 10 milligrams IV. Okay, what is that about? Okay. He said, well, if he wanted morphine sulfate, or does he want magnesium sulfate, right? You look at the dose, you're like, well, 10 milligrams, he want morphine. So most of us experience, let's say hospital pharmacy, 10 milligrams, you're not going to get no magnesium sulfate. That's going to be at least a gram. And then I need a fluid. But he may not put it in a fluid, so we're going to do what we normally do. But you see that morphine sulfate. But if a nurse sees that order, before there were the days of 24-hour pharmacist verification, the nurse would see that order at 2 in the morning, and she might decide to give magnesium sulfate. She might decide to give a whole gram. Most of the time, a gram of magnesium sulfate might not be deadly, but still it's a medication error. Depends on how fast now if she did it IV push, it might be some problems. But those do not use abbreviations became prevalent in the early 2000s. Do not use abbreviations, sound alike, look alikes. So then every institution was expected to have a do not use abbreviation list in your institution that was adopted and approved by your pharmacy and therapeutics committee. Everybody was supposed to have then some way of having sound alike, look alike list that's been adopted by your facility so that we can identify medications that sound alike, look alike, and then we identify them and what's our process for them being segregated. All right. So we use things like tall man lettering. Tall man lettering on our automated dispensing machines, on our selection devices, tall man lettering on our shelf labels, little sticky notes, or little healthcare logistics came up with these various little label stickers where you could put your sound alike, look alike things there. So as an institution, whether it's a modified 2B type institution, whether it's an institutional 2B or institutional institution like a hospital, we wanted to understand how could we improve our medication use. So do not use abbreviation adoption, tall man lettering, segregation, changing locations of certain medications, all right? Putting identifiers in our automated dispensing cabinets. So when a nurse got there, they got a nice little bling that came up in their face to let them know that, hey, this is a sound alike, look alike that could also be confused with this. Double check, all right? And we'll talk about other mechanisms like barcode scanning shortly. High alert medications. These high alert medications. So we were supposed to adopt high alert medications. These are all things what we've learned since 1999 or since 2000 when Institute of Medication Practices came up with Institute of Medicine said that to err is human. What are we going to do to prevent these over 100,000 deaths that occur that are preventable? High alert medications came in as another technique that we'd use, that we'd institute. We developed certain medications these medications have a high propensity to cause death or harm if there is an error. So critical drips and critical infusions, dopamine and dobutamine, because one or the other having a wrong rate of dopamine versus dobutamine could lead to a fatality. Heparin infusions, even heparin, because it comes in various strengths and formulations. They say, well, do we have standardization? Start learning how we're going to standardize the things that come in our facility. We adopt, because if I have heparin and I'm dependent on the nurse to kind of figure out what the concentration is, how many units per milliliter, the heparin bag we carry, and we're switching them up every 2 or 3 weeks when we used to do that. Remember, sometimes we switch them up depending on which one was the cheapest, right? Now we have a justification to our CFO. No, we can't change those. Our costs are going to be a little increased because we're looking out for the patient. So we ran those things up through administration, and CFO was a little mad. But we say, well, guess how many days length of stay we're saving you from not having an adverse drug reaction, okay? Secondary to this patient bleeding because they received heparin 25,000 units in 250 opposed to the less concentrated heparin 20,000 in 500, right? So these are all things that we put in place, high alert medications, and we'd identify them. So we'd have drugs that have a high alert status, so that the differences between nurses and pharmacists, what our beliefs were, nurses feel like, well, why do I have to go through this extra step? Whereas we as pharmacists, we'd be catching the errors on the backside. So we had to figure out how can we prevent the medication from getting to the patient in an adverse manner. So we developed other techniques. We looked at our most highly error-prone medications that have a propensity to cause death or harm, such as our chemotherapy agents. We would agree that in some surveys that were previously done, 98% of most pharmacists believe that this should be a high alert medication. IV potassium chloride. 96% of us during an early survey believe that this should have high alert status. And Joint Commission decided that for us. Neuromuscular blocking agents. Once again, Joint Commission has also decided that for us in a lot of instances. Patients get things like atracurium, cisatracurium, pancuronium, vecuronium, rocuronium, and they get these paralytics. And if we don't have very well established airways for our patient, and the physician decides to administer something that's a rapidly acting neuromuscular blocking agent like rocuronium, and doesn't realize he's only got about 2 minutes to get the tube down before the rocuronium is going to paralyze the lungs. And it takes 8 minutes to get the tube down because the patient has a short neck, a thick esophagus, and he can't get his tube placed, right? So now we have even parameters around those that help us to prevent medication errors. Hypertonic saline. Every once in a while, we get a patient who's got a sodium of 118, 119. We're afraid they might start seizing, so we do keep 3% saline in the house. But we have to have parameters around how we keep it, how we dispense it, and whose hands we put it in. Because if we get a nurse who picks up the wrong saline, a new nurse or a nurse that hasn't practiced very much in our institutional settings, and they think they're getting normal saline, and they go in and they pick up 3% saline, even though it's got big red bold letters on there, but that patient gets that 3% saline running at 125 cc's an hour, that could be a game changer. All right, IV insulins, IV electrolytes, heparin, thrombolytics, those are all high alert medications that we put protocols in place, parameters in place. We have the pharmacist is almost a must to handle these medications. They're usually it's usually highly agreed upon. They're not dispensed anywhere in any of our dispensing units unless it's a specialty area. Let's say like surgery or neuromuscular blocking agents, and then only anesthesiologists have access to those, because we can limit access in some dispensing devices. We can limit access to neuromuscular blocking agents based on the privilege of that physician. He only has access to certain individuals. So, one of the most common types of medication errors, what do we think? One of the most common types of medication errors is what? We think wrong drug, wrong route, improper dose, or the wrong patient. So let's see, wrong drug. Who thinks by show of hands, who thinks the wrong drug is the most common type of medication error, wrong drug? All right, so we got about 8 wrong drugs. Wrong route of administration, wrong route. All right, improper dose. All right, we got a nice majority improper dose. Wrong patient. All right, well, that's a couple for wrong patient. So the answer, administering improper dose. I think y'all cheated, because didn't I give y'all that on the quiz? So improper dose. The most common type of medication error is improper dose. Now, the other ones are very significant as well. When we think about the wrong drug, the wrong route, when we think about the 6 rights of the patient. We go through the 6 rights of the patient. That means that every patient we should give them the what? The right drug, by the right route, in the right dose, at the right frequency, right time, right frequency, and we did the right medication, the right patient, dose, route, frequency, time, got the right drug, circumstance, the right circumstance. So the right circumstance meaning that 6 rights of the patient. The right circumstance meaning that when am I going to give this 10 units of insulin to a patient, right? Or our patient. Does the patient know? When is she going to give herself 4 units of insulin or 6 units of insulin? The right circumstance, right? So we want to give that. We want to have the right drug to the right patient in the right dose, by the right route, the right frequency, right time, right circumstance. All right? All right, got another short video for us.
Mitigate medication errors that commonly occur at discharge and during care transition.
Yeah, of course we have, the medication reconciliation that hospitals are involved with because of Joint Commission's push to get that done. And this is very important, not only on discharge, obviously, when we bring a patient into the hospital through the ER or on admission, they have a drug history performed, but are they really taking these drugs? What other drugs are they taking? OTCs, nutritionals, et cetera, et cetera. You need to confirm all this, and that takes some follow-up work, contacting pharmacies, other health professionals to get that list done accurately. And that goes all the way through transitions, all the way through discharge. And giving a patient an information sheet about the drugs that they're on and what they're for, the indications, is very important too. One thing I'd love to see pharmacists get involved with more, because some of these drugs that they take home with them, they're potentially dangerous. And they don't always know how to use them safely, how to apply them, topicals, how to discard them. And we've had horrible things happen. A pain patch, for example, containing a very potent opioid, fentanyl. Mom was in the hospital. She unfortunately has a chronic condition with chronic pain. They place her appropriately on a pain patch. She goes home. She has small children, and she takes the patch off to replace it and throws it in the trash. So the kids go into the trash, and Mom has this Band-Aid on her. I'll put a Band-Aid on me. And there's residual fentanyl in it. And horrible, horrible, you could cry. The kid is found dead. These are real cases. I don't make these up. And they're not that uncommon, and not that same type necessarily, but other tragedies. So even getting involved, not just with educating about the drug, but educating about how to use that medication, use it safely. And furthermore, we need to get involved with follow-up calls to the patient with complicated therapies. I don't think we do that enough. Calling them, how are they doing? How are you using that medication? Have you had any side effects or adverse reactions? These are things that you could do that would absolutely increase safety, yet it's very rare that the pharmacy department gets into that. So we would definitely like to see more of that. And sometimes the nursing folks will do that, but I think a pharmacist with drug therapy would be the right people, and we're not investing enough in resources to do that.
So what we're talking about here is developing a culture of safety, a culture of safety in which the pharmacist becomes the patient safety officer as it relates to medications. In many of our situations and environments, it's a little bit more difficult in the community, ambulatory setting sometimes, to put together all of the patient's history. It's gotten a little bit easier with some improvements in our medication administration, charting and collaboration with physician groups, depending on what type of insurance the patient has, how much data flows over through our computer system. But in the institutional setting now, it's a lot better, especially patients that are under large umbrellas. And let's say one of the systems that I like using are systems like Epic, which is a medication use computer system that allows us to get information about a patient from one hospital stay to the next hospital stay, especially if both institutions are on the Epic system, and it just flows through the cloud. So I could have a patient that leaves Shands and they come to, let's just say, Select Specialty Tallahassee, and that patient, when they come to Select Specialty Tallahassee, because they use Epic, I have all of their information, right? I have all of their, I know what happened on admission. I have all of the previous history and physicals. I have all of the diagnostic tests. I can trend what medications they were on before, because it just flowed seamlessly straight through the system. South Georgia Medical Center in Valdosta, there are several that are on that same system that I like to use, and it makes it a lot easier. So developing a culture of safety. So we say, well, what is a culture of safety? Well, that culture of safety is one that we want to acknowledge. It's the acknowledgement of high-risk nature of organizational activities, and it's the determination to achieve consistently safe operations. So we've adopted a standard within our organizations, and even with, let's say, within our profession of pharmacy, as in loose mechanisms in the profession of pharmacy, at least in the state of Florida. The reason that we have to do this type of CE program is because the Florida Board of Pharmacy says, as a part of our adoption of a culture of safety, at least biannually, we're going to have our pharmacists to get together every 2 years to have 2 hours of CE on cultures of safety, medication errors, the impact of medication errors, and how we can improve them. A culture of safety talks about having a blame-free environment where individuals are able to report errors, near misses, without the fear of retaliation or punishment. And that's one of the things that we used to try way back, 20 years ago, we tried to implement in our medication practices. We wanted it, the first word it always was is we want a good reporting system, and we want it to be what? Non-punitive. We want reporting, because when I go to P&T and I go to P&T and I look, I've dispensed 50,000 medications in the month of February, and I only have 5 medication errors out of 50,000 dispensed, and I do the ratio, and we say, oh man, that's highly unlikely. But according to the data, that's all that was reported, right? But how many 20 times did I have a pharmacist that called to the nurse or called to the physician that prevented a near miss? Most of the time, many of you out there would say, you know what, I ain't got time to be writing all that up. Gilda Brown, you came in the room, yeah? I ain't got time to be writing that up and say, ma'am, can I get a new order, please? But if we document all of those things and we trend them at the end of the month, we probably would have 40 medication errors or near misses over our total of 50,000 medications dispensed at the end of the month. So we kind of cheat ourselves a little bit about systems. Sometimes we flow that information back through the system in order to create change and make change effective. But sometimes if it's not communicated or it's not documented, it's what? Not done. But this encourages collaboration across all disciplines. If I continue to have to communicate to nursing or respiratory therapy or another ancillary department about things that are potential near misses, then we develop improvements in the process that can prevent that next fatal or near fatal medication error. And it's a commitment. A culture of safety is also a commitment of the resources to address safety concerns. So over the evolution of time, we've seen where administration in institutional settings and even in our community pharmacy settings, where they've helped to improve resources because it made a safer environment. And I know in the institutional setting now, it's big that we have some pharmacy technicians or some pharmacists that are dedicated to get that appropriate admission medication reconciliation. All right, on admission. Used to be a time when Joint Commission, when it first came out in 2003, when they said, well, it was a big buzzword, we would reconcile medications throughout the continuum of care, right? Everybody had a policy on it. We reconcile medications at admission, transfer, and discharge, right? You had all these fancy things. But we didn't have the resources to ensure that it was done appropriately. We probably don't have them all now, but we can justify it a little bit better when we say, oh, we can have computer accesses, we have some technicians, maybe a decentralized pharmacist that can assist the nurse with getting a good medication history on admission. We are able to flow that information into our electronic medical record so that it populates where we have a home medication reconciliation list. We have inpatient medication profile. And then at discharge, we create a comparison between what the patient was on in the hospital, what they're getting discharged on, what needs to be discontinued. And they get a list when they go home as to what they should continue, right? Improving the culture of safety within healthcare is an essential component of preventing or reducing errors and improving the overall quality of care. These are the basic characteristics that encompass cultures of safety. So what approaches have we improved upon since 2000? The impact of increased standards of care on prevention. It's improved our medication-related errors. Overall, we've had a drastic reduction. It may not seem as much, but we have had great reductions in medication errors in the past 20 years. Hospital-acquired infection rates, because we began to focus and do well on processes, now we could look at other things, not only from a medication error perspective, but a patient safety perspective. So we focused on things like reducing healthcare-acquired infections, As pharmacists, if we know that our patient doesn't need that IV line anymore, they don't need a central line, we have negative cultures time 48 to 72 hours. We can talk to the physician about de-escalating IV therapy to oral therapy, getting rid of the PICC line, continuing and clean up on oral therapy, and getting rid of the IV line. We reduce the source of infection. Getting rid of Foley catheters early. Patients able to get out, use the bathroom, get up, stand, pivot, get to the bedside commode. At the earliest point in time, we can pull a Foley catheter so the patient doesn't develop a hospital-acquired or a CARDI, catheter-associated urinary tract infection. All right, those things are being tracked and measured now. Catheter-associated urinary tract infections is something that CMS, if you have an increased rate of hospital-acquired UTIs, an increased rate of central line-associated bloodstream infections or CLABSIs. You have an increased rate of 30-day readmissions for the same disease state. What CMS will do now, the big payer, Medicare, they will come back, they'll look at all of your DRGs that they have or your diagnosis-related groups where they perform payment, and within the past calendar year, if this particular institution fell 2 standards away from the norm, they can come back and levy a reduction on payment across all CMS DRGs, right? So that means that they may not do that the first time. They might give you some guidance on it. But according to quality, CMS can come back and they can deem the institution across all payable CMS DRGs if they fall way out of favor on certain types of healthcare-associated infection rates and certain types of 30-day readmission rates, right? That can be real detrimental to a healthcare system if they lose a reduction in payment across all CMS or across all Medicare DRGs. That's usually about 50 to 60% of all of the payments in an in a hospital is usually not necessarily commercial, usually from Medicare. About 50 to 60% of payments come from Medicare. Adverse event reporting. We've improved our reporting of adverse events through things like MedWatch, the FDA MedWatch. We're able to now send things up through FDA MedWatch almost immediately through, especially a lot of our computer systems like Epic, or you can send the MedWatch adverse drug reaction right up the chain through Epic or Cerner. And medication adherence, improving technology. And as we'll talk a little bit later, technology has helped to improve things like medication adherence. All right, we'll talk a little bit more about barcode scanning as a technology.
Safety is a big thing. You always ask nurses to check 2 patient identifiers, and you hope that that's what they do. But in reality, having a barcode scanning system is the safest way to administer medication to a patient. And we were able to track by nurse, by unit, how many people were barcoding not only the patient, but barcoding the medication. We were able to provide that information to the nurse managers who could provide it directly to the staff. And it really helped us to improve our medication error rate. We have virtually eliminated medication errors. Our scanning rates are up at the 97th, 98th percentile in most units, actually in every unit. And we actually started that very low. We could identify very quickly the units that were not scanning, hone in on them, and put some process improvement in place to make sure they were. So now we barcode everything, and our medication rate is very, very low. And usually only when someone forgets to barcode, which is unfortunate. But the reality is the safety part of that was huge. I think the other things that we've seen is as we start to bring more equipment in, for instance, we did our beds, and our beds can wirelessly populate the Meditech record with the weight. It can populate the record with the safety features were enabled on the bed, so that if someone falls, we have a documentation that says they were enabled on the bed or what we did to improve that. And as we start to bring in more equipment, we will start to put that so that it populates Meditech automatically, and I don't have to rely on a clinician going in and entering some data in. We're doing that with our glucometers. Our glucometers now will populate the record immediately so that the glucose reading is available to the physician right away, and they don't have to wait for us to dock a station and those kinds of things. And I think that's the way of the future. I think the future is going to be that we have to, whatever we do, whatever equipment we have, it needs to populate the medical record so that that documentation is done. It gets the nurses away from the computer and more at the bedside. And that's really the goal of what we're trying to do.
Hi. So, as we improve the technologies, as we improve our medication technology, we're able to see things through, like our barcodes, as she just spoke about barcode technology, barcode scanning. There are ways in which, as she stated, I used to run these reports. I can go run a report right now by nurse and tell how many medications this nurse administered within the past month. Of the medication she administered on her shift, or was supposed that she said she gave, I can tell how many she barcode scanned. Run a report directly. What nurse? So then I can give that nurse back to the chief nursing officer and say, hey, Nurse Betty, if she would have scanned any of her patients' medications, we would have had over a 95% scan rate. She was 0 out of 100 on med scanning. And because she was 0 out of 100, we're 88% less than, instead of being at 90% or 95%. And if our benchmark is 90% or 95%, and we're reporting that, then when I'm at P&T, then I'm going to look down there and say, well, I told Jill that Nurse Betty wasn't scanning. Jill, did you have an action report for her? So, so when CEO, he starts looking at me crazy, or she starts looking at me crazy, or somebody starts looking at us crazy, then we have data that's actionable directly according to the technology, right? Benchmarking gold is usually about 95% medication scanning. That's a good benchmark. If we can scan about 95% of our medications, we're doing good. And sometimes we have issues. The scanners don't scan. They can't read the barcode. Might be a distorted label, things like that. And they can do an override. But that should be the exception and not the norm. So if you're administering, 80 or 90 medications in the course of a month or in the course of a week, I shouldn't see where 50% of the time your scanner didn't work. So then what do? All right, scanners don't work. But they keep complaining that scanners don't work. Well, let's order more scanners, right? So that's how we do it, because it's all patient safety. They're all patient safety tips. Because if that patient is not barcode scanned, if the medication is not barcode scanned, then that's an error waiting to happen, right? How many people are familiar with that type of technology? It's been very, very good. How many people know about the reporting mechanisms? Anybody run the reports and reporting mechanisms? All right, good. So ain't nobody slip through the cracks on you. They start talking noise, you just go run your report. All right. Another technology. Let's see. Okay. IV infusion systems. This is another good one I have for us here as well. A good technology that can help us in our world of preventing errors.
Our nurses here like the smart pumps. First of all, because they're easy to use. Second of all, because they are smart, and they do take all the guesswork out of calculation.
Well, what a B-Bron smart pump does well, first of all, we spend a lot of time when we're designing our pumps looking at the needs of the nurse. What does she need to make it easier for her to give the medication safely? And we design a product that allows the nurse to do that, that's easy to use and that's flexible.
So we spent the better part of a year changing everything from being highly sophisticated, high technology, to making the technology behind the curtain, make it invisible, so that the nurse, really all she had to do was hit a button or two that she was already used to hitting, and all the safety features were there automatically.
You don't have to figure out how many milliliters per hour you need to run a drug based on your physician order. You have an order, and again, this is policy in your own hospital, that specifies what the dose is. You plug the patient's weight and the dose into the machine, and it calculates it for you. And then displayed beautifully on the screen is what drug your patient is on and how much drug they're getting. So in a glance, you could look at a patient and know what they're getting. Plus the whole alert system with the minimum and maximum dosing, so that in the event, and it's happened to people, that you make a mistake in programming, the pump will tell you, you just put in an extra 0. You sure you want to give this? And you can double check yourself and correct yourself. That's a big plus.
Studies have been done that show that fewer than 1/3 of the hospitals that have bought these high-end smart pumps are actually deploying the smart pump features. So people aren't using what they paid for. So one of the things we've spent a lot of time with is getting people not just to buy the product, but to use the product.
I think what B. Braun brings, in addition to the technology, is the customer service and support that we provide. Our implementation of pumps provides 24/7 on-site clinical support, which is imperative for a successful implementation of smart pump technology. We provide follow-up educational support. When we implement our wireless technology and our dose track software, we provide both technical and clinical follow-up. And I can look at it as a B. Braun employee, but I was also a B. Braun customer for 20 years, and that's one of the things that brought me to B. Braun, was I saw the great support I received as a customer of Braun's all those years. I knew they were always going to be there when I needed them.
It would not be helpful to us to have a vendor who dropped 300 pumps on the loading dock and said goodbye, have fun. We need somebody who is going to be with us, and the clinical arm of B. Braun really did help us tremendously in analyzing the data and helping us to make recommendations for what we needed to do clinically.
Smart pumps provide all sorts of information at the bedside to provide safer administration of medication. They also store all that information either in the pump or in a wireless environment. They can send it to B. Braun's dose track software, which collects all of that information, which provides a wealth of data that hospitals can use to identify quality improvement activities. Supporting customers in measuring compliance with the use of smart pumps and in analyzing the data are unique to B. Braun. We're the only smart pump supplier that supports our customers in those ways.
In 2008, we had 0 medication events related to infusion pumps. So our journey was one of a beautiful line going downward to 0, which we were very proud of. They've really been by our side through the journey to medication safety.
All right. So even when we look at medications, one of the most common types of medication errors is that nurse or that group of nurses, especially in the critical care environment, that have issues with calculating the proper dose of critical infusions. When we have critical drips, critical infusions, that it's exactly what it is. It's critical. And when these IV pumps, if the rates of infusion are off, if the patient gets too much drug or the patient gets too little drug, then that's a big problem. Now, for us as pharmacists, we still must have the backup mechanism of being able to calculate through these problems. And we still, whether we're in a community care environment or whether we're in an institutional environment, the onus still belongs to the pharmacist. The onus belongs to us to be able to properly calculate what that right dose is. But for the nurse that's on the unit, sometimes in order to prevent medication errors, the smart pumps have been a great innovation over the years. I can also look at a smart pump by nurse. I can tell how many nurses or what nurse administers what drips, which nurse has I can look at fluid. If I'm looking at patient John Doe or Jane Doe, and I need to know what their input of fluids were on the IV pump, I know immediately through the computer system that John Doe got 2,000 liters of fluid in the last 2,000 hours. he had an output of 200 cc's, so that meant he retained 800 cc's of fluid. So we might need to give him a diuretic because he's volume overloaded, right? So smart pumps are great innovations. They're also safety precautions for our nurses, and they help to prevent those critical medication errors that can occur secondary to miscalculation. Now, for the students, that doesn't mean that we don't have to learn calculation anymore because all I got to do is plug it all up in the pump. No, we still got to be able to back calculate it all the way back. And you just to double check. You have to sharpen up your pencil. All right? So at the conclusion of all these things, we identify the types of medications. We identify the types of errors that exist. So what do we do with this data? At the end of the day, we go back, we analyze whether it's in our institutional pharmacy or our community pharmacies. And if it's even in our community pharmacies, the state of Florida, in all community pharmacies, and as well as in any pharmacy in the state of Florida, at least quarterly, all right, I'll say this, in any pharmacy in the state of Florida, at least quarterly, we must have a what? At least quarterly, we need to have a continuous quality improvement or CQI meeting. At least quarterly. Say, well, what is that? That is the time when the pharmacy, the staff and the pharmacists, we get together and then we share what we call our quality-related events, or our QREs. You know, it's a protected environment. Our CQIs can't be subpoenaed by Morgan & Morgan. They're undiscoverable. So we can go, they're used for the process of improvement. We look at what caused the error. Why was the error caused? We look at the data, and we do something called a root cause analysis. And in that root cause analysis, there are a couple of principles and there are a couple of things that we look at and we want to be able to identify in that root cause analysis. We want to understand what the cause was. What caused the adverse drug reaction? What caused the adverse drug event? It's a retrospective event, or a retrospective look back at the event that occurred, and it's done for improvement. And we want to do a chronological layout. We want to be able to lay out, well, how did this error occur? So somebody took a verbal order from the physician over the phone because, let's say, the patient's insurance didn't cover a particular medication. So we needed to call the provider so that we can get a new script. However, over the phone, we may have transcribed the wrong medication. So we go back and we evaluate the technician or the pharmacist that took that verbal order over the phone, reduced it down to a paper, input it in the system, but then we may have gotten the wrong medication. So we evaluate that system. We do that in a retrospective fashion. That's the first beginnings of what we call a root cause analysis. So we take all of this data, and we look at it, and we use this data to inform us on preventing medication errors in the future. Now, what we also want to do is we want to focus on the system. We want to look at what system or what process can be improved. We don't want to look at the blame. Well, she wrote down the wrong thing, or he wrote down the wrong thing. Well, was there a reason? Was there a distraction? Was there something in the environment that caused the pharmacist or the nurse, or that caused the however it occurred? What was a rate limiting step of the process? We go back and we look at the process and we improve it. And it's a systematic approach. Okay? So accidents in health, they come from a variety of mixed reasons, right? It could be, as we said before, it could be work relations, work conditions. It could be just deeply embedded things that occur. Remember, most medication errors are unintentional, but they're also avoidable. So we go back and we look at our process, we look at systems, and we look at how can we improve. And that's why we are committed to having a continuous quality improvement program. And that's why we also come here every couple of years to see what we can find out, see what we can learn. So final assessment question of the day. Implementing continuous quality improvement programs and understanding the root cause helps prevent future medication errors. True or false? All right, true for everybody. All right, good. So we want to be a part of the solution. All right? We don't want to be a part of the problem. We want to be a part of the solution. So I'll leave you with this. Hospital medication errors as way back in 20 years ago, at that point in time, were the cause of over 100,000 patient deaths a year at its peak. We've implemented solutions, we've developed technologies, and we've developed ways of improvement. So we want to be, as pharmacists, we want to be a part of the solution and not a part of the problem. Okay. All right. I'll take any questions, and I think we're well on our way to getting you guys back to your I-10 destination as soon as possible. Any questions from the group? Yes, sir. What is it? Remind me. Yeah. I think they were bought. I think they were bought out by another proprietary company. I'm not sure who bought them out, but they were bought out, and that technology has been embedded now in a lot of our computer systems, to where immediately you could go immediately into an inpatient environment, and I'm not as sure about the ambulatory environment, but in the inpatient environment, John Doe, you can go to John Doe's medication, document immediately in that medication, and if you document a certain level of a risk or a certain level of an ADR, another window will pop up, and you can send it directly to MedWatch. But I'm not exactly sure if that one still exists. Anybody familiar with any other proprietary vendors that document and report errors? I know a lot of them now we do. Like, I know Epic has a great one. Athena's good on that, and they're almost all online directly within the system. Epic, Athena, Centricity, Cerna, they're excellent. And you can do, I used to pull my hair out doing monthly P&T meetings, reporting things like doses dispensed, reported medication errors, other types of documents. Now that that stuff's all computerized, all I got to do is go in and build a report, check off what I want. It'll populate it all. And if I want to put patient names on it, I could. But if I don't, I could just use the numbers, hit a couple of other buttons, and it'll even create a graph on an Excel spreadsheet. And then I can export it and put it in a PowerPoint. What used to take like a week. It wouldn't take me. It should have took me a week, but a lot of times I'd be running behind. I'd end up doing it in about 2 days. Any other questions? Yes. There's nothing that dictates. So in about 2012, the federal government said that everybody by 2014 should have implemented what's called meaningful use. Meaningful use states that by December 2014, everybody should be on electronic medical records at physicians' offices, hospitals, and the idea was we want this data to be captured so it can be shared, right? Well, as they extended meaningful use from 2014 to 2018 being the time frame, this data, it doesn't say it has to be housed in a uniform section. You have various providers. Blue Cross Blue Shield, they may get all of their data from the pharmacies that they use, but they may not share it across all boards. It's not consistent. So data is captured, and it's in the cloud. It's not coordinated and cohesive for any of us to use without some digging. And if we don't have access to the platform that patients have transgressed through, then our picture is not clear. There are some situations when we get to some integrated delivery systems to where it is clear, like a VA system. It's an integrated system, and it does build on top of one another. But other than that, there's not one common place to get all of that information. If I get a patient that comes to my hospital that left Shands, and they use Epic at Shands, or they use Epic at South Georgia Medical Center in Valdosta, now my physician, his medication reconciliation is easy because it flows directly over to the system. If I have HCA hospitals that are on the same network, all that information flows in there together, and I have that history. But if that patient breaks that cycle, then I lose data. All right? Any other questions? All right, thank y'all very much. Y'all have a good day.
Good afternoon, everyone. Would y'all like to stand up and stretch out those bones? I know y'all a bit tired. Stretch, twist, turn. We almost pushing through. Once again, good afternoon. I am Clarissa Ferdinand, a first-year Doctor of Pharmacy candidate. Dr. Blight is a professor of social behavior and administrative pharmacy at Nova Southern University. He received his bachelor's in science pharmacy from University of Kentucky, PhD in pharmacy healthcare administration from the University of Florida, and his PharmD from Xavier University of Louisiana. Dr. Blight has 40 years of professional experience in preventing drug problems and substance misuse. Dr. Blight is currently serving as the Program Committee Chair for Pharmacy Section of the American Public Health Association and served 14 years as Chair of the Program Committee for Alcohol, Tobacco, and Other Drugs Section before that. 23 years as the Parliamentarian of the American Association of College of Pharmacy, and 20 years as the Director of Continuing Pharmacy Education for National Pharmaceutical Association. Dr. Blight has served over 400 presentations and published nearly 40 papers. Some of his publications include the books Clinical Research in Pharmaceutical Development, Multicultural Pharmaceutical Education, and a Guide to the Top 200 Drugs. Dr. Blight was inducted as a fellow into the APHA Academy of Pharmaceutical Research and Science in 2015, and as an inaugural fellow of the National Pharmaceutical Association in 2016. He received the 2013 Chancey Cooper Award, which is the highest honor bestowed by the National Pharmaceutical Association, 2007 Award for Innovative and Exemplary Contributions to NPHA Foundation, and the Ellen B. Stiff Local Association President's Award as the leader of the Virginia Pharmacists Association Local Association of the Year 2001. The James Tyson Award, which is the second highest honor from NPH 2001, and American Public Health Association Leadership Award from Alcohol, Tobacco, and Other Drug Session 2000. He currently resides in Fort Lauderdale, Florida. Please welcome Dr. Blight.
Good
Good afternoon, everybody. I'm what's holding everybody up. I will get us moving forward. It's good to be here. I was real excited when I saw it was the Leonard Inge Clinical Symposium, having been around a lot in the Floridas in the 70s and 80s and around. So we'll see what we do today. I have no financial disclosures. I hope each of you have the cards because we're going to be using those for some interaction here. I have a couple of conflict of interest disclosures. First off, I'm a pharmacist. I believe pharmacists make a difference, and so I will be talking from that point of view. So you need to understand that pharmacists are really the most important health professional, and that's what I tell my pharmacy students, or my student pharmacists, I should say, and everybody I come into contact with. I'm also sadly having to teach in Fort Lauderdale, Florida. I have to look at some of these beautiful pictures on the wall from Guy Harvey. It's a sad thing to have to do, but I will have to use that as a conflict of interest. It used to be I was only afraid of one thing, and that was a rattlesnake, but I'm not anymore. Oh, I don't have that picture on there. Okay, but now it's sharks because we are the sharks. Philosophical disclosure. A man who views the world the same at 50 as he did at 20 has lost 30 years of his life. One of my heroes, my mentors, I was from Kentucky as he came out, and when I heard that, it affected me as a man getting ready to go into his 20s, and it has guided my life a lot. And that's the 50 years high school reunion just a few months ago. So I came with the corollary that a man who views the world the same at 70 as he did at 50 has lost another 20 years of his life. So I kind of try to keep that as my guide. I'm teaching my first online courses right now. I'm teaching large group discussions with 253 students, trying to do some very interactive things across 4 campuses. I bring this up first off because it's Florida, it's Miami, and this is disruption. We're going to talk a lot about disruption. This mouth, as he was kind of called back then, the Louisville Lip, was not going to win anything, right? He did get a gold medal in 1960 in Rome, but not beat Sonny Liston, one of the best boxers of all time. And in the first round, about a minute, 29 seconds in, boom. This happened, one of the biggest disruptions in all of sports history, and it was voted the 4th greatest sports moment of last century. I have another philosophical disclosure from another one of my mentors. Education is the most powerful weapon which you can use to change the world. I believe very strongly in that. And it can also change your life. Real change comes from education. So I've tried to use my mentors to try to guide the things I do. So here's my learning objectives. They're printed in the book. I'm not going to go over for pharmacists and for technicians. I like to show them. So let's get out your cards. We're going to do some things. That's my wife and I going to see the 4 guys. We had some, it wasn't the 5 guys. They haven't put a 5th one up there yet. I hope they do. So the first question is, who was the first African-American to star in a nationwide TV show? Nationwide TV show. Red Fox, Harry Belafonte, Nat King Cole, Johnny Mathis, or Sammy Davis Jr.? Let's see. I see some A's coming up. There's some of you who are young enough to know who this is, yes? Some good history. Well, I see a good variety of answers. And the correct answer is, of course, Nat King Cole. Now, please understand this disruption. Okay, this is a huge disruption. I don't have the date up there yet, but this is 1956. No sponsor has come forth yet to subsidize this program. NBC put him on with no production company and no sponsor. Now, shows were 15 minutes back then. And then later, Rheingold Beer came and sponsored it, so it became a more popular show and stayed on about 4 years. It was a very good one. All right. Another level of disruption. What's the next level after Giga and Terra? Is it Yoda byte, a zettabyte, an exabyte, a petabyte, or a femtobyte? I have no idea, right? I didn't even know what a terabyte was until I got something. Oh, we got some D's here. I got some more D's. Oh, I see an A. Oh, and you're holding up all of them. Oh, that's good, but it's not all the above. That I can tell you. Okay, thank you, B's. I appreciate that. The correct answer is it's a petabyte. Okay? I will say in the next year you're going to be getting computers with petabyte memories. Terabytes are you're running out. Okay, my USB drive I'm now using 800 terabytes. I'm just about completely out of space. All right, and that doesn't even begin to talk about what we're going to be doing in medical information. And you can see after Peta we got Exa, Zeta, Yoda, Pronto, and Geop. All right. Through what genre was the first black-white kiss, male-female kissing, that were black and white on network TV? Was it a variety show, a western, a comedy, a science fiction, or a cartoon? Okay, getting some interesting responses. Now, I watch a new TV show called All Rise. It's about an African-American judge in Los Angeles. And she has a picture of, it's science fiction, of Lieutenant Uhura in her office, big, as a role model. Okay? So this is the first one. Now, do you think this disrupted TV? Oh, my goodness. The number of complaints that NBC received, FCC received, almost caused NBC to go off the air for having this on TV. So see, we've all gone through some massive changes in culture and everything, and we've done it in our professions, which we will see as I go through. So how long after the transcontinental telegraph was completed did the Pony Express survive? Remember that great Pony Express that went from Independence, Missouri to Sacramento, California, got mail out there in 10 days, and it was a great thing. So how long did it survive after the Pony Express started? We got some 48 weeks, 48 hours, E, B, 48 days. Oh, you want to go 48 days. Okay. All right. Well, that's interesting. This answer shocked me. It lasted 48 hours. So do you know what disruption does to a business? It's instant and it's fatal if you're not up with it, okay? So after English and Spanish, what language is most often spoken in the United States? Chinese, French, German, Tagalog, Vietnamese, or Arabic? I didn't say South Florida. I said the United States. My Haitian friends would love the fact that you put a lot of B's up there, but it's actually Chinese. Okay. Now, I think I have one later, but I might not, but that deals with that. So let's look at some emerging trends that are going on. Does anybody know what is or was significant about this date besides 1111? That's the first day a baby boomer of generation person turned 65 years old. Okay, that's the very first day. All right? And so we're now in year 9 of 18 of this largest, huge bolus of people going into our healthcare system at 65 years old, which means they're elderly. I call them young, but some people call them elderly. All right? So, and this huge number is going to continue until well after 2029. So we have this big change going through our system right now of 65 years old. It's called the silver tsunami. Okay? The average number of prescriptions, if you're, the average number of prescriptions filled annually, 3, 6, 13, 20, 22. 13 starts at 50 to 64. It jumps to 20. When you turn 65, the average number of annual prescriptions, and then just jumps a little bit at 80 plus. So, good for pharmacy. Lots more prescriptions being filled. But it really puts a burden on the healthcare system that shouldn't have been unexpected, because there's a whole lot of us baby boomers starting back in the 50s, right? Did you know you were in a $1.5 trillion business? So think about that. That's some money. And money attracts a lot of players. Okay? So you're seeing a lot of people getting interested into prescription drugs because it's a $1.5 billion business. So has anybody, some of you probably work for CVS. If you don't work for CVS or you don't or aren't a customer, you probably haven't seen the new labels. Okay? Very modern. You can see it has how many tablets you take right here in this section, different times of the day. They took their stuff from the universal medication schedule, which is here, which you're supposed to take 8, 12, 6, 9. So those are 4 times a day category. These are all just the messes that people, the way they take it. But the universal medication schedule has, you don't put 3 times a day, you put the time of day, and it's set times for things, okay? And they're supposed to adjust their eating schedule around their medication schedule, not their medication schedule around their eating schedule. So let's look at the future. A lot of people, we get a lot of things written about the future. People talk about the future. So what does the general public think of the role of pharmacy in the future? Okay? So those of us that are old enough to remember the 60s, is there a pharmacist here? No. All right, well, maybe it gets better. How about the 80s? Any pharmacists here? No. Well, at least they have a counselor, right? Yeah, okay. Okay, how about here? 2016, how many patients? I'm sorry, I'm a Trekkie. The same group of people, there's a physician and a Vulcan, but no pharmacist. Okay? So, how have we looked at our future? Here in the 1950s, here's what we looked at the future. Everybody remember these beautiful Rexall stores? There's a couple here in Tallahassee. Still one down in Dania Beach in South Florida. In the 60s, this is what we looked up to as the future. I actually got to work in that pharmacy in Lexington, Kentucky. In the 70s, Eugene White had a pharmacy that didn't have drugs. It was that kind of thing. In the 80s, Jack Eckert designed this type of pharmacy that every chain copied. And they're still being used a lot today. Now, here's some of the new ones. Okay, 2010s, we looked at this. USF pharmacy looks a lot like this. I didn't see any of my USF people here, but I always like to brag about how modern their pharmacy looks and does. And in the 2020s and on beyond, this is kind of a pharmacy. The CVS. This is a health hub at CVS. Houston, all the stores are this way. They're starting to do Philadelphia now, and they'll eventually get into Florida to do this. This is what the pharmacies are going to look like. They're going to have a lot of clinics, places where you go to counsel people, work with people, and do things. So as hospital pharmacy moved into the future, well, most of you have lived a lot of this. We've moved from individual syringes to automated syringes. We've gone from individual IV bags to automated bag filling. We've gone from individual piggybacks, gosh, those are a pain, to automated. Now, I've never gotten to use an automated machine, but it's been about a decade or so since I've been in a hospital pharmacy. We have plain old drug stock versus this nice automated drug stock. Boy, that saves time looking up things, doesn't it? And if you've never had to do the old system, you don't appreciate the new system, okay? Individual filling of thing versus an automatic filling of the patient cards. From last talk, visual identification of drugs through barcoding, and now even radio frequency identification in some places. I think the VA is moving that direction in some places. So let's get out your audience engagement cards. If you've never gone to Albuquerque, the first weekend in October, it's the International Balloon Fiesta. It's the most photographed event in the world, and it's kind of cool. So What did the original Bank AmeriCard change to? Was it MasterCard, Visa, Discover, Capital One, or Optimus? The original Bank AmeriCard. Okay, I see some B's and A's, C's, these D's. Oh, I've seen some D's finally. Okay. Capital One. Oh, I like that. What's in your wallet? I bring this up because it shows you what has to happen for fundamental changes. Does anybody remember pre-1958 where you or your family, it was mostly my family, I was still fairly young, had a charge account at every store, grocery store, dry cleaner, pharmacy? You had a separate charge account. And your mom or your grandmom used to have to go and pay each month to pay off the bill. In 1958, California experimented. Bank of America said, let's see if we can have a card that's accepted by everybody. And it wasn't until 65 that it went nationwide. Now imagine where we would be if this disruption hadn't started. How could you order anything off Amazon? There wouldn't even be an Amazon. Okay? So just think of how far, some of these disruptions have come in. And then now we got mobile wallets. And the sad thing is I can't keep, mine keep wanting to pay for things on my phone. It just says, hey, here's something to pay for. And I don't want my mobile to come up, but it automatically comes up when it senses something to buy. I got to stop that. Who was the first married couple to share a bed on network TV? Lucy and Ricky Ricardo, Fred and Wilma Flintstone, Archie and Edith Bunker, Steve and Elsie Keaton, or Peggy and Al Bundy? Who's the first married couple to share a bed on network TV? All right, so this. Okay, getting some more answers, getting some diversity of answers. Oh, yes. Fred and Wilma. Now, followed by a year later, Herman and Lily Munster, but they weren't humans. But it wasn't until 74 that humans actually shared a bed together on network TV as a married couple. All right? So again, disruption and change. Which generation has the most people? Baby boomers, the Gen Xers, the millennials, the greatest generation, or Gen Z? Gen Z, I believe we now have 25% of our class at Nova Southeastern that are Gen Zs. Okay? It'll be 50% next year. See some A's? Oh, yeah. A was the right answer until 2 years ago when Generation Z, there are more Gen Zs than anybody. Those born post-1997 now outnumber us all. That's because some of us boomers are old enough to have died. Okay? Now, how's that for a change? We grew up always being the biggest generation, those of us who are boomers. Those of you who aren't boomers always grew up knowing that boomers were the largest generation, and now that's changed. Again, a dynamic that's going to change everything in society. So what is the Internet of Things? Is it the World Wide Web for the Addams family? An upscale search engine? A network of objects embedded to exchange data? Web access protocol? Or a hack-resistant internet system? I know this is a millennial kind of question. Well, I'm getting some E's, D's, okay. They're not even guessing. I say they only guess if they think they know the answer. They're not going to guess. Okay, I see some D's, okay. It's a network of objects used to that are embedded to exchange data. It really started with airplanes and trucks, and now there are 50 billion objects used by 7.6 billion people connected to the internet. Alexa being one of those. Your cell phone being another one of those. So what is the interactive search engine that shows the exact location of every device connected to the internet? An IoT plot, an internet map, or an interthing map, a Shodan map, a Divic map, or a Loco Connect? I don't expect any of you to know this. There's not many millennials in here. There's a few over here. Okay, I got some good answers there. I'm still looking for one correct answer. Oh, and I see one back there. Thank you, sir. Okay. It's a Shodan map. This shows. All right. Now, what's significant about this? We grew up with Big Brother watching us. Well, we're watching us. We are watching us. We are Big Brother, not the government. So I could put in a parameter and say, I want only those people who have iPhone 7s. You know, those dumb phones as opposed to the smart Samsung phones? Okay. I fight with my students every day with that, okay? So anyway, or I could put in how many people have a special type of refrigerator that's connected to them, and that would change the whole dynamic. This is just every object, but you can look. So I could see, so they could track, they, meaning us, can track where you are based on you having a device hooked to the internet. Okay? Whether it be her coloring, her watching a show right there, okay? It's all of it. Now, I don't know who's up there. There's one little dot in Greenland. I don't know who's in Greenland using something. But just think, this is where we are in the world. So let's look closer at disruption. All right? So let's first start with where we are now. Our healthcare system is really a sick care system, right? We're not dealing with health. We're dealing with sickness, disease, illness. We're trying to take care of those who are too ill to take care of themselves. That's our whole system. So we've got a bunch of silos working in different places, okay? Of course, the big, most important one is pharmacy. I can tell you, I'm prejudiced. Pharmacists make a difference. We add that to unprecedented access. Still, even after 3 years of trying to destroy one of the great things that happened in this country, it's still the law of the land and still is responsible for expanding the coverage, all right, to millions of people, especially young adults, Hispanics, and lower-income Americans. So now we have, unprecedented access plus unprecedented costs. We're at 17.9% of our gross domestic product goes to health care. Wow, that's a lot of money. That's a high percentage. Quite $1 in $8 is more, but it's more than $1 in every $6. Okay, and still looking to go up, as time goes on. Okay. One of my favorites. I didn't want to put the song on because I'd sing with it and it would really ruin every moment. But a change is going to come. Okay. So, let's look at some disrupted industries. Remember Borders Books and Blockbuster? Blockbuster was approached by Netflix and said, would you like to add a streaming service? And Blockbuster laughed and said, who will ever stream videos? There's one Blockbuster left in the United States, and that's in Oregon, in Bend, Oregon. It's a museum, but it's also a store. It's the last one left, okay? And it used to be 9,000 stores. Okay, so I'm just saying, defunct, boom. You see any of these things around very much? Nah. Yeah. Now, again, I try not to be the same as I was at 20 or at 50. And so I was at an American Pharmacists Association annual meeting 2 years ago, and to take some of my stuff to Fort McHenry because we were in Baltimore. I wanted them to see where the Star Spangled Banner was written, and it's a very emotional place to go from the way they do it. And we met downstairs, and I come pick us up. And then as we were ready to go back, I was saying, okay, let me call a taxi company. He said, oh no, we've already got a white Prius being driven by Joseph with this license plate coming to pick us up. And I said, who, what? And I said, oh, yeah. And here's his location on the map. And I said, huh? They said, that's Uber. And it was 1/3 the price and twice the convenience. So did I change overnight? Oh, you bet I did. I haven't had a taxi in 3 years. So, and here's another thing that we've learned across the United States, the use of surge pricing. So when it's busy, they charge more than when it's not busy and they charge less. Have you ever looked at Disneyland prices or Disney World prices now? They have surge pricing. Your price of admission depends on the day of the week you go and the time of the year you go. And it'll vary by as much as $30 or $40. I imagine it's going to be real low for the next few months. I'm thinking, time to go back and get reacquainted. Well, actually, I'm an annual pass holder, so I go all the time anyway. So anyway, here's some other disrupted industries. I'm seeing fewer and fewer cash registers and more squares. I guess maybe I'm eating at too many trucks and buying from too many vendors on the streets, but that's what allows these things to occur. So disruption has already really occurred, guys. The largest accommodation provider owns no real estate. It's Airbnb. The world's largest taxi company owns no taxis. That's the Uber. What's another one? The largest movie house has no cinemas. Netflix. You can look at the others. These that have disrupted right now in the past decade. Now, it's not entirely true because Uber is not really a taxi company. It's a connecting company. It connects people. Okay, it doesn't, but it provides the same kind of service. So they thought differently, different services. Airbnb isn't a hotel. It connects people. All right, same thing with Netflix. All right. God, it used to be what was on in the movies. Now it's what's on at Netflix around the water cooler. Okay, and they don't even have water coolers anymore, but we still stand around and talk. So where are we on the disruptive curve? Both education and healthcare are still way down here and have hardly been disrupted. We already know a lot of changes that occurred. So we're in for some big changes coming up in both types of industries. So which direction are we heading? You know, or are you heading? Are we disrupting or are we being disrupted? Okay? So business as usual is dying. I'm sorry, I like that one. So how are we changing? Mirror, mirror on the wall, am I healthy after all? Workout mirrors. Health mirrors has her weight up there as 49.8 kilograms. But it gives you all the different, the weather and everything, and gives you health. Okay, so we are changing as our individuals, our patients are. There are now home health mirrors like this that not only will tell her that she has a virus, but that she contacted this SUXXOR cold virus on the train, on the subway, because other people, all the information on other people who have this same virus, they know exactly where she got it and when she got it. Gosh, could we use some of that now? Oh, my goodness. Okay. I'm saying we're practicing safe meeting going. We're kind of separating around, okay? You know, so just get the thing here. You can get, but anyway, just all this different technology. And my favorite, which many of you will dislike, is, of course, smart toilets that will look at what's in your feces, look at the different DNA things that are in your feces, and tell you a lot of things. You need to have more, you need more peppers, radishes, and tomatoes, and here's where you can buy them for 20% off, 40% off. Boom. Okay. All right. Now that's it. You know, you just go in, you know, and tells you what you need. I don't know. I don't think I want that much information coming from my poop, but that's all right. I used to say 5 years ago, the robots are coming. They're here, guys. The robots are in a lot of pharmacies now. We don't need pharmacists to be counting. They're in almost every major hospital. Have you seen the 3D printers that print drugs? There are now 2 drugs approved by the FDA that can be printed. So can you imagine when we get further down the line, somebody needs a specific drug with a specific type of solution to help them dissolve, that you and your pharmacy print out the drug for them. Real individualized, personalized medicine. So if our students, if we aren't preparing for this kind of future, it's not a good thing. Uber Health. Let's see.
Every year, a lack of reliable transport leads to more than 3.6 million missed healthcare visits, resulting in $150 billion cost for providers and poorer health outcomes for patients. Something's been missing in the NEMT industry. Until now. American Logistics has joined forces with Uber Health to solve the mobility problem by leveraging Uber's vast driver partner network to reduce barriers to care. This powerful partnership creates turnkey solutions for healthcare plans and providers that make patient transport easy and efficient. One unified platform provides smarter and safe patient pickup and drop-off with scheduling, messaging, and GPS tracking. Together, we're focused on building innovative solutions that drive positive health outcomes for millions of patients. Learn more at grownemttogether.com.
So not only Uber Health, but Uber Pharmacy. Okay? Certain types of deliveries coming now, kind of like DoorDash or Uber Eats. There's also the Uber Health, where it's bringing back the house call, where you dial in and it has a doctor coming to your place of residence, where you get the same thing as you get with Uber. Here's the picture of your doctor. Here's their qualifications. Do you want the doctor to come to your place? Okay? That's being tested. I forget which city. It might be Des Moines. But so Uber Health is working on that to try to stay ahead of what people want. And that's and in some places, not Florida, premium strains, fast and friendly delivery. Now, we used to have that back in the 60s, but it was our neighbor coming over. I mean, I don't know. That's what I heard. Don't know anything about that. But now it's an Uber bringing by. Okay. That is work. That is happening in Denver. How about some customer delivery systems that are in the plans? This is a picture of the Amazon patent application for a floating warehouse so that they didn't have to pay for land. It's cheaper because you don't have to pay property taxes in the air. You don't have to do a lot of things in the air. And so they have a floating warehouse, and they have this floating that unloads, and then these things come down and deliver to you. Or these things. All right? That would include prescriptions, which I'll show later, called Pillbox, from Pillbox pharmacies. Oh, there it is. Which is a different type of, I don't see any vials. I used to have a picture of where hell the vial's gone. Because this is the new way, again, looking at like the universal medication system, they put the number of tablets. So in here there's 2 tablets, and there's 3 tablets, and boom. Here's all of Monday's drugs, all ready for me to take at the right time with them labeled. Okay? I'm going away for the weekend, so I'll take Friday, Saturday, and Sunday's medications with me. Boy, isn't that more convenient? You don't have to put things into little containers. Pharmacists came up with this idea, and Amazon paid them a lot of billions of dollars to take it over. Walmart was trying to buy it, as was somebody else, to try to get into the business. Because they were already licensed in 47 states. Now it's all 50 states and territories. So this is going to be, the pill box is going to be really big, and that's pretty easy to put into those kind of containers to deliver. So pharmacies, retail pharmacies, are going to change a lot. So in the recent past, those of us who remember 2019, 2018, we looked at reimbursement-based medicine, volume-based medicine, trial and error medicine, intuitive medicine, symptom-based medicine, whatever you want to call it. That's the way it ran. And then more recently, the past couple of years, we've been really looking at evidence-based medicine, evidence-based practices, right? And that's what we're teaching more in pharmacy programs, evidence-based practice. But in the future, pharmacy practice will be predictive, preventive, personalized, and participatory. That means the patient will be participating in it. So you get all this big data. That's why we're going up to petabytes, because each human will generate about 100 petabytes of health information in their life. You have all that data to mine, and you add all the things we know as pharmacometrics, which is everything from pharmacodynamics, pharmacokinetics, all these things, dose optimization. You can see the thing. And that will equal precision medicine. Now I'm going to play part of this because...
Hi, my name is Alana Simon. I'm 19 years old and currently studying computer science at Harvard. When I was 12 years old, I was diagnosed with a rare pediatric liver cancer called fibrolamellar hepatocellular carcinoma. Thanks to incredible technological advances, the help of scientists, and the fibrolamellar community, I was able to identify the change in the DNA that leads to this cancer. Rather than trying to broadly learn about all liver cancers, I just examined a small, well-defined patient group, which is what allowed for such a precise discovery. With this knowledge, we're now working on developing the first diagnostic tests and new treatments for fibrolamellar. Last year, at the White House Science Fair, I met the president and got to discuss my research with him. It was such an honor to meet him then, and so it is with great pleasure that I introduce the president to you today.
That was as he was introducing the Precision Medicine Institute. But what I wanted you to particularly hear is what she said before introducing us. I had a very specific type of rare liver cancer, and they only looked at literature related to that specific kind of rare liver cancer, something that we couldn't have done 10 years ago. And by doing that, they were able to find different things. Okay, so that's precision medicine isn't just about doing genomic testing. It is also about finding precisely what it is we want from drug information. And then the message going on that when he starts the precision medicine is that it goes more into the pharmacogenetics and genomics that we're talking about now more and teaching our students more about. And so that's that's the colossal shift that's happening now. So if you're standing still, you're also going backwards. It takes a lot of movement to maintain, a lot of effort to maintain forward movement. Okay? So one of the things I ask my students who think they're really technologically advanced, and one of the things I ask our pharmacists who want to be more technologically advanced, is where are you on the Rogers theory on the adoption of innovation scale? Okay? You want to be down here among the innovators and the early adopters. Okay? The people who start using the technology early and learn it early. Because if you learn it before your boss and you show your boss how to use it, boy, Don't they like you a whole lot? Just remember that as a student. Bosses like to learn things. Well, a lot of us are over here, the late majority or the laggards. Because pharmacy, and we were talking about this before, during lunch, we like what we do for the most part, and we don't want to change what it is we want to do. And it's going to change whether we want it to or not, so where are we going to be in trying to make these changes? All right? So the change is really already here. We've got all these new models of care that I'm getting ready to talk about coming in, and now we got another tsunami besides us boomers is the silver tsunami. We got the tsunami of healthcare changes coming in and pharmacy education and just washing over everything and changing things. So let's get out some more audience engagement things. Angkor Wat. I was waiting for Angelina Jolie and my wife pops out, but that's okay. I don't mind. What was the first artificial satellite launched into space? Voyager 1, Pioneer 1, Sputnik 1, Vitoshnik 1, or Echo 1? Okay, thank you, Donna. Well, I can see we have a lot more boomers around. By the way, this is a picture of the Earth taken from an outer space and all the satellites that are currently around us. You can hardly see us. The other two were made-up names. But thank you. That means I have good distractors. That's always good to me. If you were around in 1957, the world changed as you read the newspapers, because that's what you did back then, because TV wasn't very good, the news wasn't very good, and you read that there was an artificial satellite launched by the Ruskies, our mortal enemies, orbiting the Earth. Change. Disruption. Fear. We were really afraid because we didn't know what the satellite could do or couldn't do. All right, was one. And the second thing is, I don't know if any of you could, I know I did every evening when they would tell us, hey, if you go out this evening around 8:30 p.m., you could see, because it's a brightly colored mirror, you could see it go across. And that was so weird to see something going all the way across the horizon. I mean, it was eerily cool. All right? And then up, it was just a bunch of, just a heat shield, an antenna, and some batteries to broadcast back down. It lasted 4 years and died. It took us a little over a year to get our satellite up. So for a year, it was scary. Really scary as to what was going to be happening to the world. So in what industry would you find 10 to the 100th power? Would it be trigonometry, healthcare in general, pharmaceuticals, travel and tourism, or high technology? Does anybody know what 10 to the 100th power is? It's the highest named number, and it's called a Google. Okay? Now, we learned what a Google was way back in the 50s. Now, the new Google didn't come out until later, but it's I don't know if this is right, but I kind of thought that was good. I like the new logo dancing around, so... World is certainly a lot different. Matter of fact, I had to send an email from an article I wrote to me about all the information Google has on me and how to get rid of it. So I'm going to get on as soon as I can because I kind of like my privacy a whole lot. I don't know if I can get rid of it, but I try my best. What is the moment when the limits of the human mind are surpassed by artificial intelligence? Is it the legacy footprint, singularity, superintelligence, the Turing test, or the Kardashev scale? What is the moment when the limits of the human mind are surpassed by artificial intelligence? It's a very significant moment in history to come. Singularity, the moment of singularity. Why it's important, there are many groups of people say that's the ending of humankind. The machines will no longer need us because they can think better than us, and they will get rid of it. Sounds like a Terminator. All right. But I'm not so much in there. I like to think of it instead of artificial intelligence, intelligence augmentation, because they can help us make better decisions and help us do things that can't be done. So I'm less pessimistic, but then again, I've always worn rose-colored glasses to every place I ever went. So what activity do owners of smart speakers use the device for the most in 2019? Checking weather, general questions, strategic, timers and alarms, or reminders and to-dos? Now, I put on my songs. I like it when I have my songs. Yes, I do. I love it. I can see what your all's personal preferences are. But the percentage of people who do each one of these is what's the weather today? While you're listening to music, probably. Okay, but I'm just saying. And I'm not making that data up. I tend to get it from Alexa. Alexa, buy me berries from Whole Foods. Okay, Jim, I just bought Whole Foods. Okay, I thought that was a funny one. Okay. So let's look at education. There's going to be a lot changing in how we educate pharmacists for the future and how we educate student pharmacists for the future. I'm going to start with, what are we as pharmacy educators teaching that the coming technology cannot do better, faster, more efficiently, harmoniously, and with better adaptability? What are we as pharmacy educators doing? So let's think about that for a minute. I'll bring this point up to the students I teach tomorrow. I get the pleasure of teaching some of the family students tomorrow at 11 a.m. 11 a.m. And they don't think this course is as important as their therapeutics. But I remember in my therapeutics, I learned about black box warnings. It's something that you would never do. And you memorize that because that's a key fact. And that key fact is you don't use beta blockers in heart failure. What's the current number one treatment for heart failure? Beta blockers. Okay, so don't memorize any of this clinical stuff. Where I don't want to get clinical professors mad at me, but it changes. Not only does it change, it goes to the complete opposite. You need to understand how to use clinical information. All right? And this is one way. So I presented this particular slide in Dubai last week, and it blew them away that students are going to be able to put a computer on their eyes. It's not the Google glasses. It's really Google Contact. It's a full computer contact lens. So what are we going to do when a student comes in for a test? Look at their eyes? All right? No, we're not. The only way to do it is to make them think and therefore access the information, which is what we want them to do because we want the most up-to-date information because it changes so that they can look and do this. Okay, they can see. Of course, some of them will be watching soccer probably, but that's all right. I mean, football, I had to say that. Okay. So this is the first thing we got to do in education. How are we going to test our students? We have to already be prepared for that. These now cost $5,000 or $6,000, so I don't expect too many of our students to have them. Although I suspect at least one or two do, since our tuition is so much higher than yours. I think some of our students have some money. But over the next couple of years, it's going to go down to a couple $100. And then it's going to be pretty widespread. Sorry, you can't wear contact lenses to the exam. I'm just telling us, if you're in education, this is what we have to do. There are new types of students that we're teaching. As I said before, 25% of my class right now of 2023 are Gen Z students. So these are people who were born with cell phones in their hands. No, these are people who were born with smartphones in their hands. Not flip phones, smartphones. They're called digital natives. I mean, the millennials can't even think that, okay? They're always connected. They're always multitasking. But they really value education, and they're very entrepreneurial, probably the most entrepreneurial generation we've ever seen. And that includes the silent generation and the greatest generation above me. Although I will say the greatest generation were a lot of good entrepreneurs who opened up a lot of independent pharmacies. So we've got to tap into this. We've got to build it. We've got to keep the value of education and keep this. So this is what our future in education and hopefully in pharmacy practice is going to be like. So guess what? If you're an entrepreneur, there's a 100% chance you could have a job when you graduate. There's a 100% chance that you could be your own boss and do a good job. Okay? You just have to be prepared for it. So you can look for a job or you can create a job. So we need new educational strategies to address these new types of students. I'm sure you have a few here at FAMU already, but it'll grow. As I said, I bet it'll be close to 50% of your class in the next 2 years, and then after that, it'll grow into 90. And it's never 100% because I still have people in their 50s, in the young 50s, and young still coming to pharmacy programs. We have changes in product over time. So as we've had changes in product, we've had to change education. Back when it was all an art and doing mixing and doing compounding, it was apprenticeship, nothing but apprenticeship. And then we said, no, we need to have a science background, and so we started colleges of pharmacy. And then we moved to the doctor of pharmacy because we became more patient and clinically based. Okay, so when our product has gone from compounds to drugs to the patient, this is where our education has changed. So we go back to when I started, the pharmacy was pretty close to half liquids. Now this is long after this is in the late 50s, early 60s. And we mixed a lot of liquids together to help our pharmacy. So we had basic compounding. My pharmacognosy lab was my favorite. I mean, we haven't taught that for decades. And then we started with new chemical indices, where we started to learn structure-activity relationships. You know, the drugs are the easy names, the Olols, the Aprils, those kind of things. So medicinal chemistry was pretty much at the center of everything. They were most of the deans in the colleges of pharmacy, had most of the research grants. New drugs are important. I think there are 6 drugs out of the top 200 that were on the market when I was in pharmacy school. So I have learned about the new drugs, most of them, because of my knowledge of structure-activity relationships. But that's changed. We now have biologics. A biologic drug is a product that is produced from a living organism or contains components of a living organism. So you got these huge molecules, huge complex molecules. So complex that you can't even do a generic, right? You can only do a similar. So this is why we have biosimilars instead of generics. So other new concepts. 2016 was the first time that over half the new drug approvals were classified as biologics. Okay? And you can see for the past 5 years, it's been around 40% or more. So we're changing classes of drugs that are out in the marketplace. So we went from having to know botany and pharmacognosy to a lot of medicinal chemistry to I think now we have to really do more biology and immunology. That's the center. That crazy scientist that everyone thought was completely wacko when he said there's this bacteria, and back then he called it a Campylobacter, that caused ulcers. Nobody believed him. And all of a sudden, when other people started researching it, and they changed the name to the Helicobacter pylori, he was a genius. Now he thinks there's a bacterial, now, 10 years ago he started pushing that this is what causes plaque buildup, bacteria, some type of infection in your bloodstream that causes plaque to build up and these things to build up so that heart disease can be treated better with some type of specific antibiotic regimen that is against these organisms. Helicobacter pylori requires a really specific. Okay. But anyway, so let's think about biology and immunology might be the key to almost all the diseases we know now. I believe we now have 2 gene therapies approved by the FDA. So what you're doing in gene therapy, I don't think I have a slide. That do I? No, I don't. I started to build them. Those are hard to build. So I ask my students if they're able to do a gene therapy that reverses diabetes, will that affect our prescription drug line? And the number of patients going into hospital? Yes. How about if we do diabetes and hypertension? Where are we as pharmacists at that point? Oh, and they go, why are you being so pessimistic, Dr. Blythe? I'm not. Because there's one fact that we all know. For every action, there's an equal but opposite reaction. And who knows more about drug reactions than pharmacists? Who would know more about genetic therapy reactions than pharmacists? This is, again, why biology and immunology becomes the root of where we have to go in the future. All right? It's not to be afraid of. It's what we know, okay? Now, we just changed our curriculum. I'm at 3:29, so I still got some time, right? Yeah, I'm good. I'm watching it. And I know that's an hour off, so I'm not just starting. Now, let's look at another diagram that took me hours, maybe 25 or 30 hours as I go through it to get this all together, trying to think of another thing where pharmacist is key, where we are going to be in the future. And it's called pharmacy and population health. All right, so we've got patients going from the emergency room to admitting to inpatient care to being discharged to outpatient pharmacies, to clinics or a pharmacy, into a medical home. So that's the circle of life. All right? So, if they're in an ambulance, a tech completes the med history in the emergency department or in transit, talking to the EMTs. A tech, not a job for a pharmacist, a job for a tech, supervised by a pharmacist. Okay? In the emergency department, you can see these things. We do rounds. We verify orders. We resolve issues. We help transition the patient to the unit from admitting. There is a couple hospitals in South Florida where a pharmacist is in the ED and in the admissions taking care of this. Already, full-time pharmacist, 24 hours a day. So that's 6 pharmacists hired to do these things. All right, plus more who know how to do it so that people can go on vacation and do things. And it saves the hospital lots of money. They've shown that. And the hospital says, where else can you save us money? So it takes these kind of initiatives by some directors who have a good end. And then then they're in their unit, and again, we do more transition to care, but safety is key. We verify orders. We have clinical duties. All right, so this is, again, where a pharmacist is doing clinical pharmacist-based things. Then we have discharge counseling. See, right now, I just have a problem in a lot of places. Nursing and patient educators are doing med-recs and some of this discharge stuff. And it's not a good transition of care when we see where patients have to go. And that'd be a good place for my public health model. But I need to remember that. We don't want scheduling their next primary care physician or practitioner and clinical pharmacy visit. And yes, we help the patient sign up on the Allied Health Management. Most of the major hospitals now have their own online management where a patient signs up and get a lot of direct information. I believe the pharmacist is working with them to do this because it has direct implications onto their drugs and these kind of things. So this is, again, for a pharmacist. And then this is what we do in the pharmacy. Although I don't know how many of us younger pharmacists over here are doing texting to our patients, but I do know a lot of our younger pharmacists, probably over here, who text their patients. Okay? Communicating directly to a patient. And then a big thing that's growing is point-of-care testing. You can do acute infection testing, chronic disease screening, chronic disease monitoring. Now, Florida's a little behind on this. There are 41 states that allow pharmacists to do these things. Public started with the top one. They were doing flu and strep and then had to pull back because of the scope of practice. And no one from the board told them to do that, but their lawyers told them to do that. Our board didn't tell them they couldn't do it. Their lawyers told them they need to wait to see how the rulings go on scope of practice. Maybe there's a silver lining to this thing that we're all have a little bit of fear of. The coronavirus will be an increase in pharmacists being able to do some of these things. Okay? So you can see all the things that you want, okay? So the point-of-care testing can be done where you send the results out, or it can be home care where it's done right there. You see that penny there? You see that little thing right there? When you blow it up, it's a whole lab inside of it. It does all the work inside. It does all the analysis for you. So a single microliter of blood, that's a lot smaller than a drop. A microliter of blood, you can tell if the patient has malaria, what type of malaria it is, what the patient's genetics are, and which of the therapies they will respond to. Boom. It's that specific for almost every type of test. This is where we're moving into the microfluidics. So these are things we're going to be doing in a pharmacy. Again, being more clinically engaged with our pharmacists. So that means we need to understand what these tests are doing and how to interpret them. Pharmacy integration continued. So in the pharmacy, we manage medications, we adjust doses, we de-prescribe, a relative new concept where we are working with patients to get them off of medications or to decrease the dose. I believe it's 34% of all Medicare, care for the elderly, care patients are on a drug that's on the Beers list. I'm sitting there, and in December, I was having a really bad postnasal drip, the worst I've ever had. Something new, flowering, something mold, or something got to me. And I was having trouble sleeping. And I went through my antihistamines, and I said, there's only one that's going to really help me. And that's azathioprine. And I took it a couple of days, and I went to writing to my clinical pharmacist today. I said, this, I go, Jerry, your 70 years old. That's on the beers list. And I went, oh, I didn't even pay attention to it. It worked well, and because I took it earlier in the evening, I didn't have, but I was lucky. So it's really hard to be conscious of some of these things when you don't even realize your own age. So to talk about it is something. Deprescribing is a very growing phenomenon. Okay, laugh. You can laugh at me. I have to learn the hard way sometimes. I'm not as smart as I look. Okay. Anyway, so when we're managing medications, a lot of patients, especially in a community pharmacy, will go, why would I trust a pharmacist? They just want to sell me more drugs. Well, if we're actively involved in deprescribing and helping the patient lower doses, lowering the number of medications they're taking, then we are flying in the face of that misconception, okay? Because what we want is better health for our patients. And so we'll see if that's something that happens or not. I'm very optimistic about that as we let people know. And there's a couple good articles on that. If you want to look at more, go to deprescribing.org. Deprescribing.org. It's a wonderful website out of Canada because they have a very active community of physicians and pharmacists involved in deprescribing. And it'll give you protocols and algorithms for deprescribing everything from proton pump inhibitors down to some diabetes medication. I don't know why I enjoy looking at it, but that. So who do you think is the most resistant to deprescribing? Physicians or patients? Patients. I said physicians too, and I was wrong. It's the patients. The physicians like you working with them to make therapy better in most places. I know in northern Florida that's not true entirely. The patients use an online platform to make appointments, okay, to go through their personalized, patient-centered, pharmacy-based care, okay? So this is what some of these online things are. Now, when you got a patient right now who's 85 and doesn't even know how to have an email address, and who's a minority who doesn't have internet connectivity, then this poses a problem. And we've got to find a way to get some of these tools to our older patients, to our socioeconomically disadvantaged patients, even more so than before. So it's something that's going to help them. Deadline, with a little text that pops up on a therapy, taking the medication, that kind of thing, will be things that can really help our patients through things. Now, how we do that, it's hard in the current political climate to imagine that, but I think we can. So, in this personalized care, what do pharmacists add? Because as we already said, we're going to algorithm-based precision medicine. Well, I believe we as pharmacists add cultural sensitivity, socioeconomic understanding, and you can read these things. What are capsules made of? What animal does gelatin come from? You have any Muslim patients? Yeah. Are you sensitive enough to remember that? Well, you may be sensitive enough, but you don't necessarily remember that. Okay? So we have to find ways to meet the needs of our patients. All right? It is about culture. I know we've worked really hard to get rid of the word sugar, but how many of our African American patients still have sugar, right? Well, it's sugar, it can't be bad. So they don't understand the severity of diabetes. They don't understand the severity of hypertension. Well, I feel fine with my hypertension, and the medication makes me feel terrible. How do we convince somebody? This is, again, it's not a computer that's going to help them with that. It's us being understanding. Okay, and I'll talk a little bit more about socioeconomic, but there's a socioeconomic understanding, and yes, this drug A may be 10 times better, but if it's 4 times the cost, it's not going to do the patient any good because they're not going to take it. So they may have to take drug B that's offered at Walmart for $4. Okay? So even with insurance, a $30 or $40 copay is a lot of money. Whereas a $4 prescription is still more than you want to maybe pay, but that's still a whole lot better. That's a magnitude difference. So how do we know? I don't know. I don't like necessarily referring patients to Walmart or CVS or Walgreens with these plans if I'm working somewhere else. But, if I'm trying to take care of the patient the best way I can, and I do that, they're going to trust me. They're going to come to me. So, again, this is all about listening and doing that. And those of us who are in education need to really help our younger pharmacists, who's pretty much all of our students, understand that generations are different. Us boomers think a lot differently than millennials, a whole lot differently than Gen Zs. Okay, so how do we get them to understand these generational differences and how to deal with them? And then, of course, motivational interviewing. So let's go back to that model. So we need the skills we need to be teaching our students, supervision skills, communication skills, teamwork skills, counseling skills, young children with disease management skills, medication management skills, all of the above. These are the skills that we need to be teaching more of. I'm not going to speak about what university it is, but it's really like Sharp. Just changed its curriculum a year ago and started emphasizing more the dispensing function. When these people once graduate, they may not be dispensing. So I'm doing these things, and hopefully word gets back, and my dean goes, Barry, what are you telling people that we need to change to? And I'll go, here's what we need to do. And she still won't listen. Oh, she'll listen. She does, but it's convincing all the faculty because it's a faculty-driven process, not a dean-driven process. So education is another big thing that we're doing. So let's look at this. Just got this. This came off Friday's or Saturday's news. Online pharmacy startup wants to sell $5 generics to all. Everyone. They're accepting no insurance. That way they don't have to pay attention to any of the gag orders or anything. The $5 price also includes shipping. Wow. So $4 gone to Walmart, $5 and shipped to your door. What do you want to do? All the drugs are there. Drug prices may vary, but the cost of a physician visit, which you do online via telemedicine, is $15 for a physician consultation. My copay's higher than that. All right. And this is what I like. This is what I was initially I didn't like this idea. But we read a lot about rural patients having trouble, but also all these care deserts right here. In Chicago, there's an area where it's 15, 20 miles to the nearest pharmacy. People in one of the very poor communities in the south side of Chicago. Because all the Walgreens and CVS bought out all the independents, and then they closed all the stores in the region. We have care deserts all over the country. Chicago's just the one being written about the most. All right, so I'm not saying this is an answer, but this is where healthcare is going. By the way, this is what the pharmacy already has been doing for a while. You've probably seen the ads for the Men's Health or the Viagra. And I'm going, yeah, where are they getting their Viagra? Well, it comes straight from a Pfizer company. Oh, that's an approved generic by Pfizer. Approved by them, approved by our FDA. And I went, oh. They also have Rory, which is a dental clinic, a digital clinic for women. They have Zero, smoking cessation, and Plenity. They do a whole thing on weight loss. Plenity is another company, but they specifically dispense. So they're already into these 4 markets big. Okay? and doing this. So this is, again, we're moving into the future really fast. So as we're advancing population health in our curriculums, I hope, because this is where our practice is going. And in my wonderful introduction, and I thank you, we talked about our role in the American Public Health Association. We just had a symposium sponsored by the CDC Foundation and NACDS Foundation, two unlikely partners, who came and talked about what pharmacists are already doing in some of these pharmacies in terms of disease state management. And for 8 hours, there was not one mention of dispensing. All mentioned about patient care initiatives. All right? Anything from basic screenings, immunizations, preventive services, and you can see here. And it's this is where pharmacy is moving to. It's not that we're not going to be having our product around, but we're going to have tech, and these kind of things already coming. So we have to teach patient understanding, communication, and individualized patient care. So we want them to think in that way. I call it cultural kinetics. Kind of like pharmacokinetics, where you have population parameters, and as you get information on the patient, you adjust the dosage. In cultural kinetics, you have information on what appears to be, what you see in the patient, and then as you learn new things, you change your cultural approach. So we're moving from cost-based care to more towards value-based care. That's where we should have always been more into the healthy, trying to prevent some of the at-risk. 80% of the costs are borne by 20% of our population. So how do we slow that down? All right? I won't go into measuring quality because that was covered in the previous presentation. But Massachusetts Medicaid has an experiment going on right now. There's a drug that just came out that has a $3 million price tag. And it's for hemophiliac. And you take the drug, and you don't need another blood transfusion for 3 years. If the drug works. It means it saves a lot of millions of dollars. Going to the hospital, getting blood transfusion, blah, 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 blah. Okay. But they have negotiated with the drug company that if the drug works on this patient, we pay for the drug. If the drug doesn't work on this patient, we don't pay for the drug. The drug company agreed. That's the only way they were going to get a $3 million drug paid for. All right? Anyway, it's millions of dollars. A lot of money. All right? So we are moving towards risk sharing. And accountable care organizations, value-based organizations, medical homes are doing the same thing. They're agreeing to take care of these very sick patients for a set amount of money. So we have to have our pharmacists in tune with how to get data, how to analyze data, and how to make sure these patients aren't being readmitted into the hospital and doing these things. So this came out 5 years ago, and at least 25% of the compensation of hospital pharmacy managers in a region that the survey will be based on how high the institution's quality of care scorecard is. All right, and you see almost 73% of the pharmacists said, or this wise crowd said, yes, that's going to happen. And I can say it's happened in a lot of places. In Tampa General was one of the first places to go that way in the state. They went that way in 2016. And now they have their assistant directors on there, and they're getting ready to move to their pharmacist in the hospital. Part of their salary is going to be based on how well they perform. I hope we're all willing to do that. So the effects of all this is that our job now is to keep patients well. Not treat the sick, but to keep them well. A different way of thinking. We need to prevent leaving the hospital and going back in. So you need to be able to monitor specifically pharmacy's contribution to the overall care. All right, and that's how we are moving into the future. That's data analytics, that's pharmacoeconomics, that's the fun subjects that deal with all the numbers. Technicians, we have Tech Check Tech. We have Tech Supervising Check coming up, and they're already happening in places. Different states. Texas is moving. Texas has already, I believe, moved to you have to have an AA degree to be a pharmacy technician, and has plans to move to a required bachelor's degree to be a pharmacy technician so they can take on these advanced roles. There's already technician residency programs out there. Y'all know you don't hear that in North Florida because, again, you're too close to Alabama and Georgia. We're not close to the Midwest. All right? They collect and document patient data and manage robotic operations. These are advanced technician roles. Again, to free the pharmacist up to be able to do things. Now, Tech is Tech fills a prescription and it's checked by another technician, not by a pharmacist. And in rural areas of Michigan, that's already part of their law as of 2019, 2020, forget. So in pharmacist shortage areas, that's part of the Michigan State Practice Act. So what can we teach our students maybe most importantly? Change management. How do we manage change? Something we never talked about certainly from this program, okay? What skills do we need? All right? So even if you're on the right track, you'll get run over if you just sit there, all right? As I keep saying, data collection, data analytics, data reporting. My students get tired. I haven't even brought up Disney much this time because I don't have you focus on it. But I bring up a lot of Disney stuff because I'm a big Disney aficionado. But also because they have the best customer service in the world overall. They have a big institute, and a lot of companies send people there. Okay? And that's how we do it. So we need to teach flexibility and critical thinking. We need them to not only recognize change, but they need to anticipate change, and they need to create change. So the best way to predict the future is to create it. That's what those pharmacists did who founded Pillbox. Okay? They created the change that they felt was needed to better serve their patients. And then to quote that incredibly important 21st century philosopher Pitbull, every day above ground is a great day. Remember that. So I'm a little early, so I'm going to go through a couple more audience response questions. So get out your cards and tell me, who are these young men? Are they movie stars, incredible dancers, musical prodigies, corporate founders, or politicians? Let's see if we get a generational divide here. See, we can start seeing the generational divide, can't we? Huh? Yeah. These are the Nicholas brothers. Oh, well, it was available this morning when I watched it 3 times. Maybe that's why it's not available anymore. Flash dancing, some of the best dancing in the history of the world. Howard and Fader. I can't remember their names exactly. So who is this young lady? Is she a singer, an athlete, a model, a movie star, or a pharmacist? I teach a lot about cultural and generational differences, and these are slides I added in case I needed a little more time. You go, D, yes, you're right. That's Butterfly McQueen. She was. Didn't look like her a little bit, but she said she didn't mind being funny, but she hated to be made stupid. Anybody know who this young man is? A news commentator, a jazz musician, A politician? Oh, yes, sir. All right. You knew that, yeah. Hardly a man more handsome in the world back then. Funny way he lost his seat, but I think he hired his wife, who was living in Puerto Rico, to work in Washington while she was living in Puerto Rico. And not only did he go to jail, but he got reelected while he was in jail. And then when they said you can't do that, Charles Rangel took his position, who's still there, I believe, and had to win his last election against Adam Clayton Powell IV. All right, so world is funny and small. So who is this young man? News commentator, a musician, a politician, a pioneer, or a dancer? Oh, getting some guesses. I'm stumping some people. Oh, yes, I love it. I had to call him a pioneer because if I said athlete, you'd know immediately because of the way he was built. That's Ernie Davis. All right? And you can see his predecessor at the position was Jim Brown. So Syracuse was well known for having running backs. And there's the three main ones that came out, okay? Great movie. Didn't realize he died before he played his first game in the NFL, but okay. But anyway, how many times the U.S. has landed on the moon? I'll give that question, then I won't go anymore. So what I've tried to go through, this is a disruption again. We had to make up for losing first man of space, and then make up for losing first subject. So pharmacy is undergoing massive changes. Healthcare is going through massive changes. And not because of anything other than it's so much money, people who have different ideas are coming in. All right, I thought it was really telling when Warren Buffett, Jeff Bezos, and the guy who runs American Express all put together their own little employee benefit. And it's going to be interesting to see how that is. So we as pharmacists have to be prepared for a lot of changing dynamics. Not be afraid of it, but be prepared for it. And some of those skills that I've listed, including learning a little bit more about gathering data so that we can measure how we help positive patient outcomes becomes much more important. And some of the hospital pharmacy data I have shows that pharmacy departments are having to do that within a specific hospital, not just as part of the system, but as part of the hospital. So we have to do that. So I'm hoping that I've given you a little bit of glimpse into the future. It's been a lot of fun coming here, and I thank you very much. I sent it to them so that they could, yes, sir. And if you need more information, you can contact information. I'll be glad to take care of anything. All right? Glad to be part of the first 100 days. It's a real honor for a man out of
So, with that being said, we have come to the end of our program. I feel like to sing End of the Road. If I could, I would. But before you go, you have your evaluations. Well, those are online. You now can complete them because that, for those of you that have been here the whole weekend, you can use the link that Mrs. Cleveland, I think, sent out yesterday, and it takes you from Friday all the way to Sunday. And every time you complete a section, you have to answer each question in that for that person in order to go to the next page. And then you can write any comments that you may have, because we get all of that from IT, and we'll be able to receive that. You went through a little oral gap analysis with Dr. Thompson. If we need to collect any additional data, we'll send out a link for that. But I wanted to take this opportunity to personally invite you all back. As you know, on your last page, it talks about the 44th Symposium. The reason, so this was the first inaugural for Mr. Inge. The reason why the 44th is going to be important because Mrs. Cleveland has worked with Mr. Inge for over 25 years before his retirement, and then she continued to work up until with different directors. And so she will be retiring at the end of the academic year for 2020. Yes. So when you see her next year, Lord sparing, at the scholarship gala, she will be an honoree at that time in terms of her retirement, like we used to do, and we used to honor those that are retiring in that year. So we want to definitely invite you all back to come to that. And then you have the additional dates here in the brochure related to, well, we have a preceptor workshop for those of you that are preceptors, you already know about that. But more importantly, we also have the consultant course, which will be in Jacksonville, Florida. That's the consultant initial and recertification. Now, my grandmother always taught me to give people their flowers while they are living. They are still out there busy. I've texted her. I asked her to come back in. She has not made her way back. But we did have flowers today for Mrs. Cleveland and Mrs. Garrett, her ride or die, because they are two peas in a pod. And we just want to say that all of the things that you see here today is not just because of one person, but is indeed of a team effort. And again, Mrs. Cleveland has worked with several directors prior to my arrival. She's the one that will email you all to make sure y'all were here. And we just wanted to show her a big appreciation at this moment. But really and truly, we need y'all to come back, okay? So please come back next year so we can honor her properly. Are there any questions at this time? I feel like the board meeting. We're adjourned. It's time to go. Have a good one, y'all. Please turn in your sheet to Mrs. Garrett. She's outside. And please give the small card to the young lady with the green shirt right there. Yeah. Now on to the next. Right. But I'm literally sitting there doing the preceptor workshop. Yes, baby. I'm sorry. So too excited. We're out here. It's time to go. Oh, happy days.